about Ias One and about this event.
Thank you very much, Dr. Ravi Raman and all the seniors, faculties, and my dear colleagues. I am really thankful to Dr. Rohit Lal for arranging this meeting in such a short notice. In 2 weeks' time, he was able to arrange this. The reason being, we were supposed to conduct this event in Trivandrum, but today they have got some record on this very day. So that organizing secretary requested us, can you do it somewhere else? And Ranchi was on our cards because we wanted to hold event. Happened. And he said, in 1 hour, we'll just sort it out. Then in 10 minutes, I got a call from Rohit Lal, sir, that narrated him. So this IS1 is a brainchild of Dr. IPS Oberoi and Sachin Tapaswi sir. It is based on a concept of mainly a basic arthroscopy meeting of 1 day. Like we go to many conferences, a lot of stuff is being shown, and but the main behind this IS1 is to conduct in a tier 2 or tier 3 cities, and it should be a basic program and give a chance to the faculties on the platform. These are national faculties, and most of the faculties are from that region or local faculties, so that they get exposed to the Indian Arthroscopy Society. And usually, like basic talks only, no high-fi stuff, because the reason is so that many people they should take up career as an arthroscopy. Most of the things can be done arthroscopically, and knee arthroscopy is very easy to learn. So that's the main concept behind this. And thank you very much for accepting this on such a short notice. And like as Rohit sir said, like to get almost 50 to 60 people, because that's what we want. We don't want crowd of 500, 600 and all. So because the person who is interested to learn, they'll always attend such courses. Thank you.
We will start the first session. The chairpersons for this session are Professor Dr. Sudhir Kumar and Dr. S.N. Yadav. So I think they are giving us blessings from away only. But I invite Dr. Govind Gupta, sir, to please come over to the stage for his first talk, basic arthroscopy setup. Dr. Govind Gupta is presently the head of the Department of Orthopedics. I invite Dr. Govind Gupta, Medical College, to please come over to the stage for his
Thank you, Dr. Rohit, giving this opportunity, and I am also thankful to IAS for giving this opportunity.
Orthopedics. I invite Dr. Govind Gupta, Medical College, please come over to the stage for his
Thank you, Dr. Rohit, giving this opportunity, and I am also thankful to IAS for giving this opportunity.
Orthopedics. I invite Dr. Govind Gupta, Medical College, please come over to the stage for his
Thank you, Dr. Rohit, giving this opportunity, and I am also thankful to IAS for giving this opportunity.
Orthopedics. I invite Dr. Govind Gupta, Medical College, please come over to the stage for his
Thank you, Dr. Rohit, giving this opportunity, and I am also thankful to IAS for giving this opportunity.
Orthopedics. I invite Dr. Govind Gupta.
Opportunity, and I am also thankful to IAS for giving this opportunity.
Orthopedics. I invite Dr. Govind Gupta.
Opportunity, and I am also thankful to IAS for giving this opportunity.
Orthopedics. I invite Dr. Govind Gupta.
Opportunity, and I am also thankful to IAS
See the head in this opportunity. Dr. Deepik, I invite Dr. Govind Gupta. Opportunity, and I am also thankful to IAS. See the head in this opportunity. Dr. Deepik, I invite Dr. Govind Gupta. Opportunity, and I am also thankful to IAS. See the head in this opportunity. Dr. Deepik, I invite Dr. Govind Gupta. Opportunity, and I am also thankful to IAS. See the head in this opportunity. Dr. Deepik, I invite Dr. Govind Gupta. Opportunity, and I am also thankful to IAS. See the head in this opportunity. Dr. Deepik, I invite Dr. Govind Gupta. Opportunity, and I am also thankful to IAS. See the head in this opportunity. Dr. Deepik, I invite Dr. Govind Gupta. Opportunity, and I am also thankful to IAS.
So to start
Dr.
the
Deepik, I invite Dr.
setups
Govind
in your body
Gupta.
for the arthroscopy of knee and other joints. So what things we
Opportunity,
require?
and I am also thankful to IAS.
So to start
Dr.
the
Deepik, I invite Dr. Govind Gupta.
for the arthroscopy of knee and other joints. So what things we
Opportunity,
require?
and I am
So
also
the history is
thankful to IAS.
concerned, it is the important of
Dr. Deepik, I
father
invite
of
Dr. Govind
arthroscopy,
Gupta.
and he first presented his paper. The title was Endoscopy of Closed Cavity Using
Opportunity,
Microscope
and I am also
and
thankful to
Endoscope.
IAS.
And he performed
Opportunity.
arthroscopy of the
I invite
abdomen
Dr.
with his
Govind Gupta.
handmade instruments. Paper. The title was Endoscopy of Closed Cavity Using
Opportunity,
Microscope.
and I am also thankful
So
to IAS.
different equipments and instruments are required for the basic setups. First one is arthroscopy system and the arthroscopy instruments. So regarding the arthroscopy system, arthroscope, light source and cables, camera, video system, and sheath systems are required. So arthroscope is the heart of the arthroscopy system. It consists of long rods, which includes different lenses, and there is attachment for the fiber optic cable and eyepiece for the attachment of the camera. So factor should be considered for the selecting of the arthroscope is the angle of the arthroscope, viral length, coupling mechanism, diameter of the scope, image quality, and whether it can be sterilized or not. And the optical characteristic of the arthroscope is determined by the diameter of the scope, angle of inclination, and the field of the view. The diameter of the scope ranges from 1.7 to 7 mm. The 4 mm diameter is most commonly used for knee, shoulder, and hip arthroscopy. Children require less diameter, 2.7 mm is required. For the wrist, 2.4 mm, and for the ankle and elbow, 2.7 mm arthroscopy is required. So angle of the inclination, it varies from 0 to 120 degree. 0 degree arthroscope is generally not being used. Most commonly, we use 30 degree arthroscope for the knee, shoulder. And another is 70 degree is also for the posterior knee joint and the shoulder joints. Field of view varies according to the angle of the lenses and the type of the arthroscope. So wide angle makes orientation easier. So this is the field of view. 0 degree has less field of view as compared to the 30 degree. 30 degree rotates in 360 and makes the field of view 3 times as compared to the 0 degree. So accordingly, 70 degree has much larger field of view, but there is a blind spot in the center. Next comes the barrel length. The commonly used barrel length is 18 centimeter for knee, hip, and shoulder joints. With the shorter barrel length, it is difficult to do posterior knee joints. 11 centimeter barrel is needed for ankle and elbow. 10 centimeter barrel is needed for the wrist arthroscopy. Image quality should have sharp edges and adequate brightness. All the structures should be uniformly illuminated from center to periphery. And there should be satisfactory resolution to discriminate the finest surface details. So this first one is good quality, whereas in the second image, the periphery is not clearly visible. So every instrument should be sterilized before the use of inside the body. So arthroscope should be sterilized before each use. And if this is not possible, there should be at least high level of disinfection. Different methods can be used, ETO, autoclave, and in the last 2% glutaraldehyde can be used for the sterilization. Aging of the scope is manifested by murky and hazy image, and it is due to repeated use of the flash sterilization. But image quality may still be improved by boosting the light source. Then comes sheath system, trocar and cannula. It consists of coupler for the trocar and a scope, a spigot plane which connects the inflow and outflow tubing and the sheath barrel. The diameter of the sheath barrel for 4 mm scope, we need 5.5 to 6 mm. For 2.7 mm scope, we need 2.9 mm sheath. And for 1.9 mm scope, we need 2.2 mm sheath. So this is the sheath system having coupler, spigot joint, and the barrel sheath. A sheath should satisfy the following requirement: a scope fixed securely to prevent fluid leakage. A scope can be released quickly when it is required. A spigot plane rotates freely relative to the sheath, and the sheath remains static during a scope rotation. Different obturator and sheaths are there. Then comes light source. It is of two types. Cold light source, temperature is 4000 Kelvin, and the xenon light source, which is most commonly used, temperature is 6000 Kelvin. Light source is not switched until the scope is inside the sheath. Otherwise, it damages the skin, drapes, and the cables. So different advantages and disadvantages of both the light source. Cold is very little heat generation. It has longer lifespan and less illumination than the xenon, where the xenon light source is more heat generation, shorter lifespan, and more illumination with the wide spectral range. Then comes light cable. Two types of light cables are there: fiber optic cables, which is most commonly used, and it can be autoclaved, and fluid light cables. It conducts light 40 to 50% more efficiently, but cannot be autoclavable. Then comes video system. The basic elements are video camera units, camera, cable, and image processing units. Monitor should be 20-inch screen. Arthroscopic camera requirement should be ergonomic design, and there should be mechanism for coupling with the scope. It should have zoom feature, adjustable sharpness, and control unit for the white balance and image display. And it should have flexible cable. Then different instruments are required. So before purchase of the instruments, following things should be considered. The range of the indication. With the same instruments, we can able to do many things. Frequency of use, how it is needed for the purpose. Then potential for use in other joints. Can it be used for shoulder or knee? And availability of traditional surgical instrument with similar functions, so that you can cut your cost for the establishment. So different types of instruments are there: mechanical, motorized, electrosurgical, and special instruments and other instruments. There are certain features for the mechanical instrument. It should have uniform design consisting of jaw, shaft, and handle. Shaft can be straight curved, jaw can be straight or curved. Basket forceps or punch. These are different designs. And its use is cutting of tissue bridge, meniscus, scar tissue, loose cartilage fragments. Then comes grasper to grasp anything inside the joint. Its use are removal of loose bodies, meniscal fragment, cartilage flap, and retrieve the synovial biopsy tissues. Probes, it is the most important. It is the extension of the arthroscopic surgeon finger inside the joints. And it can determine the depth, identify loose structure, maneuver loose bodies for grasping, elevate meniscus, and probe fossa and recess. Arthroscopic scissor and knives. Previously, these instruments were used. Now it is being not used due to frequent breakage inside the joint. Then comes motorized instruments, and most important is saber. The component is control unit, connecting cable, handpiece, blades, and suction. So control unit with handpiece and foot pedal. Control has display with RPM, rotation per minute. Drive mode can be clockwise, anti-clockwise, and oscillating. Hand control, it can be controlled with your hand or can be controlled with your foot switch. For the cutting of the soft tissue, the RPM should be 1000 to 3000 per minute. For burying the bone, it should be 3000 to 9000 per minute. This is the instrument control unit with handpiece and paddle. Then comes saber blade to save anything inside the joints. And its tip diameter varies from 3.5 to 5 mm. Different types of saber blades are there: synovial resector, meniscus cutter, abrader, which has got rotating inner blade and may be smooth or serrated. Different parts of the saber: the grip, the joint part, the shaft, and the tip for cutting. Then comes electrosurgical instruments. And the purpose of this is for cutting or hemostasis. It consists of control unit, handpiece, and attachment with the electrodes. Different types are electrocautery, the purpose for hemostasis. Laser, it is for chondroplasty, but it is costly. Radio frequency, purpose for coagulation and cause tissue shrinkage. This is control unit, attachments, and radio frequency ablator. Different cannulas can be required: Wissinger rod for the posterior knee joint surgery and shoulder surgery. Different types of rasp and tendon stripper to retrieve the tendon for graft. Then come suture passer, suture retriever, knot pusher, different types of screwdriver. Then leg holders, shoulder traction system. So knee arthroscopy can be done in supine position with flexed knee at 90 degree or leg holding position. This is the leg holding position. Then comes pneumatic tourniquet. It provides bloodless field inside the joints. So it should be placed in the thigh, proximal third, as high as possible. Before inflation, it should be exsanguinated. Then comes distension medium to distend the joint so that a space for the visualize and the work. The joint must be distended to view a structure inside the joint. The criteria for the distending medium are, it should be sterile, no synovial irritation, it should be non-toxic and provides good visibility within the joints. And it can permit the surgery, low cost, easy to use, and the most commonly used is isotonic normal saline. Then irrigation system. It is the pump or roller pump has preset distension pressure, and it is the excellent for irrigation effect in complex procedure, but it is costly. The most common used system is gravity flow system. It is very low cost. So distension pressure can be increased or decreased by raising or lowering the level of the fluid reservoir. It should be suspended approximately 1.2 to 1.5 meter above the knee to produce adequate distension of the joint. Then arthroscopy card, different gadgets should be inside the card. Monitor can be placed, control unit, light source, drive unit for saver, and sterile draping is also required for the procedure. This is the OT of the rims. And this is the operating room setup where surgeon should stand, where the anesthetist, where your assistant, where the trolley, where your cart and the distension pump. Thank you very much.
Thank you, Govind sir, for a lovely presentation on the basic setup. I now invite Professor Dr. Sudhir Kumar has come. He is the chairperson for this session. Sir, kindly come over to the stage to bless us. Sir, please come over and give your blessings. Now our next speaker is Dr. Sandeep Biraris, Secretary of Indian Arthroscopy Society. He will be speaking on the clinical examination of knee joint, how not to miss any ligament injury, any meniscal injury, and how to have a good clinical examination of the knee joint. It is a very important presentation. Dr. Sandeep, please.
Good morning, respected chairperson, my dear friends and colleagues. So I'll be speaking on clinical examination of the knee. So when patient with the knee injury comes to you, usually they have mainly three complaints like pain, instability, or locking. These are the three main complaints which they have. So on the history, you should try and elicit that what's the mechanism of injury, because sometimes mechanism of injury can make you arrive at the decision for the diagnosis and management. And then you proceed ahead with the clinical examination. So when you are doing clinical examination, always look for any swelling, any bruise, or any changes in the alignment. Like in this particular case, you can see the patient had an injury almost 10 days back. There was a bruise here. Then you can see how sagittal alignment of the patient is changed. So it's very clear when you look at these pictures that something is happening in the posteriorly, that means some posterior injury, some posterior component, and like some dislocation or subluxation posteriorly. You can see femur and patella is little anteriorly, tibia is subluxating posteriorly. So you look for the alignment, bruise, and the swelling. Then next thing is the pathologies which you encounter very normally or commonly in your practice are ACL injuries, posterior cruciate ligament, MCL or posteromedial, or LCL or PLC injuries. So for the ACL injuries examination, there are three main special tests: Latchman, anterior drawer, and pivot shift test. So Latchman test is doing in a supine position with the knee in a 30 degrees of flexion. Pull the tibia towards you. So your left hand is stabilizing the femur. And here you can see this is the left knee. And with the right hand, you are pulling the tibia anteriorly. The similar way, next test is the anterior drawer test. Patient's knee is flexed at the 90 degrees. So once it is flexed at 90 degrees, examiner stabilizes the foot or ankle so that knee is stabilized, and then he gives forward pull. So both the thumbs of the right and left hand, they can make you understand how much is the translation anteriorly. So that can tell you if there is any subluxation, how much it is. Then another, so that can let you know what's the endpoint, if it is the soft endpoint or mushy endpoint or even hard endpoint. So depending upon that, if ACL is torn very visibly, you can pull the tibia anteriorly. The another test is pivot shift test. So this test is very painful. Sometimes you will not be able to do it in acute scenarios, but it can be elicited during intraoperatively. So where the patient's hip joint is abducted at 30 degrees, knee is slightly internal rotated and valgus strain is given. And you gradually start flexion from extension. And then you can feel that the tibia is jumping out. That means there is the pivot is shifting the knee joint. And then when you are extending, then it is subluxed. When you gradually flex, then it tends to reduce. So this is very much specific for the ACL tears. So when you look at this sensitivity and specificity, then the most specific test is pivot shift, and while most sensitive test is Latchman test. So these are the tests which can very helpful for diagnosing ACL injuries. Now, when you come at the PCL injuries, the test being posterior drawer and look for any posterior sag of the tibia. So this special test, like you can see here, that's the posterior. I'm just pushing you can see how easily it is subluxating posteriorly. And in these pictures, you can see there is a little sag as compared to opposite side. Then another test is make patient lie down supine, flex the hips and flex the knees at 90 degrees. And you can look from the lateral aspect and see if there is any sag which is visible. So that can also help you to know the PCL injury. Then in knee flexion, as I have just said just a while ago, so that's a sag sign. Now, when you come at the MCL injuries, so usually it is more specific when you do, it is 30 degrees of flexion. So you give the valgus strain at 0 degrees and again at 30 degrees. And sometimes if there is cruciate is not injured, then at 0 degrees, you might not see any opening, but at 30 degrees, you will see that there is a little opening. So you can see here. So that can help you understand the laxity and understand the endpoint of the test. So you can grade these like grade 1, 2, or 3, depending upon the size of the opening which you are eliciting. Then for LCR or PLC injuries, the most significant test is a significant test is dial test for the PLC injuries. Then for just if you are grossly examining the LCL, then the similar fashion what we did varus strain. So that's a varus valgus strain. Then that's a varus stress test, which is significant for the LCL. For even LCL, there is, you can see here, I'm giving little varus, then you can see it's opening and even subluxation of the knee joint. So another test is a dial test where, what happens. So you examine, make the patient prone, flex the knee at 30 degrees and even at 90 degrees. And you just rotate this ankle. And then you'll see, you can always compare with the opposite side. Here, there is the right side patient's left side, which is involved, so which is on the right side here. So you can see there is slightly more rotation. And sometimes when you look at the supine, you can see that's the patella and that's the tibial tuberosity. So that means dial test is positive. So that's in the prone position and that's in the supine position around 20 to 30 degrees. And you can see both are not in line. They are away from each other. So that also signifies you that there is a involvement of PLC or PCL. So there are other tests like mentioned, external rotation recurvatum test. Dial test is very much significant. If there is a 10 degrees involvement as compared to the opposite side, there is more external rotation. That means there is a positive dial test in that patient. And another test is a revert pivot shift test. So these are the various tests which are important for the cruciates. Now let us move on to the meniscus pathologies, which is another most common patient encounter. So it can help you know if there is meniscus tears, root tear, or there is a bucket handle tears. So sometimes these bucket handle patients, they do not have complete flexion or extension if the fragment is incarcerated into the intercondylar area. So the most specific test is a McMurray's test. So where, you stabilize the patient's knee, then you rotate the ankle and you can put your other side palm on the medial aspect and thumb on the lateral aspect. And then gradually you rotate, give valgus and varus strain. So that helps you in getting patients' symptoms. So like when you are flexing the knee, externally rotating the tibia and giving valgus strain and patient feels pain, that means you are creating a vacuum on the medial side, patient feels pain on the medial side, that's the MCL, medial meniscus torn. And when you do the exactly opposite, you open on the lateral side and patient feels pain. So that means click, that's the lateral meniscus. So this is a very significant test for the ACL. Another test, very difficult to do and very difficult to isolate for academic purpose, Aplis grind test. Patient is made supine, you give thrust onto the sole of the feet and give slightly internal and external rotation. That can also help eliciting the pain, but usually it is not required just for the academic purpose. Then there is another test where you distract the joint in the similar fashion that earlier grind you are compressing. Now please distraction test. I do not have experience. I never do this type of test in my practice. Another test is like Thessaly's test, where patient is made to stand with a slight flexion in the affected knee on a single leg, and patient is asked to just turn on either side, and they get pain depending upon which side is giving pain. That meniscus is said to be torn. Thank you very much.
HDMI doesn't. Just 5 minutes back, Rohit told me that portal talk. I think Ashish is on. Ashish should not come, so I will be talking on knee arthroscopy portal. It's a very short presentation. I think it's very important for SR and junior residents who are present here for them. And welcome SN Yadav sir, Sudhir Kumar sir. आ गया? So it's very important. So whenever you are planning for your knee arthroscopy portal, always mark your knee. This is very important aspect. And most of the time, try to mark on your patients pre-operatively and try to identify the soft spot. When you are doing a knee arthroscopy or shoulder arthroscopy, if you cannot identify the soft spot, if you cannot make your portal right, it's very difficult to work in this small area. So try to mark it in patient. Sometimes you can mark it on your own knee. Try to palpate the soft spot on your own knee. Posteromedial and posterolateral portal, I think that is the best way. So I will start my talk knee arthroscopy portal. And we have 4 standard portal: the anterolateral, anteromedial, posteromedial, and your supralateral portal. These are the 4 standard portal. And we have optional portal also, which is needed as per the requirement of the surgery. the posterolateral portal, the proximal mid-patellar and medial and lateral portal, accessory far medial and lateral portal, and central Gilchrist portal, which is to the your patellar tendon. So this is very important to know the anatomy of the knee. And if you can see here, the laser mark is not working. This is your patella, quadriceps tendon. This is your patellar tendon. So your anterolateral and anteromedial portal are close to your patellar tendon, and try to make it as high as possible. And this is the standard practice we follow, because if you make your portal low, you have to struggle to the fat pad, which is there present just in behind your patellar tendon. So this anterolateral and anteromedial portal try to make as close to the patellar tendon and try to make as high just towards the lower border of the medial and lateral aspect of the patella. Now the posterolateral and posteromedial portal, of which the posteromedial portal is more important. It is a soft spot in between your semimembranous and your medial head of the gastrocnemius. And you can palpate 90-degree flexion of the knee. Just palpate, you can palpate this soft spot. All of you can palpate there. All of the residents, you can palpate this soft spot there. And the best way, suppose sometimes it's very difficult once your fluid is inside the knee joint, it's very difficult to identify that soft spot. So transillumination is the best technique. Put your scope in the posteromedial compartment and you see the light there, and then you can make your posteromedial portal. And try to put your needle towards the intercondylar notch. This is very important. Don't try to go put your needle transversely. Then you can hit your popliteal vessels. So arthroscopy, whenever you are planning for either a knee or shoulder arthroscopy surgery, yes, you need a portal. And the success of arthroscopy surgery depends upon perfect placement of portal. And why it is important? So it is very important because you want to have a clear visualization of all the structure. It is very important. If you make your portal properly, you will have a good illumination inside the knee joint. You have to use your instrumentation because you have very less space in the anteromedial, the posteromedial, the posterolateral compartment. So if your portals are wrong, you can't use your instrument properly. And whenever you are planning for your standard anteromedial and anterolateral portal, avoid fat pad and soft tissue of the joint, and avoid some important structures which are there, damaging this important structure also. So this is very important. And to achieve all this, we need a basic knowledge of anatomy, and skin marking is mandatory. So whenever you are starting your arthroscopy, basic arthroscopy practice, don't miss skin marking. And this is very important. So mark your patella, you can see, and medial border of the lateral border of the patellar tendon, the medial border of the patellar tendon, mark your medial and lateral joint line, and now mark your anteromedial and anterolateral portal. Here you can see this anterolateral portal. This is the lateral border of the patellar tendon. This is the lower border of the patella. Just 1 centimeter lateral and 1 centimeter above the joint line is your classical anterolateral portal. Anteromedial portal, medial joint line, you can see just 1 centimeter medial, just close to your lower border of the medial border of the patella. This is your anteromedial portal. And these are two standard portals. Try to mark it properly before you put your fluid inside, because once your knee is inflated, you will not get all these anatomical landmarks. Then mark your lateral joint line, mark your medial joint line, and mark your tibial diversity. And I always mark on the knee. This is the lateral side. This is your medial side. Either you can write on the superior aspect of the patella, or you can write on the proximal part of the tibia also. This is the lateral part. This is the medial part. And these markings are very important. And whenever you have markings, so in surgical setup, you can see this is the marking. This is your patella. This is your equator of the patella. You can see your resident. Then this portal is through the patellar tendon. That is your Gilchrist portal, central portal. So some of us prefer doing the arthroscopic ACL reconstruction, or sometimes some of the people try to go for prefer it for the PCL reconstruction. Also, when you are planning for the anterior horn of the repair of the root of the medial or lateral meniscus, the Gilchrist portal is very important. The classical anterolateral and the anteromedial portal, the suprolateral and the supromedial portal. And here is the soft spot. You can see this is the medial part of the knee. The 90-degree of flexion, you will, when you put your scope to the anterolateral portal, you will see the light here. And when you see the light here, that light comes from the window in between the semimembranous and the medial head of the gastrocnemius. And try to pass your needle towards the posterior part of the medial femoral condyle, and that will make your posteromedial portal. Again, medial joint line, lateral joint line. This is the medial view. You can see the medial border of the patella, the equator of the patella, and you have two portals here. the medial portal, and you can see the accessory medial portal. Accessory medial portal came into action when we started anatomical ACL reconstruction. So whenever you are targeting, you are firing your drill bit over the medial surface of the lateral femoral condyle, if you fire it to the medial portal, it's oblique. But when you fire it to the accessory medial portal, it's perpendicular. And this is very important. And second important thing is that when you are making this portal, it's very close to your medial femoral condyle. So always do under direct visualization so that you are not scrapping or you're not doing any damage by your beat pin or by your reamer to the medial femoral condyle. Again, the lateral part you can see, sometime for PCL, you need a far lateral portal. For far lateral portal, usually we don't make it regularly. And this is your lateral portal, and this is your far lateral portal. Sometimes you have to make central portals also. You loose body is there in the supralateral or supromedial aspect of the patella. So you have to make a supralateral and a supromedial portal, a small skin incision there, and then you can remove those loose body through the supralateral or supromedial portal. So this is a small outline of how you make your portals. So mark your patella tendon, mark your patella, mark your median and lateral joint line, and then mark your medial and lateral portals. And do it, practice it regularly before starting your shoulder, knee or shoulder arthroscopy. Thank you so much.
Thank you, Dr. Rajiv Raman, for a wonderful presentation on portals. Although this talk was allotted to Dr. Ashish Bajaj, but he could not make it today. Our next speaker is Dr. Shomudeep Datta, and again an important topic, how to read MRIs. चला दो. शिफ्ट कैसे होगा? ये वाला होगा शिफ्ट, ये वाला नीचे नीचे वैसे शिफ्ट होगा.
Thank you, Dr. Rohit Lal and whole team for giving me this opportunity and organizing this wonderful event. So first of all, let the presentation be there. So MRI should not be the first thing we'll go look for a knee surgery or even shoulder surgery. The most important part of your examination is your clinical examination. As Dr. Sandeep has beautifully told, you have to go through your clinical examination. First, you come to a diagnosis and then go for an MRI and then see the MRI. Don't go for juniors. And I will always say that first, don't go to see the MRI because that will give the MRI report will give a impression of your mind that that diagnosis is that, but the diagnosis may be entirely different. So it is very important. Back, go to the first slide. Thank you. So, okay. Okay. So that's why I was talking. So before jumping to the MRI, always go for a history, how the injury has happened, because it's a high velocity injury, low velocity injury, then that makes your diagnosis. You are maybe dealing with a multi-ligament or you are dealing with a single ligament, and thorough clinical examination. You have to examine all the ligament as a standard. You always do your C for ACL, PCL, MCL, meniscus, and all the things. So the main things of an MRI is that we take 3 cuts in 3 planes, your axial cuts, your coronal, and sagittals. So, and there are some technology, T1, T2. So always remember this slide that T1 is like this and T2 will be much black. And there are some in special, if you want, there is STIA or fat suppressed sequence. So this is a difference between non-fat and fat suppressed image. Until and unless in a normal MRI, you don't ask for it, they don't give you. So this is T1 image. T1 image is good for loose body fracture, osteochondral defect, and T2 images, PD are good for bone marrow edema, and non-fat suppressed are good for meniscus, ligament, and cartilage images. So mainly our diagnosis part in a ligamentous injuries, mainly you have to look for T2 images rather than T1. And there is some software also. If you can do if you have a good radiologist friend and you refer them, always try to get a CD or a soft copy. You can see in your laptop or computer to see this, and you can zoom them out and see this. This is a software. There are numerous softwares available in the market, and it's most of them are free. So first of all, what are the things you have to see? First is meniscus. So meniscus tears can be, it's a normal, it's can be grade 2, grade 1, grade 2, grade 3. So there are different types of meniscus classification. One is a longitudinal tear. It could be a radial tear. It could be a vertical flap. It could be a horizontal flap, or it could be a horizontal tear. So coming one by one. First one is longitudinal vertical tears is like a can opener lesion. You can see the pictures in different planes. It looks like different. It's parallel to the long axis of the meniscus. It divides meniscus into two central and peripheral part. So in an MRI, in different frames in axial cart or in other carts, so it looks like that. If a picture is like that, that is a longitudinal vertical tear. And longitudinal horizontal tear is like divides meniscus into a superior and inferior part. It's very common in more than 40 and in a arthritic knee. And there are sometimes it associated with a parameniscal cyst. So like that, it's longitudinal or horizontal tear like divides meniscus into superior and inferior. And sometimes this is there is a small cyst associated with them. And this is a parameniscal cyst. And it's very common in a degenerative knee. And radial tears are like your pizza cutter. So it goes from peripheral perpendicular to the free edge of the meniscus. So this is a classical radial tear. You can see this is a classical tear, and root tear is nothing but an extension of a radial tear. It is the anterior posterior root been torn up. It is called a root tear. So it is a posterior root avulsion, just a small video. You can run the video. The getting a soft copy is that you can go through these one by one, go forward and back. This you can see the posterior root is torn here. So some tears are not, you cannot classify them that the complex tears, some horizontal part, some vertical part like this. So there are some displaced radial tears like these parodic tears are also can be seen. And another is a bucket handle tear. We often see this bucket handle tear. So there is a very important thing. It's often asked. This is a double PCL sign. It's a classical telltale sign of a bucket handle tear. In the posterior part is mostly, if it is in the anterior part, it is called a double delta sign. This is the classical telltale of a bucket handle tear. So coming to the ACL, you have to be, there are different types. It could be acute, hyperacute, chronic, or it may be partial tear, complete tear, or it may be a avulsion tear. So you have to see for signal and the course of the ACL and the ligamentous discontinuity. So coming to a grade 1, grade 2, grade 3, I'm not going to the details. Grade 3 is a complete tear. So it's a, like you see this, there is some intrasubstance tear. So it's a grade 1. You can, in a good quality MRI, you can only appreciate this kind of tear. Sorry. Grade 2, there is discontinuity or changes in the direction of the fiber. So it's a grade 2 tear. And grade 3, you cannot see the ACL, completely empty ACL. So you cannot see the fibers are being jumbled up in around the tibia. So it's a grade 3 tear. So there may be a partial ACL tear like that. We all know that ACL has a 2 bundle AM and PL. Sometimes in a good quality MRI, you can appreciate that anterior bundle or posterior bundle is gone. So then you can see that it's a partial tear. Like this is in this MRI, there is only the anterior medial bundle is gone, but the posterolateral bundle is intact. Always see for the the orientation, because ACL is not a vertical structure, it's an oblique structure. So always see the continuity on the and the orientation of the fiber. If it is maintained, that is your ACL is intact. If it is not, there is some tear. So always see the lateral wall. If the lateral wall had the ACL attached to the femoral condyle, if it is empty, that means your ACL is not intact. So there is maybe a secondary sign if if the tibia is translated anteriorly, so more than 7 mm, that means your ACL is not intact. You see, and draw a line from the posterior condyle of the femur, and there may be a secondary sign. Sometimes a buckling of the PCL in a high-grade ACL tear is also seen. It's also a sign of a high-grade ACL tear. PCL is always a clinical diagnosis. Don't always remember this, that PCL is not only an MRI diagnosis, as told previously by Dr. Sandeep. You have to see the PCL, do that PCL test. And if you cannot see the fiber, can either see, sorry. So see that there is tibia is subluxated posteriorly and the fibers of the PCL is not seen. So that is a classical of PCL injury. So coming to the PLC injury, we know all the 4 structures of the PLC injury. So there is a small video. You can, video is not working. Video ta chala. Video. You can see this is you can see the posterior, this is a posterolateral injury. You can seeing through the slides one by one. You can see the cuts. You can see this is the medial side on the left hand side, and there is a on the right hand side, there is a fluid collection on the femoral side. Forward. So you can see the bony contusion there, and the femoral part, there is some avulsion, but on the medial side, it's more or less intact. So thank you. This is always that take home message is that MRI is not substitute for a good clinical practice. It or doesn't compensate for a bad clinical practice. So always go for all the cuts are important. You have to see single cuts. You don't jump to a diagnosis and then come to the another cuts before come to the conclusion, and always read in a sequential manner. Thank you all.
Thank you, Dr. Shomadeep, for a lovely presentation on MRIs. Now we want to go live for the surgery. I invite Professor Dr. Sudhir Kumar to please come over and felicitate the speakers. Dr. Shomadeep, please come. So we want to hand over the certificate and a small Jharkhand memento. So this is the Dokra art, ancient way of casting, iron cast. Thank you. Now I invite Dr. Sandeep Biraris to please come over. Sir, please stay. Next. Please come and Dr. S.N. Yadav, sir, to please felicitate our Indian Arthroscopy Society Secretary, Dr. Sandeep Biraris. Thank you, sir. So a word of thanks to Dr. S.N. Yadav, sir, because he has given us 2 cases today from his practice. And the first case which we are doing in multi-ligament is from him, and another one ACL which will follow after that. So we will go live now. The rest of, just a minute, Dr. Rajiv Raman, please come. Sir, please felicitate Dr. Rajiv Raman, the man behind this event. ये हर स्टेट के सेक्रेटरी यही है. एक मिनट सर, और एक मिनट प्लीज सर. Dr. Govind Gupta sir, please come over to the stage. Sir is now the head of the Department of Orthopedics in RIMS, very supportive for this conference, and he was the we will go live and वो लोग सुन सकते हैं हमारा बात. Dr. Sundarajan, please elaborate. Moderator of this. Sundarajan sir, can you hear us? उनको माइक नहीं दियो क्या? प्लीज कम. शोमुदीप. हाँ, हम लोग यहीं से बात कर रहे हो. एक माइक वहां दे दीजिए. So in this patient is a lady, 40-year-old lady, and she has a multi-ligament injury in her knee. Dr. S.R. Sundarajan examined the patient in the morning, and he was of the view that if we do PCL first and then ACL, the patient will be absolutely fine. There is little strain on the LCL and MCL, but we need not bother about them. So we are, I think,
Okay,
going ahead with
inside. No, inside.
Hello,
Inside.
Sundarajan sir. So Dr. Soumudip here from the hall.
It's okay.
Can you hear me?
Put the wire inside. It's okay. Switch on the mic, please. Quick. Mic on.
Yes, Sundarajan sir. We are live. We can see you.
Okay, so no. Just now we had the mic. Sorry to this
Okay.
thing. So
Sir,
this is
please
case
tell
of
about the patient. Patient and the clinical finding and what you have done so far.
So this patient had a multi-ligament injury, happened almost 12 days before. She's a lady around 35 to 40 years old. And she had a actually we had a pre-recorded clinical video. I don't know whether they can display the video. It's a case of medial invagination of MCL. It's a nice case to show the irreducible dislocation.
Okay.
Okay, so we had we pre-recorded it. Hopefully they can show it relive again.
Okay.
Can they show the clinical exam? Clinical exam.
Show it later. So you go with your surgery.
Okay, so what we had that whole medial capsule. Okay. Medial, you can see here.
Yes, we can appreciate on the
Yeah,
medial.
that was almost. Can you give me the probe? What? Probe. So what we had in the finding, once you put the scope inside, we could see the whole of that this tissue which you saw now. It was it was rolling over here and like
Okay.
this. From the posterior to anterior, it was locked inside the joint. Okay. So
Okay,
what we could do that we put a probe, we put a grasper, we could reduce it by bringing the knee into extension. With the flexion, you cannot reduce it because you have the space obliterated. Once you do the extension and medial side opening, then we could reduce here. Okay. So later on, we do open and do the repair of MCL after finishing the PCL and ACL. So this is a case of PCL, complete ACL, and very unstable joint because it's only a 12 days old. Here we can do two way. You can just do a medial meniscus repair, come back in a two-stage procedure. We can do as a PCL and ACL in the second stage. But here probably we are decided to do in a single stage. What we are planning to do on a PCL and the ACL, and later on, once we finish the PCL, we do the open MCL repair. Is it fine?
yes, sir. So what will be your graft choice, sir?
So already we have taken the peroneus longus for the PCL and hamstring from the opposite side because this side is the MCL injury. So we didn't want to take a hamstring from the same side. So we took it from the opposite side. It's a very, very thin lady. So we got around 8.5 length of peroneus longus with the triple, and they are preparing the graft now. Then I will let you know the size of the graft. Okay.
Okay.
Sir, are you repairing the meniscus?
No, the meniscus looks fine. You can see that.
Okay.
All the meniscus looks good. So most of these cases, you will get only the meniscus will escape because they are not getting locked. The dislocated whole MCL is torn. So fortunately for us, that meniscus is fine, completely fine.
Okay. So
Once you do the MCL repair, it's good.
okay, perfect.
So So this is an unstable joint, as you see. Abhinav and Anup Nair is assisting me and helping me. Hope they will help me. Leave the water.
They will help you, sir.
Okay, and one more thing, sir. What is the sequence of reconstruction you are doing?
So we are planning to do a PCL first because once you do the PCL, the joint will get stabilized. You know what I mean? That when the joint is now it is completely empty here. You can see that intercondylar notch.
Yes.
So that is completely empty. So just we started 5 minutes before. Anyway, you came in live, so that's good. So we'll just go ahead with whatever. You can see the remnants of the PCL here.
Yes, we can see the remnant.
So whenever you low velocity injuries, always you will see a lot of PCL fibers. But unfortunately, because this is a high violent injury and completely the PCL has gone, there is no fibers anywhere here. Okay. So this is a completely empty notch sign. That is the PCL attachment from 12 o'clock to the 6 o'clock position, whatever this thing. You can see that there's such a long, big incision of the PCL. But we are not going to do a double bundle here. We are going to do a single bundle medial PCL reconstruction, and we are going to put a ACL here. That is the footprint of the ACL. You can see the nice ACL footprint here. Can you see that?
Yes, sir. We can see.
So you can see. I will show it again. That is the so that is the tibial footprint of the ACL, and we will prepare the PCL tibial side footprint. So my first suggestion will be the first preference will be to do the tibial sided PCL preparation and tunnel. Okay.
So the sequence would be PCL first, and then what do you want to?
ACL.
And then are you doing something for the medial collateral ligament?
Yes. You have RF? Please with RF. And it's okay. If you have cannula, we can use the cannula. This is the posteromedial portal. Actually, here we can see because already MCL is deficient here. Everything is ruptured from the femoral side, I believe. So it is easy to make the posteromedial portal. Can you see that?
Yes, we can see that.
Beautiful.
Yeah. So
that is coming from the posteromedial portal.
So this is the posteromedial portal.
So that is the posteromedial cannula. That is a 7 mm cannula. Okay. So here, even when you have both PCL and ACL deficient, you will be able to see the most of the footprint of the band. Do you have a band? Yeah, so we are going to use some van to prepare the PCL footprint. Meantime, I will use the shaver and you will be able to see here. So that is the tibial side footprint.
Yes, we can appreciate, sir.
Can you see that? Yeah.
Yes, we can appreciate the footprint. You are clearing
Yeah.
the debris there.
When you hold the cannula, yeah.
So your shaver is now in
Remove the cannula bit.
posteromedial portal.
Yes, you can see that.
Yeah, we are.
Yes, yes.
Very
Yes.
well.
So
Beautiful.
because whenever you have the PCL and ACL is deficient, it is easy to come from the post. You can see entire tibial footprint from your
Yes.
anterolateral portal itself. Okay.
Very
Here-
nice view, sir. Very nice view.
Yeah.
Thank
So
you.
we don't need to prepare too much here.
Yeah.
And so that is the lateral condyle, that is the medial condyle, the whole center depression, what you see the footprint of your PCL.
Yeah, beautiful. Very nice.
And you see always the blade should be facing the tibial side, not on the opposite side, because this kind of injuries will have some capsular injuries. Because a lot of capsule, you can see there is no capsule at all. Lot of capsular injury here. Do you have one? The
Yes.
other way of preparation is you can use the do we have the foot pedal for the van? It's okay.
No,
Is
no,
it yellow or?
it has a hand button, I think. Okay.
Sorry? Okay, yeah. Thickness 8, yeah.
Sir, how far posterior you will go from that articular margin? 20 mm.
Yeah, at least 1.5 to 2 centimeter.
Okay.
So this patient is a small patient. So if you get 1.5, it's good. We can see that is the end of the footprint.
Yes.
You don't need to go too much there. And you could see the most of the footprint I could see. So
Yes.
probably I will make the tibial entry point now. Is it okay?
Yes,
So
okay. We can appreciate the
I'm going to,
posterior aspect of tibia.
what did you have? You have Arthrex? No? Okay, so I will change my scope to my posteromedial portal. Only thing is we don't have two cameras, we have two TV. So usually I work on the with the two. Can you move slightly this side? Yeah.
So did you get the jig, Arthrex jig?
Yeah, we have. No, this is the tibial side, no? Sure? Yeah. The only difficulty what I'm having here is that I have to see if I am. Can you move a little bit the other side? Yeah. I don't get the orientation. Yeah, now I get it. Because it's everything is floating knee. Okay.
Yes.
Can you see the?
Yes, we can see the jig.
Yeah, you can see that is the tibial. You can
Tibial
almost 16 mm. Can you, Anupna, can you make incision on the medial side? Bigger incision. Don't worry about the support the tibia somebody. Abhinav, support the tibia. Make a bigger incision. So make sure that you go between the center of the tibia, not too close. Or can you? 1 minute. I want to see the entry point. That is very important. Yes. Can you see that?
Yes, we can see the.
I could see. I want to see like this. So before I enter the, yeah. Are you okay? Yeah, that is in the center of the tibia, not close to the patellar tendon. No. Okay. So that is very important because Anup Nair is taking care of that. Can you drill it? Yeah, I'm watching. Don't stop. Keep going. There, stop. Okay.
Yes.
Can you see the entry?
Yes, we can appreciate the breed pin.
Yeah. So that is the advantage of seeing through the posteromedial portal, so that we are safe. And can you give us some scoop for the protection? Do you have some scoop? PCL scoop. Yes, that is nice instrument. Take this off. Take the jig. Yeah. Can I see that?
Yes, we can see
Print?
that.
And so I'm using the scoop here. Because we can see the footprint itself so small. Okay. The graft is only 8, which you could get a peroneus longus triple standard, 3 standard. That is enough for her because it's a very, very small joint. Are you going to ream 8?
8 mm graft on both the side, tibia and femur.
Yes, yes.
Okay.
Good. So normally when I have it, usually we'll have a PCL around 10, isn't it? So usually I start with a smaller reamer, but here support the tibia well, please. Don't push the tibia. Yeah. In 1 minute. 1 minute. Is the water is coming? Water is coming. Water over, no. Come on. Is there? Please change the water. We are not able to see. I think the water is over. Have we crossed that? Yeah.
Any question from the floor? So anybody can ask, especially the juniors.
Which scope did he use? 30 or 70?
Sir, which scope you are using? 30 or 70?
30 degrees scope.
30 degrees.
Yeah. 1 minute.
In a 30-degree scope, we were able to see all the things. In 70 degrees is not needed actually.
Go. We have the. Yeah. Okay. 1 minute. 1 minute. Yeah. Just do it in the hand. Do it. Roll it with hand. Just come out. Yeah. Do it again. Yeah. It's okay. Just come inside. Come inside. Come inside. Come. Don't. Come. Come. Hey, come.
And do you consider making posterolateral portal anytime?
Sir, do you consider
Hold this.
lateral portal or a transeptal technique? Do you do? So Delhi, someone is asking.
You sure you are gone out of the far cortex? Yeah. Where did he go? Okay. Okay, take it out. Yeah, that is a. Yeah, because it's a very small bone.
Yes.
Yeah, take it out. There is a small fragment here from the condyle. That is fine. Okay, because its footprint is so small.
Yes.
Okay. So we'll take it later. No problem.
So there is a question. Do you do any transeptal PCL ever, or you do? This is.
I do with only one portal, posteromedial portal.
Okay.
Whenever I do the PCL avulsion, then even that case, no, let it be. Even in that case, we use the one high anteromedial and low high posteromedial and the low posteromedial.
But never the posterolateral one. You don't.
I have not started. Many people are doing that. I have not done. There's nothing wrong. That is also a good option to do the because you are having a both sides view, which is not you don't need to get instruments crowded when you do with two portals from the medial side. That is fine. So I'm going to make a low anterolateral portal here now.
Okay.
Okay. For my PCL entry point.
So what will be your entry point? You will do outside in drilling.
I will do the inside out.
You will do inside out drilling, and what will be your landmark for footprint on the femoral side?
Yes, I'll show you. So I'm trying to clear the fat pad bit. Give me a shaver. That is very important when you make an inside out. So I have to clear the fat pad first. Okay, so that you don't need to struggle. Whenever you do an ACL, PCL, don't worry about removing some fat pad. so that you don't need to struggle with your visions. So you are able to see the entire footprint here.
Yes.
Apart from
That
footprint.
is the PCL. Can I see that?
Yes, we can see. Appreciate the
So,
whole footprint of PCL.
so our entry point is going to be here for the anteromedial bundle.
Yes.
Okay. So this is going to be your posterolateral portal, which is a smaller posterolateral bundle, which is smaller one.
Yes.
And anteromedial is the bigger one, which is the one which you control your vertical translation from the posterior side. Okay. Can you see that?
Yes, we can see them.
Yeah. Can you give me one 11 blade?
So, sir, what is your criteria to do a double bundle PCL or a single bundle?
Whenever I do the isolated PCL, where I don't need to do too many grafts,
Okay.
you know, so there we can make a double bundle. So then I do the outside in technique like what you talked about.
Okay, sir.
Otherwise, mostly I use inside out, so that is quicker and saves a lot of time.
Okay. In double bundle, you will do a single tunnel in tibia or two tunnel?
Single tunnel.
Single tunnel tibia, two tunnel in femur.
Yes, yes, correct. So here the plan is to have the, here you can see, can you open up the water and close it, the suction? So water is coming. Can you hold the reamer? Yes. Can I give the shaver? Otherwise, water is not coming. Water is not coming. Yeah, and do you have a tibial plug? Do you have a plug for the tibia? No, you don't have. Okay. So also good idea to have a plug for your tibial side. Once you prepare the tibial side,
yeah.
Some people usually prepare the femur. Yeah, you can prepare the femur and come to the tibia also. That is also a good option because if you don't have the plug. Now you can see the footprint here. Okay. And you see, I'm using a reamer to keep it in the center of the footprint so that you don't violate your, this is almost 7 mm. This is, what is the reamer size? 8. So I'm using the 8 size reamer. So my graft is going to be like here. So put the guide wire.
So, sir, it is how far from the articular margin? Cartilage margin?
Just close to the articular margin. Just close to the.
Close. Okay.
You can, if you want, I can, 1 minute. Maybe I can show them. Okay.
And what will be the position of the knee?
You can see the articular margin now. So that is the articular margin. Maybe I'll clear it a bit. 1 minute. Sorry. Shaver. You close the tibial side. One of you please close it, so that I will just clear the soft tissues a bit, so that you can see it better. Okay. Now you give me the.
Yes, we can see it.
You can close the tibial side.
What is the flexion of knee? It's 90, I believe.
Flexion of the knee, position of the knee, how much flexion?
Around 80 degrees, 80 to 90 degrees. Yeah, you can see now.
90 degrees flexion.
Yeah.
So how important is it to follow the landmarks in PCL surgery?
Yeah. Okay, go. So you can see that we are close to the articular margin as high as possible. 1 minute. I'm not, hope I'm not too low. Take it out. 1 minute. Take it. 1 minute. Work already done. It's okay. Yeah, go ahead. Go. Support the tibia, somebody. Yeah. Gone? Okay, leave it. It's okay. Yeah. Yeah. So you can see, can you see now? Appreciate that it is not very close to the articular margin because we need to put a 8 mm reamer there. Okay. 1 minute. I will change the scope. I will change my scope to the medial side now. You come this side so that I don't damage the scope. Okay. For the entry point, I make it through the high anterolateral portal and the low anteromedial. I made an entry. Yeah. Now we are using the 4.5. Go ahead. We are using the 4.5. We're planning to do an adjustable loop, which go ahead. Go. Gone.
You will do a endo button here, sir. Plan to do a endo button.
I'm using
a screw.
I'm using adjustable loop. Yes. You can use a fixed loop or an adjustable loop. Always people concerned about the adjustable loop for the PCL. Correct? No. Then initially when the even for the ACL, we used to is 30, almost 32. Okay, guide way.
32 is the whole tunnel length.
Yes, 32 is the tunnel length.
So how much graft you will be planning to be there? So what is your graft length, sir?
Around 18 to 20 maximum. Because it's only a 30. Because as I already told about, it is a small size knee. So you know now why I changed my scope to the medial side, because you cannot do with the high anterolateral and the low medial portal, because it will be crowded and you'll be breaking the scope. So once I made an entry point, I changed my scope to the medial side so that you are safe.
So how far you will drill, sir? Yeah.
We are planning to slight flexion. Is it slight flexion? Yeah. Enough. Hope we are not touching the condyle. You can see that. So that is very important. Is it 8 mm? Yeah. Not really. Wait, it is in the forward. Hope it is in forward. Huh? Forward, huh? Maybe it's a little blunt. You want to give a 7 or something? Give me the 7, then we'll go to the 8 maybe. Maybe it is a little blunt. Seven, 6, something. Below some serial reaming. This is the forward only, no?
Graft 8 mm diameter.
Yeah, only 8 mm diameter. What we got the peroneus. You can see it has gone to almost 18, 15, and that is around 18. Excuse me, 8.
So there is a question from the floor, sir. Is 8 mm is sufficient for this patient? So
For the PCL, the
Yes.
PCL better always have at least a minimum of 9.
okay.
Here we accepted because that is the thickness what we got even with the triple standard peroneus. Second thing is, as I told, this joint is very small joint.
Yes.
Okay.
Okay.
I think you are changing the position. That is.
Posteriorly, how much down he went?
No, hold the scope.
Yeah.
Flex the knee. Maybe? Yeah. Correct.
Sir, do you ever augment the graft in this situation of using any internal brace?
Take it. Okay. So okay. You want to put this. Okay. Sorry. What is the question?
There is question from the floor that ever you augment the graft, like if you are in this scenario to get the diameter more with the
Augment the-
internal brace.
Internal brace? No, I don't do it.
You don't do it.
Huh? Femur, jig. You have jig, no? Yeah. So what we do now, I will go ahead and do the ACL. I will just show the tunnel now.
Okay. Yes, we can see the tunnel.
Can you see the tunnel?
Yes.
So, okay, that's good. You can see that we are not violating the articular margin here.
The medial condyle cortex is not maintained.
Not violated exactly over where we wanted. Okay.
Yes.
So we will do do the ACL tunnel in the femoral side. Okay.
Okay, sir.
As I already told here, you see the nice footprint of the ACL. You don't need to struggle here to find the space. The always problem here when you do a multi-ligament injury, you have a, okay. So we have the offset. You can see that?
Yes, we can see
Nice
the,
offset. You should not come too low. It will be very anterior, and I want to go little higher, not very higher, but you can see the still entire footprint. There is a high margin of your footprint.
yes.
Okay, you don't need to go like this. So you have to be exactly within the footprint. Go ahead. So we flex to 100 and some more flexion. Enough. 110 degrees flexion. Go ahead.
So you are drilling from the accessory portal, or you are drilling from the medial portal?
Same portal. You can use some far medial portal here. Not required. All everything is very small joint. And if you see, if you can see the outside view, which I want to show.
Yes.
If you can show the outside view of your my entry out,
Yes, we can see that. Knees flexed,
exit point of your guide wire. Okay, go ahead with the. What is the size of the ACL? 7 or 8.
What is the diameter of the opposite CBT, sir?
Yeah, 7 in the femur and tibia 8.
7 in the femur, tibia in the length.
ACL.
And length, sir, what is the length?
7.5. Okay, so ACL, what we have got 7 in the femur.
Okay.
7.5 in the tibia. That is very good for this patient because the graft was so thin.
Yes,
Now,
sir.
because a small patient. So you have to accept that. Don't try only minimum size 8, which is not required for this patient because the size of the patient is so small. Sometimes if you try to put a too much graft also, when the small notch, you will get a impingement, you will have a stiffness, you will have FFD. So better. Yeah, you can show the outside view. Can you see the outside view?
Cameraman, please focus. Yes, we can see the outside view. Cameraman, please focus on the outside knee.
Take it. What I want to show that that exit should be in the middle of the thigh. That means your entry point is perfect. Can you show that?
Yes, cameraman, please focus. Yes, we can see now.
Yeah, probe. And if the same exit point instead of here,
yes,
if it is here, that means you are making a more vertical graft. If you are coming too posterior, that means it's a low and anterior.
Okay.
That means this is also one of the another clue that your entry point is correct or not. So this is, you can see it exactly in the middle of the thigh. Okay, and it should not come here. It should not come here also.
Yes, it's a very important point. It should be in the middle of the thigh.
Length of the ACL.
So what is the length? What femoral tunnel length, sir?
We are going to have around 2.20 or 22 because we have a length is around what is the length of that? Now, what is the length of the tunnel we measured for the? We are not measured.
So we are drilling down the 4.5.
Now I want to measure the. How much is that? Not measured, huh? Okay, take it out. It's okay. We can measure again. Better we do not take a risk. Okay, you see the length is around what we got. No, this is over the skin. 30. Okay.
30.
Yeah. So we are going to put around 20, 22 like that. Sorry.
A small tunnel.
Yeah, that's why I told this patient is very small. Okay. So don't imagine like a normal patient, small female, thin built female. That's why we accepted 7.5 like that. Okay.
Yes.
If it's a bigger patients, naturally you require a. Here also I'm going to use the same adjustable loop. We have almost gone to 23. Okay, that's fine. So we require a minimum of 7 mm from the far cortex. If you are using the 1 minute, I want to clear and show the tunnel. Take it out. We can put it again, no problem. It's going to give me the shaver. Take this drill off. Take this drill. Just I will show the tunnel.
Sir, what is the length of the graft?
Length of the graft is 8.
8.
Because we put a 5 strands here.
Okay.
Because I thought of putting a quadruple, but its length is very short, so we put a 5 strands. Can you see now the,
we can see the tunnel? We can see the tunnel.
Okay, that is the posterior cortex. Exact where we wanted.
Is intact, so
and you can see the exact footprint of the ACL. This is a small joint. That's what I kept on telling that. You can
Yes.
see that exactly over the center of your footprint of the ACL.
Yes.
Okay?
Yes.
Is it okay? Okay.
Yes.
So
Perfect.
now I will make the tibial tunnel. Can you give me the knife again? 23 blade knife. So you will make a bigger incision so that you don't struggle for your ACL entry point. 23 blade. So don't worry about making a bigger incision because you want to see your PCL tunnel and you want to see do the ACL tunnel.
What is the minimum amount of the wall should be kept in the posterior part of the tunnel?
Hold this internal notation. Where? Sorry, come again.
There is a question. So how much you can posterior cortex should be posterior condyle or posterior part of the tunnel should be kept
For the
So-
femoral side. What was the question?
So in the femoral tunnel, so how much bone should be kept to be intact?
Yeah, at least 1 or 2 mm. But when you,
Okay.
because you are using now all the adjustable loop and hamstring graft, you don't need to worry about the blowout little bit. 1 or 2 mm blowout doesn't matter. But better to have it in the safer side. And so because the joint is very unstable here, so you have to try to close slightly internal rotation and do the posterior. You can see the now
Yes,
stop.
we can see that
Can you
is a
give me the
big
probe?
footprint.
Probe. Slightly push the tibia anteriorly. Yeah, that's fine. That's fine. Yeah, good. Thank you. Can you show the? Can you see the footprint?
Yes, we can see the tibial footprint.
That is the tibial footprint. That is the anterior horn of the lateral meniscus. That is the posterior border, and this is the anterior border. And you see the stump is just corresponding to that. Okay. So you want to make an entry point almost this level. Okay.
Okay, sir. There
Are
is
you
no
happy?
PCL, so your meniscus is the guideline there.
Yes, yeah, meniscus, and we have always footprint here.
Yeah, footprint there, so it should be in the center.
Yes. Okay. So that should be fine here. So don't come too lateral, and so you'll have a slightly on the medial side. Okay.
Okay.
Yeah. Drill. Yes, go ahead. Yeah. This is elbow. 1 minute. Sorry. Take it out. Take it out. Take your gun. I want to go slightly inner side. Remove the procar bit. Yes. Yes. Go ahead. Because that was too anterior.
Yes.
Okay. So I want to go slightly posterior. That's why I changed my jig because I think it's an elbow. Go.
Elbow aiming.
Elbow aimer. Okay. Go. Don't stop. Yeah. You can see that?
Yes, it's a perfect.
Yeah. That's why I changed my my jig to slightly posterior so that it's an elbow aimer. So if
Yes.
the tip aimer, it's correct for that old point. Because it's an elbow aimer, I changed it into the slightly posterior.
It's perfectly in the center of the footprint.
Yeah. Can I hold it? So you are going to do 4.5? Is it 4.5? Just you want to show for the youngsters, if you want to do a serial rimming is better. Yeah, if you are confident enough, you can use directly 8. But just we'll use a 4.5 first.
Okay.
For
Then
the
we'll go for 8.5.
Yeah, then we'll go 8.5 because for the idea is that give the guide wire now. Guide wire. The idea is that guide wire, please. Guide wire. Yeah, give us some other guide wire. Whatever it is. No. That is the entry point. That is the femur. No. That is the for the PCL. Retractor, somebody?
But do you see impingement after putting the guide wire in the tibial tunnel?
Okay, give the artery now. Artery. So the idea of putting the 4.5 first, so that put 8 now. 8 mm. 8, yeah. Oh, 8, 7, sorry, 7. Yeah, 7, yeah. So you can see
Yes.
So the idea is that you can move the your 4.5 this way, this way. You can direct it. So even if entry points, you can go ahead. Even if the entry point is slightly wrong, you can adjust. Go ahead.
And play with your.
Play with your guide pin. So we have done the job now. Take it out. So can you give me the grasper with the wire or suture retriever with the wire for the to pass the tibial side first? So well, what we'll do is we'll do the PCL graft first, and wire, thread, some threads for the PCL.
So
Both
we'll
sides.
pass the PCL graft first and then ACL graft.
Yes.
And fix the tibia, first fix the femur for the PCL.
So we pass the graft PCL first, then I pass the, because anyway you are fixing in the femoral side.
Okay.
Okay, because it's an adjustable button. And then we do the fixation later. I mean, once you pass both the grafts, then you fix the tibial side PCL, then you fix the ACL.
Yes.
That's how, I mean, there are many ways, there are a lot of controversies. When you are doing a PCL fixation here first, you have to be very careful, okay?
Of course.
Because you can sublux the tibia more anteriorly, and you can fix it in anteriorly subluxed position. So you have to be careful intraoperatively. Because here joint is open, I can easily bring it like this. But otherwise, normally you take it through the posteromedial portal. Then no, that means what I meant was you put your instrument through the posteromedial portal, go down, take the thread up, and bring it through this portal. But because the joint is open, very loose here, we no need to do that extra step because everything is open here.
Yeah.
Okay.
Make your things easy to play with. Otherwise, you have to play a lot of with your killer turn.
Yeah, correct. So you can take this and put it in the PCL. No. Can you? This is the pass in this. We make a single one. What happened? It's okay. Now I want this has to go in this. No. Hold the scope 1 minute. Hold the scope 1 minute. Yeah. Pull it. 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 Stop. So it has got stuck there. Hold it here. Somebody one of you hold it there. Pull it here. It got stuck in some fat pads because it's a different entry point. Hold it tightly. Is a fiber wire or ethibond? Oh, I like to have a. It's okay. It's okay. 1 minute. The soft tissue is gone. 1 minute. It's okay. Can you give you the suture retriever? No problem. Leave it. Suture retriever? Yes, sir. This suture retriever? Yeah.
The most difficult part.
I'm going to do it again. It doesn't matter. Okay.
Yes.
So instead of wasting time, okay, leave the femoral side. It doesn't matter. Okay, give me the pin again. Pin passer. With pin with the hole. Yeah. We do it again. It doesn't matter. Okay. See that?
Yes.
So it will not take much time for me. Yeah. Hold this. Which one are you loading? Which one is you are loading? Why are you loading? No, load this, man. Load this. Load this. Directly. So normally I do this way only. I take it from the tibial side, everything in a single shot. Yeah. Take your hand. Yeah. Okay.
Okay, sir.
Okay.
You can see the.
There you have some steam and
going from tibia to femur.
Yes.
And
so when you do an inside out, so I took it through the low anterolateral portal where I made an entry point. So you have to go through the same thing. Do you have some rod for the PCL passage? You have some rod for the PCL passage. Okay. So what we are planning to use is that always use this rod. I use always steam and pin because this can bend. Anyway, it's a Rohit's trucker, I think. I'm not bothered. Even it's get bent.
You are going this from the posterior medial portal to
Hold this.
help your graft passing, isn't it?
Now, graft is passing through the tibial side, it will come through the opposite side.
Okay.
You tied it. Tie it, man. Make a knot. Oh, okay. I know everybody is doing in a different way. I'm having a Raju Raman's assistant. So he got confused because Rajiv is doing, I think he might be doing a more elegant way. Huh? Oh, yes, sir. Okay. Okay. That's fine. Put the graft. So I will pass the graft now. Remove it, everything. Yeah. No. Be careful. No. I want to make sure that you have enough space here. Huh? Okay. Okay. Pull it. Pull the graft. No, don't bring your hand close to the. Right. Go. 1 minute. No, don't worry about it. You pull it. No, don't worry about it. Pull. Come on. Pull. Pull it. That's why I like to use the fiber wire, not the ethipon. Okay, so that it can get caught. No. It has come. Take out the threads. No. Yeah, take the threads, man. It's okay. Take the threads. You don't bother about it. It will come off, no? Which way? Hey, no, man. One. Take one by one. No. You take the first. No. See, hold this. Or else I will do it. Hold this. 1 minute. Sorry, 1 minute.
Okay, sir.
No. Correct. Okay. All has come up. Yeah. So now it's fine. So we have an ultra button from the Smith and Nephew because he told me to tell the name. Sponsored. Otherwise, Rohit has to pay from his pocket.
They have given a big clap, sir, for you from hall.
Okay, so we are pulling the.
Yes.
So he is using the pulling the green thread, which is for passing the button. We can see the button is going in the tunnel. We have to be careful. Hold the button. Don't go to pull. You have the mark. The mark has got slightly. That's okay. No problem. You go some more. You flipped. Hold this. Now hold the steam and pin. Hold the steam and pin here. Somebody.
It's very
What is
important to
this?
see the
No,
mark.
that's gone. Go. Some more. Yeah. Now it's slip. Leave it. Okay. Now, okay. It's flipped now. You see the mark.
Yes, it's
And
matching
also
the
it
mark also.
And and you can see the button.
Yes.
Leave it. Now don't pull the button. Huh? No. Take this hand off. Your hand off. Yes. Now it's. Huh? Okay. Now pull the graft. 1 minute. I'll use again the rod. So to avoid the killer turn, always use the steam and pin so that the delivering the graft will be more easier. Okay. Yeah. Go, man. Pull.
Yes, we can see the graft going.
Yeah. 1 minute. Yeah. Go. That is the mark. I think I made it.
Mark with the white pin. So
yeah.
it's around 20. So
18. It's marked only 18. So it will go only 18. Go as much as possible and lock it. Over. That's all. Okay. Lock. Pull tightly. Tighten it. Okay. It's fine. That's okay. It's okay. So can it be the bead pin for the ACL? ACL bead pin. Flex the 1 to 110 degrees. Yeah. Can I give pass the white? Sorry. Careful. Pin.
Okay. Now we'll pass the ACL graft.
Yes, I will pass the ACL graft. Then we can fix the PCL tibial tunnel and yeah, hold this. Have enough? Okay. Yeah, it's okay. It's okay. Can you give me the grasper or suture retriever, whatever you have? Yeah. Suture retriever will be better. Yeah. Okay. Okay. Ready for the ACL graft?
Okay.
Somebody said support the
Sir,
tibia.
how much graft will keep in the for the ACL in the femur?
For the ACL?
Yes.
ACL we have around 2022, I think. We reamed around 2022 because we have a lot of length because it's a 5 stance graft.
Okay.
Hmm.
So what is the minimum amount of graft should be kept in the tunnel? 15 or 20? So what is your take?
No, the
on
minimum
that?
required is 15 is enough.
15 is enough for the,
Yeah,
for
yeah.
the
Studies have shown that 15 is enough. But anyway, we are scared to put on a 15. So we get at least, we plan to put at least 18. Okay?
Okay.
Okay, go ahead. Go ahead. Go ahead. Go ahead. So you can see that ACL graft is going.
Yes.
That's the button. Go ahead. Go ahead. One more. Pull, pull. Okay, leave it. No. Go. Go. Okay, leave it. Leave it. Okay. Take the graft. White. So for the youngsters, the white thread which is holding the, you can see that is the fiber wire of the, wire on the graft. So he is pulling only the white threads. Support the tibia, somebody please. Go ahead. Go ahead. Come on. Come on. Water, 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 water. Pull, pull, man. Pull it. Yeah. Pull it. Gone? Okay.
Yes, graft is going. Yes,
Yeah.
you can
So
appreciate
there was no water. That was a problem. Support the tibia, please. Yeah, yeah, like this. See, show it like this. See now, it's better.
Yes.
Yeah, it's good.
Gone into the tunnel.
Correct. So, where is the PCL? We should have put a different color so that it will not. You can see that is the PCL.
Yes.
That is the ACL. Okay. And
Perfect cruciate, cruciate reconstruction.
Yeah, so you can see that the tibia is not. So you need to fix in this position and internal rotate. Yeah, internally rotate, and we should not subluxate the joint too much anteriorly. That is very important. You can, so maybe I can show it. Hold this in both the hands. Hold this. So if you try to pull the PCL, you can see the joint is subluxating too much anteriorly.
Yes.
Okay. So you have to be careful that you are not pulling too much anteriorly. Clinically, you can put a finger here. You see the, I don't know whether you're seeing the outside view. Outside view should be a 1 finger depression from your medial femoral condyle for the tibia. So that gives you another clue that otherwise, if you have doubt, always put the scope and fix it like this. Okay?
Okay, sir.
Are you happy?
Wonderful surgery, sir. Wonderful.
So I will fix
Very nice surgery, sir.
Thank
Everybody is appreciating.
And I'm going to fix the tibial side of the PCL first. Then we fix the ACL. Then we open on the medial side, do the MCL repair. Okay?
Okay, sir. So what will be the knee position for PCL fixation?
There's the same 80 degrees knee flexion. The same what you are seeing out. I don't know whether you're seeing the outside view. We got around 80 to 90 degrees. That's fine.
So what is the diameter of your screw?
The screw which I'm going to use here, usually I am going to put my awl and see if it is tightly fitting. I go for one size more. That is 9 into 35. Or if it is a little loose, then I will use a 10. One size more or 2 size more. But usually I use the that is the ACL. No, leave it off. Yeah, put the artery here.
So do you use a double fixation in tibia or a single fixation in tibia for PCL?
The double fixation, the tibial side always. I use an extra button for the additional fixation, the tibial side. Femur, sometimes if the graft is very loose, I put a screw.
Okay.
Otherwise, I don't put a screw on the femoral tunnel side. Okay. So we are planning to. Can you? I'll come to the. Can you hold the scope on the one hand, and so that joint is not subluxed. So Abhinav is going to hold the scope to make sure that we are not shifting too much anteriorly. Hold this. Leave it to me. Give me the all and the retractors. The here depth gauge. And somehow one of you can retract.
Right angle.
Depth gauge.
Yeah.
Can we have the outside picture?
Outside picture. So you can come through the scope on the posterior portal. You can visualize and fix it up. Okay. So here I'm not doing because I want to see the joint is not subluxing. So that's why I kept the scope there. How much is the measurement? Can you see? Anybody can read that? Top light, please. Top light. 1 minute.
So we
Top
want
light.
to see the outside picture. Somebody is standing in front
Top
of
light
you.
on. I don't know. Yeah.
So,
Oh, no. 40. See the 40. The you can see the whole size of the tunnel itself only 40-42 tibial side. Normally you get around 65 to 70. Okay. Here we have only 42. And if you see and you can also see through the put a scope and see where is your graft. You can see that.
Yes, just in the mouth.
My
of the
graft
tunnel.
is not far away from my outer cortex.
Yes. It's
Okay.
in the mouth of the tunnel.
So yeah, so I'm planning to use the 30 size screw guide wire. 9 into 30. 9 into 30, I'm going to use it. And Abhinav is going to show the joint. Yes. So the joint is not like this. So I want this position. I don't want too much anterior. 9 into 30, please.
How is he ensuring that joint is still not subluxating?
That's why we are seeing no through the we are seeing the articular side view. You are not seeing the arthroscopic view.
No, we are not.
Oh, we are. You can see Abhinav is holding the scope,
वो भी दिखाइए.
and he is showing me the joint.
Yes, we
Okay.
can see the joint.
Yeah, but we are seeing anteriorly, right?
You are seeing the arthroscopic view, no?
Yeah, we are now.
Oh,
And
don't-
we need to look further.
So there is no problem. You can even if you are not correct with your position, you can always remove the screws and change your. Sorry.
Any specific
Pull it
point
in rotation.
that
Pull it in
the joint
rotation.
is still not
Like this.
subluxating?
Yeah. Please hold it.
There is a step sinus that has been explained.
Clinically, you can.
Yeah, you can palpate the tibia and the femur, and you can see.
Leave it. Take your hand. Okay. Leave it to me. Yeah. So you want only this position, okay? Not too much. Can you see now?
Yes, you can see. See the joint.
Yeah. Can you see the
Video is
intraarticular
now.
view? So you can see, I didn't subluxate the tibia anteriorly. This is a very important step because when you do a PCL, ACL, always they are very unstable. What we have done is that you see once you fix the PCL, the joint is completely in the center now. You see the ACL is in center, PCL is okay. Your joint is not subluxed, perfect here. So this is what most important when you do a PCL, ACL. You should not do that. And also see the outside view. Can you see the outside view?
Yes, we can see the outside view also.
So you can see that I'm pushing. Can you see that? And also
Yes.
you can see the intra-articular view and also outside view. Okay.
Okay.
So that is perfect. So I'm going to fix the ACL now, and I'm going to take the camera out. Fix
So
the
what is
tibia.
the position of the knee, sir, for the ACL fixation?
For the PCL, I kept it for the PCL. You see, I was seeing intra-articular view, and
Yes.
my Abhinav was holding the tibia internally rotated, and I didn't ask to give any anterior dryer at all because somebody was asking me. I told no because you see, without If you go 90 dryer, the joint will subluxate. That support the tibia. Here. Put your hand like this. Yeah. So
And
we are
what-
going to fix it tibia. ACL and around 30 degrees.
Okay.
Retractor.
And position neutral rotation or
Neutral rotation.
neutral rotation?
No. Can you retractor and show the outside view, please? Can you see the outside view?
Yes, we can see the outside view.
Yeah. All. You have guide wire. So give the same 8 into 30. Yeah. What do you have minimum? 25? Do you have 25? 8 into 25? 8 into 25 is fine. Enough. Yeah, please give it.
So,
Here 8 into 25 is enough because a small tunnel.
so your diameter is 8.
Here 7.
Seven.
Sorry, 7.5.
7.5. So you are using a 8 mm screw.
Yeah, because you see the graft is very nicely, snugly fitting.
Okay.
So there is no gap between that. So I'm using you can use the same size or one size more. I'm using one size more.
Okay.
Can you give me 8 into 25? Or if it is, because 8 into 25, not there, huh? Just a moment, we are waiting for the screw. 8 into 25, if it is not there, you can give a 30. There is no other option. Now open it up. So we are 8 into 25? Yes, sir. So okay, we have 8 into 25.
Okay.
Yes.
Sir, what is the screw?
Sorry?
Which screw you are using?
Is a Smith and Nephew. Smith and Nephew screw.
HA coated.
BioSure.
BioSure.
Can you give me a small knife, 11 blade knife? So when you make, can sometimes screw, if you don't clear the soft tissues, no, 11 knife, 15, whatever it is. If you don't clear the soft tissues, nibbler, can you give me the nibbler, please? The screws will not go inside. Sometimes if you are not having if you don't clear the entry point, okay?
Okay, yes.
You see that is the PCL tunnel, that is the ACL tunnel.
Yes, two tunnels should not be, there should be a bone bridge in between. It's very,
Always
very...
so that will not collide because your PCL you are using a 65-degree jig, and here you're using a 50 or 55. And second thing is your PCL is going 1.5 centimeter below the articular surface. So totally there are different trajectory screw. It doesn't matter.
So, sir, do you ever use a disc or any kind of that kind of fixation, or always you are using screw for tibia?
Tibia, I use mostly screw only unless I previously I used to do some all inside technique. Then in that case I use a button. Otherwise, I don't require. But sometimes when you use the short graft, like when I do a semi-T with post stand, if suppose the graft is short of your length, then you put a screw, then I add a button also outside.
Okay.
That's enough. Okay, you can see that now?
Yes, perfect. Knees.
I will put a scope.
Can you do can we have a look at the stability on the medial side now?
Yes, you will see that. So that is the PCL, ACL looks good. You can see the joint nicely. You see the joint is not subluxed. Support the tibia. I'm going to open up the medial side. You see the medial side, how much it has closed now?
Yes, medial
Okay.
side.
But still, we are going to open and do the repair because it's a grade 2 to 3 opening. Okay.
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 So it's going to be a open surgery. So can you give me the 23 blade? Can you come this side? Anu? Take everything away.
Okay, thank you, sir. We will start the next session.
Yeah, sure. No problem. Thank you, Rohit.
Come back to you when your medial sided surgery will done. We will see the final.
In 5 minutes, we'll come back.
No, take your
I
take
want
your
Dr. Somudit Dappa to
23 blade.
come over to the stage and felicitate Dr. S.N. Yadav for being the chairperson and for being the support of this event.
3 blade. Yeah, let it. It's okay. Retractors. Forces. Ready the rupture the femoral end, and just we'll put as a sleeve. Usually they will stay very well. Can you give us some triple loaded metal anchor you have? Double loaded only. Okay, give the double loaded metal anchor. Open it up 5.5.
So that is the
tibial side piece MCL.
MCL repair.
So only
Primary repair of MCL.
like a sleeve avulsion. So you see the suction. Can you give me the open suction? Can you put
this is important, an open surgery for all. Let's
please open the 5 mm, 5.mm metal screw, double loaded or helicoil, whatever you have. If you're expensive, if you're not bothered about money, give a helicoil also. I don't bother. It's a live surgery.
Sir, we are back live because all of us want to see the medial sided repair because that is very uncommon.
No, it's not a tibial side. No. It's not a tibial sided retractor.
Medial.
We are talking about, we are live, sir. We want to see the medial sided repair. Please explain about the incision.
Retractor.
Keep it going.
What we did we just extend the same incision, slightly curvy incision here.
Okay.
Normally, what you do when you planning for a repair of MCL, even for this incision which you made it for our tunnels, we can make more oblique tunnel like this, so that you can just extend the incision like this.
Okay.
Here we made it slightly more vertical, but still I made a slight curved incision on the medial side here. Okay.
Okay.
And take out all the artery. You can see that is the tibial side MCL. Can you see?
Yes, we can appreciate the MCL fiber.
That is the pes serious sheath. Okay. Yes. Pes serious sheath. You can see the underlying that white tissue here.
Yes.
Can you give a probe or forceps? One more forceps. So why I didn't want to take the hamstring, because already it's an MCL sided injury. Okay.
Yes.
If you want to take a hamstring, then you will be damaging the entire pes serious sheath here.
Yes.
Oh, that is a good. We require a good medial stability. So that's why we didn't want to disturb it. And we can see the underlying white tissue. Can you show me? Can you see that?
Yes, we can see the white MCL.
Yeah, that is the tibial sided MCL. So I think for the people who knows that it's a tibial sided MCL is around 6 centimeter from the tibial articular surface goes and attached down. So that is okay here. Okay, but you see the femoral side. That is the that is the ruptured fibers. Can you see that?
Yes, we can appreciate the fiber ruptured.
All this.
Cameraman, please zoom in, if possible. Please zoom in.
And can you give in a, actually from this side it will be a very nice view. But anyway, Alice forceps. Is the AC on, or I don't know the switch of the AC?
So what is your plan? Putting an anchor there and repair it?
Yes. Can you see here?
Yes, we can see that.
It's like a sleeve avulsion. Okay.
Yes.
It is a very easy to repair. One of the easiest MCL repair what you can get it.
Okay.
And also for the life surgery. So I can escape easily. Okay. So what I'm planning is that put an anchor. It's a double loaded anchor which I'm going to use as a metal anchor.
Okay.
You don't need to search for the footprint for the entry point, because already you have a footprint here. You see that?
Yes, we can see.
That is the MCL footprint. That is the medial epicondyle which I'm able to palpate. Mallet.
So, sir, what is the diameter of the anchor?
5 mm. Mallet.
5 mm diameter metal anchor. Single loaded or double loaded?
Double loaded.
Double loaded. So 5 mm double loaded.
I prefer to use triple loaded.
Okay.
The Smith & Nephew has got a double loader, but it's a nice purchase. Can you see? I don't know whether hear a sound.
Yes.
Yes,
A nice sound.
So where do you put the anchor?
at the foot.
Sorry,
What is the position that in the epicondyle or?
epicondyle, and you have the entire footprint here. You see
Okay.
our that is our button for your PCL. Can you see that?
Yeah,
Yes, yes. Yes, we can see the button also.
Yeah, so you don't need to worry about the tunnel collision, all those things, because everything is open here. And you can see that you have already needle, that's good. So you see I'm pulling it, it's holding
Yes.
it good. So we are using this anchor has got a needle, so I no need to struggle with the give forces, please. So can you see that remaining sleeve here?
Yes.
Okay. So you can see that I'm going on you don't need to do any disruptions here at all. Next one, hold it here, and I'll leave this here, all here. So just take your 4 bites.
And it's a good prognosis it is having among the MCL, isn't it? This type of repair.
This patient will have a very good stability also, because this sleeve avulsion usually heals very well. I think all of us know that anything at the femoral side, medial sided injuries, they heal very well. Tibial side, they may have a poor prognosis. So anything on the tibial side, better to do an augmentation with a CBT graft. Or if you are having a internal brace, that is also okay for an acute cases. Of course, anything which is a little bit chronic, better to use the better to cut the needles. Now and also get free needles if you want. Okay, can you have a 30 degrees flexion and varus for the repair? So what do you support the posterior tibia? One of you. You can take hold it, support. Just
what is the position of the knee when you tied the
yeah, so now we have a 30 degrees of flexion. It's a superficial MCL and slight varus.
30 degree of flexion with a slight varus, you will tie the knots.
Yes, yes.
Dr. Sundar sir.
Yes.
Good morning. Dr. Layak, Jamshedpur.
Hi, Layak, how are you?
I am fine. Thank you. Seeing you after a long time. So
That's
what I was asking is that, in the multiligamentous injuries,
yes,
what is the ideal time for fixation?
Any multi-ligament injury,
Go for
you have to knee has to be quiet. Like a ACL, you want the knee movements to be around 80 to 90 degrees to prevent postoperative stiffness. Okay? Even it's an acute, unless it's a vascular injury or an open dislocation or an irreducible dislocation, that's like this case. Okay?
Okay.
Then you had to do a open, otherwise not required.
So suppose someone wants to go for a, multi-stage.
Yeah, you can do even, that's what I told in the start of the surgery.
Okay.
Here, what you can do, you can open, do the medial sided repair, then come back, get back the knee movements after 4 to 6 weeks time. Then you go and do the PCL, ACL also, it's fine. I don't do that. You can do it because only thing is you require a 2-staged rehabilitation which you require. That is the only disadvantage of doing a 2-stage procedure.
Okay. Thank you. See you in the lunch.
So just I will show you now how much stable it is. We will see. That is the extension. That is good. The 30 degree flexion.
It's stable now.
Very stable. Very stable.
Very nice.
I will put a scope and see. Can you do the?
Cameraman, put the inside picture.
Can you support
Inside picture.
do the extension?
Yes.
Can you see that?
You can see the picture. Yes.
Can you
It's
see that?
completely, the gap is
It's
completely
a 30
obliterated.
degrees flexion, and I kept a valgus opening. Can you see the outside view?
Yes, yes.
Very good. Very good.
So that is the advantage of this femoral avulsion. It's like a sleeve avulsion. They heal very well with just to do the repair. This patient has got a completely stable knee now with the complete MCL repair and PCL and ACL. Okay.
Perfect, fantastic surgery.
Thank you,
Beautiful.
Thank you,
fantastic.
sir.
Thank you,
Thank you.
thank you.
Thank you for the wonderful demonstration.
Thank you.
Thank you very much. Thank
Thank
you.
you very much, sir.
We
So
do
I
a-
now invite the chairpersons
One
for
more
the next session.
You have a suture
Gurudev,
post.
please come over to the dais.
What do you have?
This is our meniscus section.
Washer, huh?
And, Dr. Govind Gupta, sir.
What otherwise? You have suture post?
Dr. Gurudev has been kind enough to come from all the way from Patna to
You have suture
do a
post with some
surgery.
drill?
He has a live
What is
surgery
the size of the suture post they have?
today. And
The suture
he's
post.
doing a very good work in Patna,
Okay, you give the button. What do you have?
Universal Hospital.
Thank you, boss.
Okay, open it up.
Guru of multi-ligament reconstruction.
We'll
He's
put it over there.
Guru.
And tie it.
He's an expert on multi-ligament, and you must see his
This is the
videos.
perfect time to intervene this patient. Okay. If it becomes late, then it is very difficult to manage the
stiffness.
medial collateral.
Correct. So our first speaker is Dr. S.N. Yadav, sir. He will talk about meniscal tear management, how he does it.
It's okay. Put two on either side. Take the artery. And somebody can hold the artery. Don't push the tibia too much down. No, you are pushing too much. Leave it. Okay. Leave it. That's good, huh? Okay. Knife. Hopefully it will be all right. Yeah, that is very important. Yeah, that is the important step in the doing this surgery. Yeah, multi-ligament always a challenge. Yeah, sometimes there will be a big vent here also. So what I do, I repair it and take the same thread I used to repair here. But this layer is intact here, so I didn't do anything. Here after that only muscles are there. You can take 1 or 2 stitches if you want one vehicle, or else you can leave it. Yeah, you can close.
Good morning, everyone. Respected chairpersons and delegates.
That's all.
It's a very wonderful program. Thanks, Ias, and thanks, Dr. Rohit, who brought this.
I'm using everyone.
TV.
I use tight rope.
We are lucky enough that we
also I
got
use
such
ultra. I
cases.
use.
You could see everything in one case. All repair, ACL, PCL, and.
What is that? Check off button. Mistake of us.
So I'll talk on
Most of the time, it's only our mistakes. So we try to put the blame on company.
Meniscal is a really very important structure. In the year 1997, Meniscal described as a functionless remnant of intra-articular leg muscle at blind certain. Biomechanical function of meniscus, spiking, 1936. Meniscus plays an important role in knee stability, load distribution, joint lubrication,
Picture.
joint nutrition, soft
Take that
tissue,
photo, camera.
arthritis
Photo.
repairs.
There is a phone is there. No?
The
Phone.
incidence of meniscal tear is quite common among sports activity persons. Common cause of meniscal tear is increased rotational force on the knee,
Photo.
habit stepping, squatting on an uneven surface. Treatment options are conservative and surgical.
Take the.
Conservative treatment, those who want to know meniscal repair, they must go
Here.
for beginner.
Take one with hand.
Do diagnostic.
Yes, yeah.
First, lot of cases.
One more. Second. Yeah, one more.
Damage the inside structure by your saver
light.
or scope. So conservative management is good for those cases in the white zone.
Thank you.
A surgical
Thank you.
management
Thank you. Thank you.
is
Thank you, everyone.
meniscectomy or repair.
Thank you, Anup. Thank you, Vinod.
Meniscectomy increases the
Thank you,
incidence
sister.
of osteoarthritis of the knee in the later stage. So all efforts should be made to preserve the meniscus in order to protect the knee.
Already gone there, huh? Okay.
Conservative, small,
Thank you.
degenerative and asymptomatic tears.
Can remove the mic.
What is aim? Aim is to generate a common consensus in
Sandeep
meniscal
Karro.
repair management. Goal of every arthroscopic surgeon to comprehensively treat meniscal pathology. Acquaintances with the tools and facility of meniscus repair. So what is the anatomy of meniscus? Meniscus is a C-shaped structure which is very firmly adhered to your tibial component. Periphery is a, thicker side, and as you go to center, it's a white zone. So red joint is a good part for the meniscal repair. Then come red and white, and then white zone. This is red, white, and white. Clinical presentation: pain, swelling, effusion. This is the knee injury, presentation, locking, instability in the meniscal injury. And most of the time, associated injury are ACL patient. So you saw this case. On examination, joint line tenderness, McMurray test, apply gradient test. These are the common tests you have to perform before surgery. This is a O'Connor classification, vertical and horizontal tear. And vertical, this is classification longitudinal, radial, oblique, and complex. What age? Factors affecting management: age, duration, activity level, type of tear, location of tear tissue, quality. What affect the prognosis? Tear factors: location, vascular zone. As I said, red zone is very good for meniscal repair. Tear size, tear pattern, injury acute or chronic, concomitant injuries, alignment stability, patient age, BMI activity. This is the final separate repair graph that is very easy, and it's so everything how to repair and when to repair. This is a final separate. When you get a red zone, an acute, chronic, or it's a very good part to repair. 1.5 to 4 centimeter is the area which give you good prognosis, good result. Then red, white. And as you comes down, the white zones, probability of repair is it's not good. Repair best result in location, red is ideal. Red, white is in between gray area. You think so repair, or you think for conservative also. Time acute 8 weeks better than with ACL repair, reconstruction. Morphology, as I said, 1 to 4 centimeter. Vertical and longitudinal tapers. Age is better if it sports person less than 30 years. Meniscal repair principle: reduce the tear wall, repair it well by debridement. Good approach: use accessory portals, stitches perpendicular to tear. These are the users points how to repair and how you get better result. Enhance healing by fibrin clot or vascular challenge. I am working on fibrin clot. I am doing my own work. But after some time, after 100 cases, I'll present with fibrin clot. I am making fibrin clot myself, and I'm using meniscal repair, having very good result, but it will take some time. Customized for each individual tear. 2 associated ligament reconstruction. Contraindication for repair: degenerative tear, older patient more than 60 years. Avascular white zone is not good enough to repair. Complex tear are not good enough. Stable income tears for meniscectomy. Patient unable to follow strict non-weight bearing protocols. Infection or RA cases. In longitudinal vertical repair, this is the diagram. Inside out technique, how I am doing. Outside in or all inside. All repair, inside repairs in the posterior 1/3. Inside out, tears in posterior and middle 1/3. Outside in, anterior horn, anterior 1/3, and body of meniscus. Arthroscopy view is showing the technique of all the inside meniscal repair and posterior horn tears. Arthroscopy view is showing the technique of outside in meniscal repair in the capsular attachment zone. This is inside technique, inside out. Lasso used. See this diagram, how this double lumen inside out cannula, and this is meniscal needle, 18 gauge spinal needle, and you should give you a good result. Horizontal cleavage tears, old patient, posterior horn, dissection of unstable leaflets, all inside circumferential compression stitches. This is radial tear. As I said, the perpendicular tears, stitches are very good, excellent for Laprade two-tunnel technique. Root tears, root classification, Laprade's classification, type 1 is partial root tear. This is a complete tear, complete root tear, oblique tear, and root avulsion fractures. Transtibial pull-out repair of a medial meniscal posterior root tear in right knee. Techniques for avascular zone, parameniscal cerebral tissue flap, preface of peripheral meniscal rim and suturing, creation of peripheral access channel, tissue injuring, MSC, allogenic cells, human embryonic stem cells. These are recent advances in meniscal transplant, but we haven't seen these cases. This is a recent one, so I just put in this talk. Acceptable procedure for younger patient less than 50 years. Has pain in femofemoral joint, cartilage loss on arthroscopy, and contraindication in case of grade 4 arthritis, flat femur condyle, osteophytes I mean the grade 4 osteoarthritis joints, malalignment, instability, infection. These are not indicated in meniscal transplant. Closing remarks, meniscal tears are common orthopedic pathology. Selecting the correct treatment can be challenging and involves multiple factors. A systemic approach always wins. Every attempt should be made to preserve the meniscus, because meniscus is not a remnant, is a very important structure inside the joint. This is a flow chart, how you can judge meniscal tear. When severe degenerative knee, symptomatic, then it displays, you go for physiotherapy. If white zone, you go for meniscectomy. If red zone, always go for repair. So this flow chart very illustrated very well. This is all inside technique. This is very small video for all this technique fiber stitch. Little bit slow, but just see how sewing in one case. For any orthopedic surgery, as I said, for beginner or learner, that you first go for diagnostic one. Don't damage inside the structure by your saw or by scope. If you put inside your saver and you run the saver and you go for a repair and you damaging the inside the joint. So don't go do this. You just see how we debride. Put the saver, you see, you can able to see the saver in the right place and debride well. In very cases, chondromyopathy, if you are doing this, then choose that cases for beginner and you do all these cases. For discoid meniscus, you do these cases without damaging. This is fiber stitch method, all inside. How you pass this needle for the tear area. Always better to use bite both the tear. And always see whether it is reducible or not reducible. So always clinical judgment and doing arthroscopy, always try to see, pull the meniscus, you see whether it is reducible or not reducible. And then you want to, they go a plan to meniscal repair. This first needle, this first pass. This is tear. You could easily visualize the tear inside. This is all inside technique, as I said. Draw. Again, another stitch. just through. We'll tie the loop. So that's enough. This is all inside technique. So at the last, these are recommended literature of meniscal injuries. You can go through the meniscal injury by management and surgical technique. And thanks again. Thanks, Ias. President Secretary and Dr. Raju is here. Thank you so much.
Wonderful presentation, sir, about the meniscus, all about.
Thank you, sir, for a wonderful presentation. Good technique. I have a lot to learn about meniscus. Now I invite Dr. Debayan Singore for meniscal root repair and ramp lesions.
Thank you, sir. So I'll be speaking on the meniscus root and ramp repair. So first I'll speak about the root repair, then I'll go about the ramp repair. Okay, so for the meniscus root repairs, first we have to understand what are the meniscus roots, and then we'll talk briefly about the anatomy, how to diagnose meniscus tears. Then after we have made the diagnosis, how to treat this, how to repair this, and how to rehab these patients. So first we have to understand what are the meniscus roots. So both the menisci, the medial and the lateral menisci, are attached to the tibia at the anterior and their posterior roots. So before going into the anatomy, we have to understand why are we so interested about repairing the roots. So if you see these X-rays, this is a patient who, so the typical medial meniscus patient will present to you as a 50-year-old, slightly obese female with a sudden onset of pain in her knees, which will start, have a medial joint line tenderness, and it will start with a sudden pop sensation while trying to get up from a chair or coming down the stairs or something like that. And then, if you look at this is the presentation at zero, at presentation, then at 3 months, 6 months, 9 months, and 12 months. So how rapidly this progresses. And if you look at this study from Laprade, you'll see that in 5 months, you already have articular cartilage changes if you don't, if the meniscal root is lost. And even in the biomechanical studies, you'll see that if you see this red box, you see that the contact pressures are almost equivalent if you have a total meniscectomy when you have a meniscal root tear. So a root tear is almost similar to a total meniscectomy. So the idea is that if a patient comes to you, you have to first make the diagnosis, because if you don't know in your mind what can happen to the knee if the root is not repaired, then this kind of X-rays you will get in your patients. And in this Korean study, they studied about 180 odd patients for TKR, and they found that almost 78% of them had a medial meniscus root tear. So understanding the significance of repairing the root is very important. But the biomechanics of the lateral meniscus is completely different. As Laprade wrote in this article that it's like comparing apples to oranges. The lateral root is completely different. The classical patient of a lateral meniscus root would be a 35-year-old young patient or slightly younger patient with a ACL tear, because about 8% of ACL tears have a concomitant lateral meniscus root tear. So if you're doing 10 ACLs, if you're seeing 10 ACLs in a month or a week or whatever, but you should see at least one of these root tears. If you're not diagnosing one lateral meniscus root tear with every 10 ACLs, then you're probably missing out on these. So what does the lateral meniscus do? The lateral meniscus has a very important stabilizing role in fixing the providing rotatory stability to the knee. So if you look at this diagram, So if you look at this diagram, the blue is the native knee. The red is if you transect the ACL, then this is the amount of anterolateral rotation that you get with just transecting the ACL. But if you cut both the ACL and the lateral meniscus root, then this green, so the rotational instability is very high in case of lateral meniscus posterior root tear. And but unlike the medial meniscus, the lateral meniscus doesn't have a lot of role in reducing the contact pressure because the popliteal meniscal, the meniscofemoral ligaments are intact. If the meniscofemoral ligaments are intact, then the lateral meniscus doesn't extrude as much, and the contact pressures are almost same. So this is the intact knee. The contact pressure on the lateral femoral condyle on intact knee. This is a lateral meniscus root transected knee. So the pressures are almost similar, but if you remove the meniscofemoral ligaments, then this sudden spike in pressure you see in the lateral femoral condyle. So, so now that we have understood the biomechanics of the medial and the lateral menisci, let's go into the anatomy. So it's very important to understand the anatomy, because if you do a medial meniscus root repair but you don't do it anatomically, then it's almost as good as not doing the repair, because we'll see later. But so first, the idea is that the medial. So where is the medial meniscus root? So so for the beginners, any arthroscopic surgery, if you want to identify a soft tissue landmark, then the best way to do it is to start from a fixed bony point. If you go from a bony point, then from a hard point to a soft point, going by the bony landmark is always easier than to go from a soft tissue landmark. So the most reliable bony landmark in the medial tibial plateau is the medial tibial eminence. So if you look at the highest point of the top of the mountain, the peak of the medial tibial eminence, so you have to go about a centimeter behind. So it's 9.6 millimeter, or about 10 millimeters or a centimeter behind, and just lateral to that will be your medial meniscal root. So any tear from 6 millimeter from this root attachment is defined as a root tear. So you have to repair it anatomically. Unless you do it anatomically, then the repair won't work. So, but if you suppose you cannot find the bony landmarks, then there are soft tissue landmarks also to identify the medial meniscal root. The lateral meniscal root, similarly, on the lateral side, you have to find the lateral tibial eminence, the highest point of the lateral tibial eminence, and you go just posterior to that, about a millimeter posterior to that, and then you go medial to that, about 4.2 millimeter medial to that. So that would be your lateral meniscal root attachment. So how do you diagnose these root tears? So like I said, you have to have a very high degree of suspicion of clinic from your history that if you're seeing a young patient with an ACL tear, you have to suspect that if they have a high-grade pivot or something, then you have to suspect that they might have a lateral meniscus root tear, because as we saw that about 1 in 10 or 8% of patients have a root tear. And if you look at the Get Good stability trial, you'll see that the incidence rates could even be higher for the lateral meniscus root. For the medial meniscus root, the typical patient would be a slightly middle-aged, slightly obese lady who had a sudden onset of sudden popping sensation in her knee, and then it starts paining. So you can do the Piers test. I don't think it's that reliable. This is from Tapasvi sir's paper, where he shows the supine way of doing the Piers test. There's another way you can do it by the patient sitting cross-legged. There's also the Roman Seil group that described this extrusion sign, where if you apply a varus test, then you feel the extrusion of the meniscus. But I don't think these tests are very reliable. You have to diagnose this basically from your clinical history and your MRI and your clinical judgment. So next, what do we see in a MRI? So like sir already has described the classification, Lapprat classification for root tears. So a type 1 tear, a type 2, which is divided into A, B, C, type 3 tear, type 4, and type 5. You can read this up in a book. So on the MRI, what are you looking for? So on the coronal cut, you're looking for a bone marrow edema on the medial femoral condyle. That means that the contact pressure is lost and the medial femoral condyle is getting damaged. And you have to look for the extrusion. It's classically said that more than 3 millimeter of extrusion is suggestive of a root tear. There will be the ghost sign where you're seeing the anterior horn, the meniscus, medial meniscus, but you're not seeing the posterior horn. So that would indicate a ghost sign. And on the best way to diagnose is on an axial cut, where you can directly see the tear. So how do you treat this? So the treatment of the medial meniscus posterior root tear. So the first thing to understand, whenever you diagnose a medial meniscus posterior root tear and you're planning to repair it, you have to understand that you have to offload that compartment. You have to unload that compartment of the knee. So first look at the alignment, because most of these patients, these middle-aged patients will have a varus alignment. So unless you correct the alignment to a neutral or a slightly valgus alignment, your meniscus is not going to be offloaded and your repair is not going to work. It's going to fail very soon. So first check the alignment. That is the most important thing. then you have to access the root. So like we saw in the anatomy, so you have to access the root. So for that, you use whichever method is suitable for you for the MCL pie crusting. So you open up the medial compartment a bit more, then you can access the medial meniscus root. And there are many like root-specific jigs. Smith & Nephew has a very good one. Then other companies also have. So you have to use the jig to navigate the medial tibial eminence. So unless you go around the medial tibial eminence, if you're using an ACL jig, it becomes a little difficult to go to the posterior root. So if you have root-specific jigs, that will help you a lot. And sorry, the point that I made about the anatomical repair. So if you look at this study, that if you repair the medial root 3 millimeter medial to its anatomical position, then the tension is decreased by about 50%. And if you repair it slightly laterally, about 3 millimeter laterally, then the stress also increases by about 50%. So unless you're repairing it exactly at the root, then you are not doing a very good job. Sometimes if the tear is a bit old, it won't come. So you have to do an artificial ramp sort of lesion. You take a meniscal scissor and release the meniscocapsular junction as you need to bring the meniscus back to its root. And so you don't need to repair these artificial lesions that you create to really reduce the meniscus. So prepare the bed with a curate. You can see in this, these are pictures from Laprad's paper. So you take a curate and then you prepare the bony bed. Then tunnels, the 2 tunnels are better than 1. So you make 2 tunnels, one 5 millimeter anterior to the other one. So that provides a broader base of attachment for the root. So if you are using only 1 tunnel, then it's probably a bit of point contact and the chances of healing are a bit less. But the results are not that sure. We are not sure about the clinical significance of 2 tunnels versus 1 tunnel. So maybe 1 tunnel would also do. Suture materials, there are lots of studies about suture materials. I think tapes are a bit superior to sutures, tapes because they provide a broader base of attachment. And mattress kind of sutures would be better. And cinch or luggage tag types of sutures also do work fine. There have also been studies about using knotless anchors, but I have not, don't have any experience in those. But according to the studies, they perform as well as the normal sutures. For the lateral meniscus root, first thing to understand is that if you're doing 10 ACLs, you should see at least 1 of these lateral meniscus root tears. They perform much better than the medial meniscus roots in both radiological and functional outcome studies. So there's a recent trend that for the medial meniscus root, they're repairing it on the lateral tibial plateau, and for the lateral root, they're repairing it on the medial tibial plateau. So maybe cross fixation, there are some studies going on that show that they might be slightly better to do that. And there's a Charlie Brown video which you can see where he just repairs the lateral meniscus root, and it reduces a grade 3 pivot to a grade 1 pivot. So just repairing the lateral meniscus root is a very good stabilizing factor for prevention of anterolateral rotatory instability of the knee. And okay, sir. No, sir. Okay.
Hello. 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 Sandeep, sir.
Yes, hello.
Yes.
Hi, am I audible?
Yes, you are audible. So what are the patient profile?
So he's a 48-year gentleman. So on MRI, there was a medial meniscus tear. And as we had seen in the morning, so it was like irreparable type. So we have already harvested his semity, got the 8 mm graft. Now you can see here. So if you look at him, I'll show you the medial meniscus. ACL was completely torn. So that's the nature of medial meniscus. Can you see?
Yeah, yes.
See. So I'm going to do pie crusting here. So just to show, now this is what as much I'm getting this much opening.
Yeah.
I'm finding it very difficult to see the root and the posterior horn. So body and anterior horn is visible. You can see the tear. So that was his medial meniscus tear. And see, there are already osteophytes. So already he has started to develop arthritis and little, what we say, unstable. So he's just 48. I feel this is the ideal treatment for him for ACL reconstruction. So I'm doing now pie crusting.
So what are the level where we are going to do
Yes,
the crusting?
so pie crusting can be
Femur
done
side,
at any
tibial
level,
side, at the joint line.
on the tibial side, on the femoral side, or at the joint line. Yes. So I'm going to do, so as Dr. Bancha has described, classical, magic point. So you extra rotate and open cut. Okay. Yes. Now that's maximum I can see. So now I'm going at the level of femur, posterior medial femur. So I'll put one needle, like 3-4, only one hole, but 3-4 punctures. You can see it has reasonably opened. Now I can see complete up to here and even up to root. Probe. Now I'll again pass the probe and see. Now see, earlier it was touching. Now at least I've got some space. So if you see at this meniscus, it is completely unsalvageable. There is no root, no posterior horn. It is just capsule, some remnant attached to the capsule, and this body and anterior horn. So it's a chronic injury. Some flip fragment here. Well, it was completely adhered to the capsule. So here in this case, I'm going to just debride and remove this.
Just go and balance it.
Balance it. That's it. Okay.
So what is the age of the patient?
48.
Its alignment is okay.
Alignment looked okay. On the X-rays, though we do not have scanogram here.
It's a male patient or a female?
Male patient. So his complaints were only instability. So he has got a lateral meniscus tear as well. So which we are going to repair. It's like, double shadow there. Any option I would like to ask all the eminent faculties if anything would have been different done. Any one of you have thought different for this patient? Gurudev, Dr. Gurudev?
No, but if the alignment is okay and
even on MRI did not look that bad.
then recently we have seen Dr. Amit Joshi from Kathmandu. He's using the grassless or semi-T.
I don't know. I feel it is too much overdoing. You see here, completely gone.
Yeah.
So now that's the lateral meniscus.
Yeah.
I'm doing the figure of 4. Can you see? Can you here?
Yeah.
First check चलेगा. Pattern को तय first check को. चलेगा. ये दो.
Yeah.
अरे ये दो ना.
So, do you want to repair such kind of tear or leave it as such?
Sorry, sir.
This horizontal tear.
Yes.
You are going to repair this kind of tear or you leave it as such?
I would like to repair because this is not the only one. I'll show you. So there is in the red zone also. Can you see?
Yeah.
Yeah. Okay. So maybe I'll put 1 or 2.
The question from the floor, this kind of tear is stable.
It is stable, but then we don't want it to increase further.
So what is your plan? How do you repair this type of tear?
How do you?
Repair.
Yeah, so now this is, see, I'm a fan of inside out. So being a lateral meniscus probe, rasp.
The
So
basic
that
question.
meniscus, it is all inside only.
There is a very good amount of opening on the lateral side, but most of the time it is very difficult. Hardly we are getting any space on the lateral side to intervene. So what is your tips and tricks to increase the joint space on the lateral side?
So like Dr. Ayan is here, who is helping me with the opening. So we had done. So it's a figure of 4. Zoom out, please. Zoom out. Zoom out. Zoom out. Yeah. So it's figure of 4 position, and that's giving me very good opening. Okay. Out. Out. यहाँ पर रखो. So I'm not getting good trajectory. So maybe I'll be changing the portal here. Okay, so I'll shift on the lateral portal, medial, anteromedial portal, and then I'll repair from the flex neck in the same position. Focus. Because when you are repairing meniscus, there is no harm in changing the portals. What is it? Blade. Let it out. Take out. Hold this. Hold this. Yeah, that's perfect. Yeah. Out.
Step.
Hold it.
So what is the depth that you're setting for the all inside device?
Yeah, so it is already preset. कितना है? 18, 16.
16.
Yes.
And did you do the rasping, the diamond rasp? Have you
Already we had done earlier.
Okay, sir.
Prior to when we did diagnostic arthroscopy.
Sir, because of the vessel flow,
Yes, please tell.
your the stitch is just pointing towards the vascular structure. So
No,
what is
it
the
is not. I'll
direction
tell you
of
why.
your
I'll tell you why. See, it's here. Vascular structure are more here. So I'm very much. It's in the body.
inside picture?
So maybe you can say neurological structure, but certainly not vascular structure.
Cameraman, inside picture, please.
Please show interside picture.
आउटसाइड वाला थोड़ा जूम कर दीजिए थोड़ा सा.
Yeah.
हाँ जूम कीजिए और थोड़ा जूम कीजिए.
No, it's away from the popliteus. No, just tell them about that. Yeah. Can you see the outside picture, inside picture?
Inside picture, no.
Oh, can someone
One inside
inside
picture. Yes.
Yeah, so
Yes.
I was not aware that it was not visible. So I have passed it. Let's see, probe. Don't worry, leave. So I always give counter pull. No, pull, dhaga pull. Pull, please, gently. Gently, gently, gently. Very good. Bas. Relax. Leave. Leave. Wapas. Pull. Slowly, 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 slowly. Leave.
Yes, nice.
Again, thoda sa. So I always ask bas. That's it. To avoid cheese wiring. So now see, this one is enough, and it's not going to displace further. So that fear of out is gone out of my mind. That's the popliteus tendon. So it's very close to the popliteus. The direction, if you think if we are going here, then it would have been very close to the vascular structure, just close to the lateral meniscus root. I think that's what it's all inside device by Smith and Nephew cutter. The cutter.
We can use the scorpion here also.
Yeah,
This
I
kind of
think
meniscus.
we could have. Hold it. Yeah. So that completes the repair. Again, going to shift my scope into the lateral portal, and now I'm going to start preparing for the femoral tunnel. I'll go ahead with the ACL reconstruction. Any questions? I'm sure there will not be any questions because so beautifully demonstrated by Dr. Sundar Rajan. So everyone got to see ACL, PCL, and MCL all in one. So I already prepared it.
So you have prepared your graft. So what is the diameter and length of your graft?
8 mm diameter, around 7. So my fixation is going to be adjustable ultra button in the femoral side, and most probably suture disc for the tibial side. So I don't use. Yeah, please tell me.
Basic things. What is the minimum length of the graft required for ACL
7.
reconstruction?
7.
Fracture fixation. And what are the minimum length while
No, diameter.
Minimum length of the graft
Is
7.
When
we are going to use the screw aperture fixation.
No, when I'm going to use the screw for tibia.
Yeah.
Then that it should be not less than 8.
8 mm.
So please show the femoral tunnel position once more.
Yeah, I'll show. So see what I do. I don't like those jig which companies has got. So I'm taking, this is 8.5 mm reamer. Okay, so that's like almost behind my femur. So my entry point is going to be, so it gives me very good, that's it. I'm exactly at the footprint. So this is going to be my femoral aimer. Exactly at the footprint. Now Dr. Ayan is going to pass the bit pin. So this is like working like a aimer. Ayan, please go. Yes. Go. But that's it. Discontinue. So what I'm going to do is I'm going to load this 8.5 onto this. So that saves me 2 steps. I don't use depth gauge. I don't think it is required. So now he's going to drill up to 20 to 25 with the same 8 mm. Go, please go. Go.
You are using the adjustable loop here. Your plan is to use the adjustable loop.
Yes. Go. Very thick, huh? Very hard. Yeah. No, you have come out. Go. Oh, relax. Release. Queen, I'm going to use adjustable. Earlier, I used to use only fixed loop. Now I have shifted to adjustables. Go, please. Go. That's it. I'll again check. So 20 is right. 1 second. Yeah, go. 15 is 20, after little more than 20. So that's 20. Go little more. Go little. Perfect. Yeah. Yeah. Come out. 4.5, please. No need. So this, what it does, it saves. So the guide wire never comes out. So that is also one step which is saved. So I'm going to show the tunnel from the anteromedial portal. When we pass the, you'll notice that there is no violation of or no breakage in the posterior to the femur. Chalo, 4.5. And through. So look wire लो जो मैंने बनाया है. Please go. I'm not interested to see here. It's okay. Yeah. Yeah, out. It can come out. Tibial jig, tip femur, elbow femur. Whichever they have.
To always doing this femoral tunnel creation by eyeballing technique. You are not using the offset.
I don't use offset. I told you I'm very comfortable with this. Can you see?
Yeah.
Anyway, we'll see better once we are in the posteromedial. Knee flex, please. Hold it, hold it. Mosquito. So at the beginning only, I just keep everything this done, so I don't have to. Please pull the. This one. Very good. That's it. Remer, tibia. What is which one emer you have given? Tip emer. This is a tip emer. Okay. So now the one this please. No, this one. So the ideal position Dr. Sundar has already put artery. Dr. Sundar has already said in his technique. So it is just, you can see the root of the anterior root of the lateral meniscus. So just anterior to that. So this is a tip emer. So I would like to come out somewhere here. Directly. Yes. With pin. Yeah. Take this.
Using just in the center of the stump.
Yes, I'm in the center of the stump. Yeah.
So while doing the ACL reconstruction in
Yeah.
ACL avulsion cases,
What do you
that
think, Dr. Gurudev?
situation, in ACL avulsion cases, neglected case of ACL avulsion cases, while doing the ACL reconstruction, then what is your reference point for tibial tunnel creation?
Okay, very good. So for ACL avulsion, I go very lateral. So I'll tell you where I go. I'm doing ACL avulsion. I'll go here, here, then anteriorly on this portion or this. So 3 to 4, sometimes 3 to 4, but it is never ACL avulsion is accurate. ACL avulsion is never done with a single. Yeah, drill it directly. So what is your preferred choice for ACL avulsion? How many tunnels?
Yeah.
Aram se. Go down, go gradually.
ACL avulsion.
Sir is asking, sir, how many tunnels do you do? ACL avulsion.
No, no.
Withdraw.
My question is.
Withdraw. Again go. Again go.
Yeah, my question is what is the reference point while doing the ACL reconstruction?
Question is to me or someone? Hold out. In the center. Retriever. Here, different. Okay. Yeah, graph, please. So that's view through the posteromedial portal.
Yeah.
Is this okay?
Yes, it is visible. Yes. Yeah, you can see the entire tunnel on the.
Yeah, you're convinced? So that's adjustable. I'm fan of adjustable loop. So that's Smith and Nephew ultra button. It's adjustable. Wait. Yeah, please check. Split no, already. Yeah, good. So I always like to check under vision. Now once it is done, I'll again shift my scope into the anterolateral portal.
So how many of us use the C-arm to confirm proper placement of the endo button on the outer aspect of the femoral condyle?
So you can see
Because
here,
in
I'm giving
adjustable loop,
complete
there is
downside.
many chance you are going away from the cortex and it slide on the IT band.
Right. So line.
The solution always use the post enteromedial portal to check and mark over that and finally definitely use the C-arm.
Yeah, very good. Screw. No, not screw. Okay, that was me. Well, don't worry, aram se. Very good. So sometimes our assistant can be rook can be very aggressive. So you should always.
Endo button is inside the soft tissue and it is not coming through pulling.
Right.
Then.
So the two way we can observe that. Once it goes out of the, there are two way it can go out. One go out of the facial letter, or it can go out of the skin.
Yes.
We had seen that also. You have to once it comes to the skin. It comes to the skin, it is obvious you have to see at least.
20.
But if it comes out of the facial letter, if you don't see it and neglect it, then it will be a spongy graft. You know, you will get a lax graft.
Yeah.
So always once there are two ways. One, you have already marked your length of your tunnel. That mark is too much inside the tunnel. That means you are not correct. That means your button is not in the outer cortex. Probably it will be away from the facial letter. The other option is once you feel your button is flipped, you pull the graft and see. If it is a spongy, always you see there will be a 1 centimeter movement from there because the facial letter to the outer cortex, it will come and go. Like
middle क्यों निकाला?
Easily feel that. But if it is over the cortex, if you pull it, it will not move. So that is the two thing which you always confirm that your cortex, your button is on the outer cortex, not over the facial letter. If it is over, then you just make a small 1 centimeter incision, put an artery forceps, just open the facial letter, then pass your assistant to pull it up. It will come very easily. Before making an incision, you make a 4-5 cycling. The cycling, ask the assistant to pull it up. Even that direction changes will bring the button to the outer cortex most of the time. If it doesn't come in that, you make a small nick and use the mosquito or artery forceps, open up the facial letter where the thread comes out. Then you pull it, it will come easily. You don't need to explore the joint again.
Yes.
Yeah.
No, that's okay. No.
Most of the time we are used to fixed loop. So the assistant is very aggressive because he has to pull the graft into the tunnel. But in variable loop, only the thread is coming out. So if the assistant, he pulls it with full force, thinking that the graft is also to leave the tunnel. So I think we should instruct the assistant that this is a variable loop. Only the thread needs to come out. Don't be very aggressive. So I think it solves it.
Other option is that yes, because you are a surgeon, you are not pulling it. So your control will be in your tibial side. So what I do myself, I roll out all the threads, hold the graft in my hand, put my hand between the tibial side and this thing. So you cannot pull too much
Little bit tense, little bit tension over the
Yeah,
graft.
tension over
Yes.
the graft and pull it over the, you just press it over the tibial side. So even if he pulls up, it will not go further. So that is the other way that it doesn't go out of the skin. You can prevent it. That's the other trick.
Flexion extension even helps in tight tunnels also.
Regarding your, I have an experience, I will tell. I was trained under Dr. Sundarajan, in fact. So I was very confident of, not having the endoverton coming out of the cortex to the tensor fascia lata. First 100 cases didn't go. I mean, it was on the cortex. One case, what happened? Post-operatively, I saw it is 2 to 3 centimeters away from the area where it is desired to be.
Are we still live?
It was in the tensor fascia lata.
Yes, sir, you're live, sir.
Yeah, done. So we
Case,
have done suture disc. That's the final graph, I think.
you should not, because they are athletes. You can't take a second chance for them.
So fantastic surgery.
Fantastic, sir. Thank you.
It is all thanks to Dr. Ayan, all the staff, and our wonderful anesthetist, and all the people here. It was a fantastic setup. Good to operate. I'll again check lateral meniscus.
Very nicely done, sir.
Okay, fine. Thank you. Thank you very much.
Run the ramp. Back to boarding lectures. So we already did the route. I think that's more than enough for the route. So we'll go to the ramp quickly. Very briefly, we'll go over the ramp lesion. Next PPT. So about the rehab, I have this slide from one of Dr. Tapaswi's lectures. I have it handwritten and kept it for all my meniscus repair patients because it's very complex. If you go look at the Laprad's proposed rehab, is very complex to explain to the patients. Very simplified version that I use for most of my meniscal repairs. So I think this is one slide that you can keep a photo of and use in your own cases. Then can you go to
Photograph. Sister, please come. Thank you.
Okay, so now we'll very briefly go over the ramp tiers. So what are the ramp? So what do we mean by ramp lesion? So ramp lesion is a longitudinal tear. It is defined to be less than 2.5 centimeter in length at the posterior aspect of the medial meniscus rim at the meniscocapsular junction. So you see something of this sort at the posterior aspect of the medial meniscus. So why is it important? What does the ramp lesion do? So if you look at the studies that the forces on the medial meniscus increase significantly about by 200% in an ACL deficient knee, because the medial meniscus has a it sort of fits the medial femoral condyle into the medial tibial plateau, so it provides a bit of rotational stability. So as soon as your ACL is gone, the forces on the medial meniscus goes up. And so how does this ramp tear occurs? So it occurs by, so if you have an ACL tear, then the medial meniscus sort of so the tibia is pulled anteriorly, the tibia is translated anteriorly, and as it is translated anteriorly, the posterior horn of the medial meniscus is wedged between the femur and the tibia. So the posterior horn of the medial meniscus is locked between the femur and the tibia, and there's pull of the semimembranosus capsular arm at the posterior capsular area. So this pull causes this area to open up, and that's what we call the ramp lesion. This was described by Houston in '93. And so why should we repair the ramp lesions? Why is it important? Now, we understand biomechanically that the forces on the ACL grafts, if you don't repair the medial meniscus ramp or the medial meniscus is torn, then the forces on the ACL graft will increase by about 50%. There's a chance of progression of the ramp tear. And also with, like if you look at the studies, then the risk of osteoarthritis in an ACL deficient knee goes up by almost twice the amount in a ACL meniscus deficient knee as compared to a simple ACL deficient knee. So there are biomechanical reasons to repair the ramp, but there is no good long enough RCT or a very good evidence to show that they are clinically, there's a lot of significance to repairing these ramps. So, so the main thing about ramp lesion, you have to remember that you have to first diagnose the ramps. So Jack Houston said this, that the ramp lesion saw you, but you didn't see the ramp lesion. So it has about similar prevalence as that of the lateral meniscus posterior root, about 10% in ACL tears. And some studies even show a higher percentage, about 16%. So for your ACL tears, you should have a very high degree of suspicion of medial meniscus ramp tears. And whatever clinical test, McMurray or posterior joint line tenderness that you do, they are not going to be very reliable in diagnosing the ramp tears. And also, your MRI is always not going to pick up the ramp lesions, because MRI is done in extension where these tears are reduced and they are not very well diagnosed. These are the recent studies have shown that the sensitivity and the specificity of MRI can go up to 71 to 94%. But these are studies done in the West, so where they have dedicated musculoskeletal radiologists. We don't have those, so our chances of MRI picking up the ramp lesion might be much lower. So so once you have have a ACL tear, you should have a high degree of suspicion. So you should go to the back of the medial meniscus and look for the lesion. So there are two ways to do that: the intercondylar approach between the PCL and the medial femoral condyle. You can use that as described by Strobel, or as Jean-Marie Cotte has developed, shown his 4-step method, where you use a posterior medial portal, and then you can get this nice view of a ramp lesion as on the bottom right picture. And even if you are going through the intercondylar between the PCL and the medial femoral condyle to the posterior aspect, you should use a needle from the posteromedial area to sort of push the meniscus and probe it to see the ramp lesion. So once you have diagnosed a ramp, how do you repair it? There are many ways you can do it inside out. If you're doing inside out, Laprade has described this technique. You make sure to use a safety incision. Use a they use a tablespoon, but they're too large for our patients. So I've seen a teaspoon is a lot easier to put into the safety incision. So you put in a safety incision, put your spoon, and then use your long needles and your double barrel or single barrel, whichever cannula you prefer to repair the ramp. But the more popular way is to do an all-inside repair using a suture lasso kind of device. And keep in mind that this is like a bank cut in the shoulder. So you have to bring the capsular rim to the level of the meniscus. Otherwise, these repairs are not biomechanically very strong. You can use all-inside devices. This is a way of using the fast fix device to repair the ramp. So by definition, the tear is less than 2.5 centimeters. So you should deploy anchors at 3 to 5 millimeter intervals, but this is a very expensive way to do it. And the outcomes are usually better as these tears occur in conjunction with ACL tears. So you are stimulating the biology through the ACL tunnel. So the results of ramp repairs are slightly better. And rehab, I think we should use a standardized, simplified protocol for all our meniscus repairs. Like in the last talk, I showed the rehab protocol for these. So that will be all. Thank you.
Thank you, Devan, for your wonderful talk. Now I call upon Dr. S.R. Sundarajan, who will speak on bucket handle tear repair. Sir, please.
Good morning, everyone. Once again, I thank all the organizers of this Ias One program, particularly Rohit, Pawan sir, and everyone. And my talk is on a bucket handle middle meniscal tear. So we'll start with this 29 years old. It's presenting with the pain and giving you a sensation of the left knee for 3 months duration and giving you a sensation while playing badminton. And he had a popping sound, developed pain and swelling. This is the typical picture what you get. You get a normal X-ray, you see the MRI, you see the double PCL sign. So you can see that the meniscus is completely flipped and locked inside the joints. So when we come to the meniscus repair, I think most of us know all the zones of the meniscus. I don't need to discuss too much about it. And you know that between the zone, 0 and 1 is an ideal place to do repair because they are in the meniscocapsular junction and the red zone. Anything coming inner side, the 2 and 3 always there in the gray zone because of you have a less blood supply. So in that we can take a little caution when you do a repair. And all of you know these kind of pictures, red zone, red white zone, and white zone, where you have the blood supply, where you're planning for repair. What technique to use? When you have a backhandle tear, you know that it's a long vertical tear. Yeah, sometimes it can be only in the posterior horn to middle horn. Sometimes it can extend up to the anterior horn. It is essential to know all the 3 techniques. Always it is very useful to do on a backhandle repair, like all inside repair, inside out, and outside in. So outside in is classically for the anterior and the middle, you can use it. Usually all inside can be used for your posterior horn and middle horn. You cannot come anteriorly, so all inside is very expensive also. The most commonly which is used nowadays is an inside out. So it's cheaper, more easier. You can almost go through the posterior, middle and anterior horn if you are making a safety incision, if you want to be in a less expensive for that particular patient. But otherwise you can use an all inside for the posterior horn, and middle and anterior horn even can be managed through inside out. If it is doubt, then you can always use the outside in technique. So there are a lot of nice cannulas from all the companies. This is one of the zone navigator. What you can see here, you have the, sorry. So you have the different curves is what you see here. You can see that this can be used for your middle and posterior horn. You see the nice curve here. This can be used for your anterior horn. So that's why you can even avoid sometimes outside technique. So most of these cannulas will work out with just inside out technique. So it makes your life more easier. And you can, there all comes with the 2 needles, so there are disposable needles like this. This comes with the fiber wire, or nowadays it comes with the mini tape. That is also so good because that gives less cutout than the fiber wire for your meniscus, especially when it's more damaged or a little bit degenerative. Using the mini tape will be very useful in this kind of meniscus repair. So coming to the, when do you do a repair? Of course, all the acute cases in the red zone, red white zone, we do the repair. But even the chronic cases, if it is in the red zone or the zone 0 and 1, better to do a repair rather than the meniscectomy. And of course, we have to see the cartilage status and quality of the meniscus and the reducibility. If it is a rolled out meniscus in chronic cases, if it is not able to reduce it, then I don't think there is no point in doing the repair. But anything which is even 7 months, 8 months, if you are able to reduce it and the meniscus quality is good, younger patients, better to do a repair. But same thing, you can take a same kind of patients with around 55 years old, 65 years old. Even in this kind of situations, you can do a just meniscectomy because you don't need to do such a repair for that particular patients. All young patients, you have to do that. The key position to repair, I think all of you know that the medial meniscus repair usually done in around 15 to 40 degrees of flexion with the valgus force. And the lateral meniscus, always do a figure of 4. Ask your assistant to put the knee down, do an internal rotation that will open up your lateral joint space. And just as a case example of another 26 years old male, pain instability for 7 years, recent fall 4 months back. So even though the patient had a ACL insufficiency for 7 years, they can have a fresh back and handle tear. So please don't you decide before the surgery that all the chronic ACLs will have a chronic back and handle tear. Not so. So many patients develop instability. After that, they develop a new tear of meniscus. So that meniscus to be repaired and ACL can be reconstructed. So that have to counsel the patient that if you see that I go inside, if it is a fresh, I do a repair. So this is just a peripheral tear of the meniscus in the red zone, extending up to the middle horn, not over the anterior horn. So these kind of cases, you can just manage with the cannula, which I told you. I think all of you know how this works out, all the inside out technique. So you bring the 2 needles out of your meniscocapsular side and make a knot like this. So that's how it gives a stability when you do these kind of inside out technique. You can protect it when the needle comes out like that. And always pike resting is very essential because you don't want to damage your femoral cartilage or the tibial cartilage be liberal in doing a meniscus pike crusting. But when you do a pike crusting, don't overdo also, because that may end up in the meniscus laxity. So this kind of opening is more than enough. So the controlled opening, that is more than enough. So on the medial side, always it helps. As I told about the same tear, as I said, that inside out, it can be easily performed with this two needle technique. These are disposables. Nowadays, some companies comes with the two different needles and you can thread it and use it. So still it's cheaper. I think that is very, very easier. This is very quicker when you use the disposables like this. So you can use both vertical and mattress stitches like inside out. So that is the vertical, what I shown that as mattress, and this is the vertical stitch. Vertical stitches make a first bite over the capsule and second over the meniscus. So they are naturally the vertical gives more stability than the mattress. So, but alternate with the vertical and mattress gives more stability as well as it covers the more meniscus. At least keep a 5 mm between the two tear. And also it's very important that you repair the inferior surface. Don't alone do the superior surface, because that will evert your meniscus. When you do only superior inside out and try to pull it, naturally this meniscus is going to get everted. So do at least 2-3 stitches on the inferior side like this. So that will balance the meniscus, bring into the neutral position so that your anatomy is maintained over there. So this is the inferior surface. So that's how you make in a mattress, you make in a vertical, make a superior and inferior surface, and make sure that this can be very stable by just doing a inside out technique alone. So this is a different case. You can see the ACL tear, bacchanal tear. You see that already there is looks like it's locked inside. You see there is already some healing to the ruptured ACL fibers here. So these are the cases where you can do a easily repair. You pull back inside. They are a bit unstable. So in this case, you stabilize the meniscus first doing with the inside out. So inside out gives you take 1 or 2 stitches. So that gives you more stability. Then you start doing the multiple threads. So ask your assistant to hold the meniscus, pull it to the meniscocapsular junction. Then you repair from posterior to anterior. So that's how you do the inside out techniques. Sorry, I don't have the laptop in my control. Otherwise, I can do a fast forward. So this is the same way. I think inside out, I think all of you had seen that in previous meniscus. So you do the multiple stitches. And what you can do that when you bring out the needles outside, the safety incision always is safer for you. I think most of you know this article. You can, I don't want to discuss all those things, but it is a medial side and the lateral side. There is a safety incision. You can make it so that the needles are not coming out. Before you make an inside out needles, you have to make a safety incision. Then you start doing the inside out stitches. Okay. So this will help you to protect the saphenous nerve and vein. That is very important. That's the same way the lateral side, you go above the biceps femoris so that you don't injure the common peroneal nerve. Even the common peroneal nerve is very away below the biceps femoris. You make an incision, you keep it over the biceps femoris. And sometimes I make that if you do a good flexion, if you are not going inside out stitches for your posterior horn, only middle and anterior horn, you don't need to make even safety incision. With the good flexion with the valgus force, will bring all the threads above the safety incision level. So you don't need to make a safety incision. I make a small percutaneous incisions and take out and do the stitching like this. So that is how it looks finally. And as I said, anterior horn, you can use the outside in technique also. You should learn because it's a very simple technique, very cost effective. You need just 2 Venflons, or some companies are coming with some sets also. You can use 2 this kind of cannulated wires. And you use a 9-inch loop, or you can use you can use a thread, and another one you can use a 9-inch loop that bring it out, and you can take it through the other needle. So once you remove the other needle, that will become a knot. So that is the 9-inch wire on one side. Then other thread comes to another 9-inch wire. You can, this is with the loop. The another one is without loop. So you can use the mosquito with. So you use a mosquito, go inside and take it. So always is a little fishy because that's why the outside in will take more time than inside out. Inside out is so easy to do. It will be very quicker. Then you remove the needle, then you change it over to the fiber wire. So that's how it's outside in technique. So you can see that the posterior horn still it's unstable here. So in this case, you use that is the outside in technique. You can use it. That is finally you end up doing with your all inside. One is on the superior surface, and we can see the upper film is in the inferior surface. So two all inside is more than enough for your all bucket handle tear. So remaining you can manage with inside out, or sometimes you can add an outside in technique. So only you require a two all inside, which is very expensive. Remaining can be managed very easily. I know all of you know how does it work. That is the end of the repair. You can see there's a good stability of the meniscus. So the ACL and the meniscus repair. So the preparation is very important. Sometimes in the chronic cases, acute cases not necessary. In chronic cases, you can use a meniscus rasp like that, or you can use a just soft shaver so that it increases the some blood supply for your repair. Yes, I said that already. It's very important that now superior surface alone is not enough. If you see the when you do superior repair, you see it's completely averted here. So do another one or two inferior surface, we see it is lying down to the normal anatomy. So it's important to repair both superior and inferior surface. Sometimes it's very complicated cases like this, ACL, MCL, and back handle tear, where you can push the meniscus, but you can see there is no space for your inside out to go outside because it's completely medial side is ruptured. So in this case, what you can do, you can open up on the medial side. You can do an open repair also. Nothing wrong in that. Otherwise, all the inside now needles helps you to reduce the meniscus to the position perfectly, and you can do the reconstruction. In that cases, do the ACL reconstruction first. Still will have enough medial space. So that will give a more stability, bring the meniscocapsular portion to your meniscus closely. Then you do the repair. So here I did a ACL first. Again, I took some bites. Then I repaired the MCL. Then finally I made a all inside to get a stable meniscus repair. Of course, add a biologies, you can use a fibrin glue, which I don't use it, but otherwise you have microfracture, PRP. They're all a bit controversial, whether there works or not, but at least do a microfracture. It's a very simple procedure, which you can add on with all the meniscus repair. To conclude, it's a deep learning curve, but you need to have all the armamentarium of meniscus repair whenever you do an ACL reconstruction. The days are all gone that we do only ACL, learn ACL, then meniscus repair. That's gone. Because all the cases, what we see now is acute cases, not the chronic cases, which we saw 10 years before. So it's very important. Of course, high cost, but not very expensive. But saving the meniscus and knee is more important than the cost. Thank you very much. Before that, with the permission of chair, I request that we have a Ganga arthroscopy course in March 20 to 24, planning for more than 25 live surgeries. If you are free, you can come. And few of the, I know many of you, few or many of you IAS members, you had seen me as a secretary, and please support and vote for the vice president also. Thank you very much.
Thank you, sir, for a wonderful presentation. Now,
questions are later?
Later on. Now I call upon Dr. J.K. Layak, who will speak on graft option for ligament reconstruction.
ये मेरा नहीं है, आ जाइए. नहीं है.
One announcement for our Sundar Rajan sir. Those who are IAS member, please vote and support our Sundar Rajan sir for the post of secretary. Oh, sorry, vice president. Already he has done secretaryship.
आएगा. Thank you, Rohit, for giving me the opportunity to talk on graft choices in ACL reconstruction. Now, what we know so far is reconstruction of the ACL is a common surgical procedure. However, if you look to the literature, there is no such graft which can be told as an ideal graft for ACL reconstruction. Now, what are the graft choices? There are 3 graft choices. You can use allograft, you can use autograft, or you can use synthetic grafts. But the most common is the autografts. Now, the allografts are usually taken from the cadavers. They are bone patellar tendon bone graft, hamstring grafts, tibialis anterior graft, tibialis posterior graft, and tendo-Achilles grafts. However, they are not usually available in normal hospitals setup. Maybe in the West, it is very commonly available, but at least in India, we are not using this type of grafts. These grafts are used mostly when you have problems in multiligamentous injury, when you do not get any adequate grafts from different areas. Now, the autografts which are most commonly used are bone patellar tendon grafts, hamstring grafts, quadriceps graft, and peroneus longus graft, which we are of late we are coming. The synthetic grafts also are not available probably in India. I don't know if Sundarajan sir is using these grafts. However, I have not come across these grafts. These are what I have seen in the literature in UK. People are using ligamentous augmentation reconstruction system and lead skew. I got it from literature. However, I am yet to come across such type of grafts. Now, question remains that what is an ideal graft? Now, the ideal graft has already been asked by some of the members. The ideal graft length should be over 7 centimeters. I will tell you why the reason, what is the reason. And the mid substance diameter should be between 10 to 11 millimeter, contributes to the mechanical properties that allows the graft to withstand the pressure that a normal anatomical ACL that gets into. And they should follow the Young's modulus, the tensile load and stiffness and high load to failure properties. Now, these are a little complex physics things which we have forgotten. So I'll just recapitulate you what is a Young's modulus. High Young's modulus are stiffer and less deformable. Hence, they are stiff and rigid. Only you have to remember this. Low Young's modulus are flexible and easily deformable. They can undergo significant deformation before breaking or permanently changing their shape. Now, material with low Young's modulus will fail lesser than materials with high Young's modulus. A material which is stiff, that reflects how rigid or flexible the object is. Materials with a high stiffness are prone to failure when subjected to excessive or sudden load. Now, about the tensile strength of any graft, the high tensile strength can withstand significant pulling and stretching force before failure. Good for load-bearing applications. Low tensile strength, conversely, are less capable of withstanding high mechanical force. And the load to failure is another characteristic of any ideal graft. ACL is tested for increasing level of force till it fails. Higher the value, better the ligament. Now, if you look into all these small things, the ideal graft, just remember, you should have a low Young's modulus, low stiffness, and it should have a high tensile strength and high load to failure. Any graft which can fit into this category are the ideal graft for you. Now, what are the grafts that are good for you? Now, let us see the literature. If you see the literature, the autograft or a bone patellar tendon or hamstring graft, you can see the hamstring tendon has got a very high tensile strength. So it's a good graft. It has got a good Young's modulus. If you look at the native ACL, the failure load to failure rate is 2160 and the stiffness is 242. So any graft which is coming around this value are a good graft. Now let us see what are those. Now look at this graft of hamstring tendon which you are using. It has got a Young's modulus 154, which is almost, and stiffness of 238, which is almost same to that of native ACL. And has a high tensile strength of 2422, which is almost same to native ACL. So this is one of the most ideal graft to use. Now, if you see the quadruple hamstring graft, they say it's one of the very good graft if you have a quadruple graft, because of high load to failure. So in case of young athletes, if you give a good tensile graft, they usually don't fail quickly. Now, if you use 4 combined hamstring tendon graft, there are different varieties of diameter you can come across. So if you look at 15 millimeter of BPTB graft, bone patellar tendon bone graft, which has got equal strength that of the 4 combined hamstring tendon graft. So of course, in case of, the failed ACL cases, when you are looking for, either you can go for a bone tendon graft, which has got a very high tensile load to failure, and that too compared with the hamstring 4 tendon graft. So what are the materials properties of a various ACL graft? If you look into in a summarized way, bone patellar tendon bone graft has a stiffness of 162, 168, and Achilles tendon graft has got a tensile strength of 4,612. However, if you look at the mechanical properties, the quadruple graft are coming exactly to that of the native ACL graft. Look at the stiffness of the native ACL, that is 242, which is equivalent to, quadruple graft can give rise to exactly the same amount of stiffness, and tensile strength almost same. And the load to failure rate of quadruple graft is equivalent to that of the native ACL graft. So this is one of the most ideal graft. That is why we are using most commonly the native ACL. For any injury to the native ACL, we are most likely using the quadruple graft. Of course, of late, peroneus longus graft has come over, but the literatures are not too many. So what is the graft length? The graft length all depends on the length of the femoral tunnel, how much bed you want to create, how much bed you want to give into the intercondylar area, and how much length is the tibial tunnel is. Normally, you should have at least 15 millimeter on the femoral side, 15 millimeter of the tibial side, because in between area is constant, that is around 20 mm. So you should at least have a total of 50 mm graft for your reconstruction. Now, about the autograft versus allograft, most studies compared stability between autograft and allograft. They are of level 3, level 2, and level 4 evidence, and great variation exists in the result of these studies, which can be at least partially attributed to the preparation of the allograft. Allograft sterilized osmotic treatment, oxidation, acetone solvent, drying, and gamma irradiation had a 45% rupture rate at 6 years follow-up, which is very high. Hence, allografts are not very good as compared to the autografts. Then there are 3 meta-analyses which is seen in the autograft versus allograft. If you see, there is no statistical significant difference between the knee stability in these 2 meta-analyses. The third found a small but statistically significant difference in mean anterior knee laxity on arthrometers testing, with the mean allograft laxity between 1.4 to plus minus 0.2 millimeter. However, there is no statistical difference existed between the autograft and allograft groups with regard to percentage of knee with less than 3 millimeter of laxity. It is not possible at this point to make any definitive conclusion regarding the resultant stability of these grafts compared to the autografts. However, the best available evidence points towards relatively equivalent stability provided by allograft and autografts. Now, if you look at the graft rupture after 10 years, it has been seen that combined autografts has got a least amount of graft rupture rate as compared to BPTB graft, which is a little better than HT autograft, that is hamstring tendinous autograft, which has got a little higher percentage of graft rupture. Allograft has got no significant differences. So these are all grafts which we use. Normally, on the same side, you can use semitendinous gracilis graft. The advantages are minimal reaction to the own bone, own tissues, small incision size, and from there also you can put the drill on the tibial side. There is low risk for anterior knee pain, and the failure to load is very high, leading to very low rupture rate. Now, disadvantages: residual hamstring weakness and unpredictable graft size. And also, sometimes there can be a saphenous nerve injury during the harvest. So another is the bone patellar tendon bone graft, which I think nowadays we are not using it, but in case of either re-injury cases, sometimes we use. Of course, I do not have much of knowledge about this bone patellar tendon bone graft. I think some people might be using it, but nowadays I am using at least peroneus longus graft as compared to bone patellar tendon graft. The limitations are enteric knee pain in up to 30% of patients. There will be kneeling pain on the patellar pain and increased risk of patellar fracture and patellar tendon rupture. The other grafts are quadriceps tendon graft that avoids enteric knee pain, avoids hamstring weakness, and adequate thickness of the graft can be harvested. Already we have spoken about the allograft. The synthetic grafts, maximum load to failure force that exceeds that of the native ACL. They are the advantage. And also, it limits the complication described to that of the autografts. However, the disadvantages are limited evidence on strength of the synthetic graft. Synthetic debris affects function of the knee joint, and it promotes synovitis. Also, there is a very high risk of revision surgeries. So indication of allografts are patients more than 40 years, multi-ligamentous injuries, patients' preferences, and previous harvest from other donor sites, and inadequate autograft tissue. As I was telling you about the peroneus longus graft of late, which you are coming, either when you are accidentally rupturing the semitendinosus graft, or you are not very sure that the graft diameter is less, or it is more than 7 or 8 millimeter, then it is better to go for a peroneus longus graft. I have seen in one test, I have last 4 years I am doing it. I have found there is no functional differences if you use peroneus longus graft in case of primarily in case of ACL reconstruction. Also, although I am just going for another study on the difference between the functional outcome between the peroneus longus and semitic graft, which I think will publish after 2 years or so. Thank you.
Very nice presentation, Dr. Lake. And you have enlightened the knowledge about the graft choice and ideal graft. Thank you very much, sir.
Thank you, sir.
Next tips. Now, may I request Dr. Abhijit Sen to come on the dais for his presentation, superficial quadriceps graft harvesting.
First of all, thanks to organizing committee from giving me the opportunity to present this surgical technique. So my topic is superficial quadriceps graft harvesting technique. So many times we encounter the situation like we have harvested graft for ACL or PCL reconstruction, and we have prepared the graft and find that the graft thickness is not up to the desired mark. It's either 7 or 7.5 mm, which is not adequate for ACL or PCL reconstruction. Now we start thinking, what is the alternative option? So alternative option is superficial quadriceps graft. So the superficial quadriceps graft is a versatile graft, and if we go for the anatomy of this quadriceps tendon, we find that it basically shows a trilamellar pattern. The superficial most layer is formed by the rectus femoris, the middle layer by union of the vastus medialis and vastus lateralis in the distal 6 centimeter of the tendon, and the deepest layer is formed by the vastus intermedius. See, if we notice, so this quadriceps tendon is more muscular on the medial side and it's tendinous on the lateral side. So if we want to harvest the graft, we go along the lateral part of the tendon. So what are the advantage of this quadriceps tendon? So from the literature, we find that the quadriceps tendon contain 20% more collagen. It has higher fibril interstitium ratio and higher fibrillous density compared to the same thickness graft of BPTB graft. So this is the study which shows that if we compare the patellar tendon of 10 mm thickness with the quadriceps tendon, it has higher cross-sectional area, it has higher ultimate load to failure, and it has higher stiffness. So what are the other advantages of quadriceps graft? So the literature shows that if we go for hamstring graft harvesting, in case of vertical incision, we get 25% superficial branch of saphenous nerve injury, and in 16% in case of oblique incision. So literature also says that there is transient weakness of the knee flexion if we harvest hamstring autograft. So in case of superficial quadriceps graft, we don't encounter any anterior knee pain, which we encounter in case of BPTB graft. And customization of graft is possible. Like in case of hamstring graft or peroneus graft, we get the graft of the thickness, whatever is available. We cannot change the thickness of the graft. But in case of quadriceps graft, we can harvest the graft according to our choice. So there is reduced incidence of arthrofibrosis if we harvest the only superficial quadriceps graft. If we go for full thickness graft, there is chance of arthrofibrosis. So as we harvest the superficial graft only, so there is less chance of arthrofibrosis. And we also have the better patellar mobility. So conventionally, quadriceps graft is harvested in full thickness, or in superficial thickness graft is also harvested. It is done through a big open incision, which has a big ugly scar, and it also delays the rehabilitation process. So now I will present a video technique to harvest the superficial quadriceps graft. Can you please run the video? So here we have this is the lateral side, and we have marked the upper pole of the patella. This is the medial side. And our surgical incision is at the junction of the medial 2/3 and lateral 1/3 of the patellar upper pole. So we put a vertical 2 to 2.5 centimeter incision starting from the upper pole of the patella and extending proximally. So this is the surface marking of the incision. So with the surgical blade, we incise the skin and the subcutaneous tissue. Now we incise the peritoneum, which is exposed after dissecting the subcutaneous fat. So we go for sharp dissection of the peritoneum so that there is little fibrosis after repair of the peritoneum. So here we use a Jugaru technique of measuring the graft thickness. We basically harvest 8 mm of width. So we use a 8-inch right angle forceps to measure this, because this tip of this 8-inch right angle forceps measures around 8 mm. So our first incision is in the midline, and we take the second incision 8 mm lateral to that. And to take the depth, we use a 6-inch right angle artery forceps because the tip of that 6-inch artery forceps is around 6 mm. So with the help of that forceps, we take the depth of this graft. So our width of the graft is 8 mm and depth of the graft is 6 mm. Then we make a loop with the suture and we excise sharply dissect from the upper pole of the patella. Now we take some whip stitch with a knob absorbable suture to the dissected end. So here we have the liberty to change the width of the graft. Now we dissect the resected tendon superficially. So here we have to be careful. We don't violate the deeper layer. And many a times we are able to find a fatty layer in between the deep superficial quadriceps and the deep quadriceps. So this is the confirmatory, but all the time it's not possible to find this fatty layer. But if we can get this fatty layer, then we are sure that we are not violating the deeper structure. So now with the help of a 8 mm closed tendon stripper, we push it inside. While harvesting, we keep the knee in 30° of flexion so that the quadriceps muscle is relaxed and we can harvest the graft easily. You can see how nicely we can harvest a very long, generally we can harvest up to 30 to 35 mm of long quadriceps graft, superficial quadriceps graft. You can see the length. It's around 30 mm. When more than 30. So this is the wound after harvesting graft. So we close the peritoneum layer by layer, and you can see that we have not violated the deeper quadriceps layer. You can see the size of the incision. It's 2.5 centimeter, and after doubling the tendon, we can get easily 9 mm thick graft. So we have studied in cadaver also. We have harvested the graft in the cadaver and we have opened the tunnel, and we have seen there is no violation of the deeper structure. It's limited in the superficial layer only. You can see the tunnel. We have opened up the tunnel. You can see the deeper structure is intact. So there are some disadvantage of this quadriceps tendon graft harvesting technique. Like generally we go for measurement of the thickness of the quadriceps in MRI, 3 centimeter proximal to the upper pole. If it is less than 7 mm, then we don't prefer to harvest quadriceps graft because there is chance of violation of the deeper structure and the further arthroscopy become difficult because the water will leak. And if the BPTB graft is already harvested in that patient, we won't prefer to harvest this superficial quadriceps graft. And another disadvantage is it needs considerable force to harvest. So this is the 3 disadvantage of this graft. Otherwise, it's a wonderful graft, and the quality of graft tissue is very high. So this is the paper we have published this surgical technique in arthroscopy technique in 2022 December, and we are doing this superficial quadriceps graft. We are using this for primary ACL reconstruction also and PCL reconstruction also. Thank you very much.
Nice presentation, Dr. Sain. And this is the end of the session. Any questions from audience? No question.
My question to Dr. Abhijit. One question from my side, because there are so many youngsters sitting here. So what are the minimum diameter of the graft in male and in female? Number two, and what are the length of the graft for aperture fixation?
Sir, for quadriceps?
Any you
In
can.
in general. Sir, for ACL reconstruction, we prefer to keep the graft of 8 mm thickness, minimum 8 mm thickness. For the PCL reconstruction, we keep at least 10 mm thickness. So this is the standard guideline to keep the graft thickness. But many times we find that if we use hamstring graft or peroneus graft, we get the, in case of shorter build of patient, we get the graft of 7 mm. So many times it becomes sufficient for them because their demand is low. But in general, we try to keep the graft thickness of 8 mm for ACL reconstruction and 10 mm for PCL reconstruction.
Okay, thank you. Hello.
Thank you, sir.
Hello, Rajiv sir.
Hello.
Hello, Rajiv sir.
Yeah, am I audible?
Yes.
So,
what is the diagnosis of this patient?
yeah, so this patient has a road traffic accident almost 3 weeks back, and he came with a history of pain, swelling, and some amount of extension lag in the knee. So, if you see the MRI, he has a classical ACL avulsion.
Yes, yes.
And just we have put our scope inside, you can see this is the tibial side avulsion, and here you can see the shining ligament. That is your intermeniscal ligament, and this is very important for junior to see that there is entrapment of the intermeniscal ligament here. So whenever you try to reduce, you see the intermeniscal ligament acts like a hindrance. So normally you have to debride this intermeniscal ligament to have a good reduction of this fragment. Second thing, you have to see integrity of your ACL. You can see here both the bundles are intact. It's a quite vascular graft. You can see the vascularity is very good. You can see probe. The PCL is intact. We have done a diagnostic roundup also to see valgus and external rotation. You can see this is the anterior horn of the medial meniscus. You can see this is the root and the body of the medial meniscus. The whole of the medial meniscus is intact. So once you go figure of 4, do figure of 4, you can see the lateral meniscus is also intact. And sometimes you have to make a window with the fragment, and you can see whole of the root, body, and the anterior horn, the lateral meniscus is also intact. So this is the case of isolated ACL avulsion, tibial side avulsion. So you can fix it arthroscopically, you can fix it open, you can fix it with the suture, the anchor also. So I prefer fixing it with the suture bridge technique. So normally I make 2 tunnels. The first important part in this old cases is preparation of your bed of your avulsed fragment. This is your avulsed fragment. Some amount of hypertrophy is there. This synovial hypertrophy will be there when you get more neglected case. So try to prepare and debride the undersurface. This is very important step. So undersurface of this, so that you have a raw bone and you will have a good bone-to-bone healing. Now put your scope inside the crater. You can see now I am inside the crater. Can you see this? And this is your intermeniscal ligament which is getting entrapped. So debride the intermeniscal ligament. So intermeniscal ligament, it attaches with from the medial anterior horn of the medial meniscus to the lateral horn of the medial meniscus. So just you debride this intermeniscal ligament. You can see I have debrided this intermeniscal ligament. And once you debride this intermeniscal ligament, you will see whole of the frame. You can see this is your intermeniscal ligament, and just I am debriding it. So Gurudev, what is your preferred fixation device for these avulsions?
Sir, we use many things, but depends on the fracture configuration. Sometimes we use the lasso, sometimes a scorpion, like that. If the fracture fragment is too big, we prefer to put the screw also.
Yeah, so this is a moderate size fragment, I think, here. So we have planned for fixation, and now see for the reduction. So once you have prepared your pulse fragment, and then
one question, for how long in chronic cases you prefer to fix that fragment
so I have fixed it up to 6 to 8 weeks. You can fix. If you can see the vascularity of ACL is good. The only thing is that as you get delay cases, you have hypertrophy of this fragment, and you have also some of the fibrosis in the crater also. You can see all this crater will be filled with fibrous tissue. So you have to go for a good preparation of the crater so that your whole of the fragment sits well. And you can see whole of this avulsed fragment. Now I have prepared the bed and it's sitting well. Yes, yeah. Because I have removed the intermeniscal ligament, and now some amount of intermeniscal ligament is still there to try to debride that part, and ultimately you will see there will be a good reduction. So I use 2 tunnel. Sandeep, as Sandeep told, sometimes you have a very large fragment, you can use 4 tunnel also. But normally for moderate size fragment, when you have a fragment in between your median and lateral tibial spine, you can use 2 tunnel technique. So first step is preparation of your avulsed bed. Try to debride the anterior part, which has hypertrophied. Then second part is preparation of your crater. This is very important. Don't try to remove too much of cancellous bone here. Just debride the fibrous tissue, which is coming in between your bony fragments, so that there is a good bone to bone healing. Got it?
Yes.
And this is very important. Scopy of the crater. You can see this is your crater. This is a raw bone here. So I'm not going for too much debridement in this part. So now again try to reduce it. Switching rod. And you can see the whole of this fragment. Pump. Water pump.
So sir, before passing the thread through this fracture and ligament junction,
Yeah.
you prefer to put some K wire to temporary.
So yeah, see, if your fragment is not reducing well, you can put the K wire. Here you can see it's like hair-like reduction here. You can see the whole of the fragment is getting reduced, and there is no anterior bump. You can see it's like a hair-like reduction. This is a fragment and it's getting hair-like reduction here. So I think if you have a very good hair-like reduction, I don't put any K wire because that makes my life cumbersome. And here you can see this is your anterior horn of the lateral meniscus. Sometimes what happens in old cases, you get some amount of avulsion here also. So you have to repair it. Here you can see it's well intact with the anterolateral border of your ACL and the fragment. You can see this is the anterior horn of the lateral meniscus. So once you put your fragment in an anatomical position, it will reduce back to its anatomical position. Got it? So first step is we'll take a bite. See, go. So you can see here, this is the first pass XT from Smith and Nephew. It's a self-retrieving suture passing device. Here you can see, and you will use a vicryl to pass my first thread. So one from medial to lateral, one from lateral to medial. So just hold it at the junction of, you can see, this is your pump, ACL, and here down is your bone. So this junction is important, and try to take the bite as far as possible. You can see, this is a self-retrieving suture passing device. Lock it, and now you see a good bite has come out. Take it out, boy.
Knee scorpion, or this is
This is the first. This is for rotator cuff. This is first pass XT from Smith and Nephew, and you can see this is a self-retrieving suture passing device. You can see here the needles coming out. So first bite I take through the vicryl. Over that I will pass ultra tape. So 2 ultra tape I will need. Yeah. Hold it. Can you show cameraman this part? Gurudev, you can see this part?
Yes, it is visible.
Yeah. So now you pass it. You can see my suture is passing. It's like a railroad. You are passing my suture through this vicryl. The advantage of taking your first bite through the vicryl is that your needle will not damage your thread. The ultra tape. Got it? So just zoom it here, friend. Give me a suture manipulator, please. And you can see you have a open end and you have a closed loop here. So just try to take a cinching loop. Just I am taking it out through this, and here you can see it will go and it will hold it. You got it?
Yes.
Yeah. So this is my first bite. My second bite will be from lateral to medial here now. And now he will hold. Now my assistant will hold it gently. Again, this bite is through the vicryl only. And then I will take it from lateral to medial. See, above that bite, you go it and
This bite is it's proximal to the bone tendon junction.
Yes, proximal to the bone tendon. All your bites are proximal to the, hold it, bone tendon junction. Second ultra tape. Yeah. Again, 2 tapes are good enough. Make it equal. Again, you can see there, I am passing this over the vicryl. Got it? Yeah. And then cameraman, close. This is a simple cinching loop. You can put a knot there. I don't prefer putting knot there. Just this is cinching loop. You part this through this loop, take it inside, and you will see there are two bites are there. Got it?
Yes.
Yeah. So now you park both of your, leave it. Park it there in the anteromedial portal, and now I will make my tunnel, ACL jig. So again, try to lift the avulsed fragment. You can see here. So normally this is your normal cartilage. You can see here, and this is your crater. So try to make your tunnel over the margin of the normal cartilage and the medial margin of the crater, and the second tunnel will be over the lateral margin of the crater. Got it?
What is your reference point while creating the 2 tunnel technique?
Yeah. So 2 tunnel, I try to make first tunnel over the medial border of the crater and second tunnel over the lateral border of the crater. So you can see this is a normal cartilage over the lateral side, and you should have minimum 5 to 6 millimeter distance. So if this is my second crater, 1, 2, 3, 4, 5, 6. This will be my first crater. Got it?
Yes.
So then again, this is my normal bone. You can see normal cartilage just here. Hold it. 11 number blade, please, boy.
What is the angle of the jig here?
55 only. I need a small bridge there only. All right. So just I will make it bigger, my incision a bit bigger, so that when I tie it over the post, wait before tightening. So this is my crater. Go, yeah. Fire the bit pin. Yeah, fire the bit pin. Yeah, go. Lock it. Yeah, got. No, again it's this. You have changed the direction. Wait. Just once I put it, don't lift it up, huh? Yeah, the lateral body. Yeah, go. Tight. Tight. कितना हो रहा है? बस हाँ ठीक है. Fire your bit pin. Fire your bit pin. Fire your bit pin. Fire your bit pin. Yeah. 4 millimeter. Get it. Give it. Fire your bit pin. Go. But wait. Yes. Remove. No. The second bit pin. Take it out. Bullet. Hold the guide wire. Then take it out. Hold it. Then take it out. Yeah. Take it out. Yeah. Got it. Fantastic. Now second tunnel will be at least 5 to 6 millimeter lateral to that. Got it?
Yeah.
So this is my first, and this is your second tunnel, and distance is approx 6 to 8 millimeter. Yeah, go. Fire, but fire. So Gurudev, anything difference?
No, sir. We're following the same principle.
Same thing, no? All right. So all right, good, fantastic. So take it out. Now 4 millimeter.
Yeah, I already reduced it with the probe when it is sitting well in the crater.
So you can see the 2 bit pin there. So I will take a bit out, a bit out. This one.
We do little bit different while passing the thread. I generally use the lasso. First one through the tendon, and the second one encircles the entire bone ligament junction.
Fantastic. So now you can see both the pin there. It's quite wide apart. So for a yes. Now protect your bit pin. This one, yes. Wait and keep the suture ready, huh? Yeah. Go. Wait. इसको पकड़ लो 1 minute. Don't be in hurry. All the suture, yeah. Now I'm protecting my cartilage and the fragment here. Got it? You can see here. Yes. Go. Skin में गया देखो. Yeah. Go. Suto. suture manipulator. Go, go, go. You can see, yes. And this is my first 4 millimeter tunnel. Wait. Don't take it out. Ask your assistant to keep your lasso loop ready. Come out. Take it. Yeah. And now you can see my first thread is green one. Yeah.
Yes.
So now take this and park it in the, lift it up.
So the previous one and this one between the diameter is the same.
What diameter you are asking for? No. That was between, and this is, I am delete with the 4 millimeter.
Okay.
So rotate. Rotate, rotate. थोड़ा निकालो, थोड़ा नीचे करो, नीचे. Yes. थोड़ा नीचे करो. Yeah. And now hold it and park it in the anteromedial portal. दोनों thread है, take it out. Yeah. So this is my first thread. इसको ऐसे कर लो, loop कर लो. Yeah. Loop कर. Loop करके lock कर दो. Yes, fantastic. Hold it like this. A second drill. Bapi, you come. Now again, try to protect your second pin. This is your fragment. You can see here. Just I'm lifting it up and just protecting it. You can see this cartilage media, the lateral border cartilage is quite close to that. So it will pull the fragment inside. Yeah, go. 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 Wait. Bit pin. Yeah. So normally I use 2 different color. You can take it out. So you can see this is green and this is light green. Got it? So you don't get confused. So you can use a white thread also. Suture retriever, Babu. Yeah. And now take it out. Yeah, take it out. Yeah. So now you can see you have 2 loops there. Got it?
Yes, sir.
Yeah. So there are different technique you can use. Isko pakad lo, Bapi. Scope ko. Bapi. So this one is your for lateral loop and that is for your medial loop. No, isko pakado. So now you pass your. So now you pass your first bite from the medial. Chalo, chalo, aajo, idhar aajo, idhar aajo. Yeah. So इसको पकड़ लो. Let me see. Same है? नहीं. So whenever your 4 threads are there, just see whether you are
trying to do like double row technique.
Yeah, no, double no. I will just do it. Just take both. This is the best way. You take both the hold any 2 of the threads and take it out so that you will have no confusion. Huh? Now you check it that hold this one, hold this one. So what do you prefer? You prefer crossing of your sutures, Gurudev?
Yes.
You prefer crossing of the sutures.
Sir, how do you differ this technique in pediatric age population?
So normally in pediatric age population, what I do? So now I will pass. You can see, just zoom it on. Pediatric age population. So what I do? I make my tunnel. So pediatric age, normally what I do, if it you can go for fascial sparing also. So all these 4 threads, try to take it through the intermeniscal ligament. You can tie over the suture post or disc over the anteromedial aspect of the tibia. Got it? Or second thing is that you can use your smooth pin. In spite of bit pin which is threaded, smooth pin like K-wire you can use, and you can make your tunnel through the K-wire and try to put your post distal to your tibial fasces. So these are the 2 techniques which are well described for the pediatric. Yeah. Chalo. Take it, track. Yeah, it's good. No? It will take, and just I will take it out. Yeah, chalo. And 9 second, chhod do. Just, you can see here, Gurudev.
Yes, sir. It's
So
sitting
just
nicely.
you are passing both the bite through the tibial tunnel. Got it? Both the bite through the tibial tunnel. So this is the lateral bite, and I am taking out through the tibial tunnel. So got. Now you see, you can spread it, huh? Yeah.
And
I am done. 5 minutes, I am done. So you try to spread it over the. चलो pull करो इसको. This one, दो इधर पापी इधर के चलो अर्शु. All the 4 threads. Yes, just pull. No, just two. Only 2, huh? The lateral 2 and middle. Hold it separately. Yeah. Pull. Yes, and leave it like that. See, it's now reducing this fragment. Leave. Pull. So you have a wide spread coverage. Got it?
Yes.
Yeah. And now you pull it, and you see there's a hairline reduction there. Got it? So.
But there is no any interposition of that ligament.
No, intermeniscal ligament. You can see here. I will show you. Probe. So normally this is the first step of surgery. You debride the intermeniscal ligament, huh? And you can see here.
Yes, sir.
There is no interposition of intermeniscal ligament, and you can see there is no bump. Earlier, the fragment was lifting like that. You can use one more tunnel, as Sandeep told. You can use it there also to fix it, huh? So now we'll fix it over the tibial side over suture post. Chalo. Hold it. Yeah. Chhod do. Isko pakad lo.
On the tibial side, you are using
Post.
or
Post. You can use disc also. You can use post also. So I think the disc, they have to open one of the endo button to use a disc. So post will be a cheaper option. They are already Smith & Nephew is taking care of implant of 5 patients.
Sir, in this type of fixation, their most common complication is FFD. How do you prevent this?
Yeah, so yeah, there are 2 things which is important, Gurudev. First thing is your extension lag, and second thing is your loss of flexion. So loss of flexion is because of poor rehab. Whenever you have adhesion in the suprapatellar pouch, you get loss of flexion, and loss of extension is because of sometimes your fixation is not good enough to hold the fragment in the crater. So what happened? Anterior part of your fragment lifts up, and whenever patient is extending his knee, it gets impinged over the intercondyle and all. That causes your loss of extension. So be careful when you are doing such type of cases now.
Dr. Rajiv, one question.
Yes, sir.
There was a comminuted fragment. Do you want to debride it?
Yeah, so later on I can do anything, sir, once I fix it.
Because I think.
Yeah, I will do that, sir. No,
Thank you. And how do you actually make sure that the reduction is good? Sometimes this fragment sinks. And
so normally what happens, don't try to debride the undersurface of the avulsed fragment too much. Don't try to make your crater too deep.
Undersurface.
And these are the, go, one cortex. And this is very important, but take it out. This is very important whenever you are planning to put your post here. So, no, here.
Rajiv.
Yes.
Sundar here.
Yeah, Sundar sir, please.
It's a fantastic surgery, nicely demonstrated. Just for the delegate's point of view, what I want to add here is that the most common complication of ACL avulsion fracture, whether you fix it or don't fix it, patient comes with FFD. 10 degrees or 15 degrees of fixed flexion deformity.
Yeah.
The most important point is that post-op rehab. So you have to immobilize them in extension.
Yeah.
Make sure that you do immobilize in extension for at least 2 weeks time, so that the patient gets extension. What happens when you leave it like that and send the patient, they'll keep in flexion. Fibrosis will form because of all the surgeries. They go for FFD, even we do a surgery.
Yes.
So the most important thing is to prevent that complication, keep it in extension and do that. And the other problem is sometimes the comminuted fragments like Rogitas, if you leave it, they can have again FFD. Yeah. So after it's nicely fixed, there are small fragment was protruding outside that can be easily taken off.
Yes.
You can just take out the It will help.
So you can just don't try to debride it, just with the artery forceps or
Yeah, just take it
with
up,
your
yeah. Now
basket.
push it inside. Yeah.
Yeah, yeah. With your basket, just try to. So Sundar sir, do you do it differently?
So what I do most of the time, I reduce it.
Uh.
Temporarily fix with on K wire.
Yes.
So my
All right, good.
pre-reduction before I fix it. Almost pretty much are the same. I make a loop, but what I do sometimes the fragment is not comminuted. I make a tunnel through the fragment itself. When
Many
you make
times,
a tunnel,
yes.
that
All
gives
right.
more stability for me because already you reduced it, and you make a small tunnel through the
Bottom.
at least one of the fragment on the medial side or lateral side. So the loop goes exactly through the fragment also. So that gives an extra mileage for the fixation. But otherwise, this is very good.
Yeah, so you can see one comminuted fragment here.
Comminuted fractures, we cannot do it.
And you can see the reduction here. It's a perfect reduction. You can see the reduction here. It's a perfect reduction, and this is a small comminuted fragment here. So just I will see whether I can reduce it there or I will take it
always
out.
fix with the two KOIs, one on the medial side and the lateral side. Then only I take the bite and drill it.
And cover till final fixation on the
Till the
tibia.
final tightening, then I will take it out. When I do a tightening, I'll take the KOIs.
Dr. Rajiv, just a question. If the fragment is big enough, do you consider putting any suture anchor on the posteromedial aspect and crossing it over to the lateral side, the threads?
Yeah, yeah, always. Sometimes people use 4 tunnel also for large fragment. For very large fragment, I would suggest to fix it not through the only this with a suture lasso. They're better to fix it with a screw. You can fix it arthroscopically also with a screw. So that you can do if your your fragment is large enough.
When coming to the pediatric question,
yes,
we have one staple which is got a length of around I think it's 13 or 14, which was done with the Coimbatore surgicals. I started doing with only staple. Just I put a staple, it has got a thread at the head.
Yeah.
So just staple it. You can hit it and you can unscrew your insert.
So you can now see the tensioning in the anteromedial and the anterolateral bundle. Both the bundle you can see here, the anteromedial and the both the bundles here. You can see the tensioning of both the bundle of the ACL. So anteromedial
yes, sir. It looks
good, quite good.
perfectly
So
reduced and stable.
now just we will tie the screw. And thank you so much.
Thank you, sir.
Thank you.
Thank you, sir.
One more question. Do you anytime consider drilling through the fragment?
Yeah, always. Sometimes there is a mini tightrope device from Arthrex. So you can drill through the fragment and you can put a small button is the endo button and you can tension it. That also causes reduction of the fragment in the crater. So you can do like that also. Through the fragment drilling is also recommended. But I prefer drilling through the crater.
I use the same technique, but I reduce
So
it before.
Can we shift to the other OT?
Yeah, yeah. Now Somadeep is there. He is
Somadeep is taking the graft.
Brought through the fragment itself can be fixed also.
Shomudeep, can you hear
Yeah,
us?
so Somadeep is telling just complete 2 or 3 lectures. He will be there.
No, Somudeep is there, I think.
No, he is telling you complete 2 or 3 lectures. He will, yeah.
No, any tip for graft and all? Somudeep, can you hear us? Okay. So let's start with the lectures.
This session is end.
So we have
Thank you,
finished the next session. I would like to.
Having the blood bank, bone bank. So do you use allografts for your instead of autografts? I've got the facility of that one as well, no?
Situations when a KD4 where you do a dearth of the grafts, then actually I was using a lot before. Now I have reduced after coming to the peroneus longus. Previously, now we don't use it. Now after peroneus, my usage of allograft has come down, but still we use now. We are using for even for the shoulder. They're quite good. We use for lower trapezius. We use for this.
Dr. Sundar sir, please on the dais. We have to felicitate us. You.
हो गया, अभी थोड़ा सेव कर लेते हैं। হ্যাঁ হ্যাঁ 70 ভালো ভালো গ্রাফট আছে। इसके एक माइक्रोपोर मेरे हमारे ये একটা মাইক্রোপোর লাগিয়ে দে তো এতে চশমায় নইলে একটা মাইক্রোপোর নিয়ে আয়, চশমাটা পড়ে যাবে। হুম এই চশমা দিয়ে উপর দিয়ে লাগিয়ে দে, চশমাটা বাই চান্স পড়ে যাবে। না না চশমা এই হ্যাঁ সিম্পল এসে চলে पकड़ो। हाँ ठीक है। व्हाइट बैलेंस हो गया सिस्टर, एक गॉज दो ना उधर से।
So next session is the third session on ACL. I invite Dr. Professor Pawan Kumar to please come over to the stage to chair the session. And Dr. J.K. Layak to please accompany him for chairing the session.
तुम इधर आ जाओ, मैं उधर।
Dr. Nirmal, you are ready? Please, Dr. Nirmal, come. Methods and devices of graft fixation.
सकर सेवर में लगा दीजिए, सेवर में लगा दीजिए सकर, सकर सेवर में लगा दीजिए, सेवर के पीछे लगा, यहाँ पे लगा दीजिए, सेवर का ब्लेड लगा दीजिए। ये ऑफ हो गया, टॉप लाइट ऑफ। हाँ टॉप लाइट ऑफ, टॉप लाइट ऑफ कर दो, टॉप लाइट ऑफ कर दो, लाइट सोर्स ऑन कर दो, टीवी भी ऑफ है, टीवी ऑन कर दो।
Very good afternoon. I would like to extend my sincere thanks to IAS and the organizing secretary, Dr. Rohit Lal Boss, for this opportunity. Probably this is one of the easiest topic to talk about, but at the same time, probably quite important because in spite of doing your best and giving your best efforts, your fixation may fail.
What was okay? क्या कौन सा ब्लेड, राइट वाला? कौन सा व्हाइट बैलेंस, राइट वाला, ऊपर वाला, लॉन्ग प्रेस?
So probably this is one of the most neglected, I can say, or an aspect which probably we never give much of importance. So the idea is just to prime up, especially the younger generation, the importance of the options we have while opting for graft fixation in ACL.
दोबारा घुसाते हैं, ऐसा सिस्टम। रिलैक्स कर दे, ट्रोकर कहाँ? ट्रोकर डिग्स दे दो नीचे। छोड़ छोड़।
So ever since ACL reconstruction was done arthroscopically first, probably lots have flown below the bridge and lots of options have come up. What we need to understand is either we are fixing bone or the soft tissue, and that will decide what exactly devices we can use. So it can be either on the femoral side or the tibial side.
Like stab knife.
So basically, if you look at the femoral fixation, probably based on mechanism, divided like compression devices, which produce compressive loads to the longitudinal axis of the graft. Examples would be interference screws and bone plugs. So that is something like we all most probably be using more interference screws. Rather expansion devices producing a bulging of the graft. Example would be cross pin. Suspension device, probably that is what being used more oftenly by all of us. And that is usually in the form of endo buttons. There are also other options like swing bridge and ligament plates. That is for cortical suspension basically. Then there are cortical cancellous suspensions in form of cross pins and bone mulch screws, cancellous suspension in form of links ST. But probably we use more of endo buttons. As far as tibial fixation is concerned, what is important is to understand that this is a weak link. So whenever you think of going in for your rehab, then what is to be remembered is what kind of fixation you have used in tibial side. That will decide the aggressiveness of your fixation. And why it happens? Because there's lower bone mineral density in the proximal tibia compared to the distal femur, and the angle at which the forces act, probably they are not in favor compared to the femur side. So your fixation, graft fixation, has got high chance of failure on the tibial side. So probably that is the reason why most of us, or like many times, we consider fixing it by two methods, by what we call as hybrid fixation. So intratunnel and extratunnel, probably we have seen even in the morning, like how it was done, especially in PCL during the live surgery. So what we need to understand is ultimately the graft has to integrate with the tunnel, or else your whatever beautiful done surgery gets wasted. So we need to understand that depending on what kind of graft you have, so whether it's bone to bone or whether it's soft tissue to bone, which you are aiming for, it may take around 6 weeks to 6 months for the graft to take up. So depending on the graft fixation device which you use, that crucial period is important. Otherwise, if you go slightly aggressive, then you may land up having graft failure. So like already has been talked, I mean, so much have been talked about graft selection, the tunnel position. Finally, graft fixation is again something which we all need to understand the importance so that we can have a good fixation, rehab, and ultimately a good outcome. So we need to understand that having fixed a graft, we will be encountering graft motions as well. So it can't be like once you have fixed the graft and you start the rehab, so there is not going to be any motion. We should not be having that kind of a misconception. The graft will move across the tunnel. It will move horizontally as well. So what we call as bungee cord effect or wind viper effect. They also creeping of the graft tissues, and all this can lead to loosening and maybe elongation or loss of the stiffness or the loss of the integrity of the graft. So we need to understand that all these things need to be taken into consideration while opting for graft fixation devices. So as was like discussed regarding the graft strength, so we also need to understand these three factors which decide the graft fixation. Ultimately, that adds on to the graft strength, stiffness, and slippage of the graft. So not only the graft, but also the fixation device, these three factors will come into play. So what would be an ideal fixation? An ideal fixation would be strong enough to avoid failure, stiff enough to restore knee stability, at the same time secure enough to avoid any slippage. So ideal graft fixation should be anatomical, it should be biocompatible, safe, reproducible, MRI compatible, because of course that's of major concern nowadays, especially if you yourself want to go back and look at what exactly, what kind of a thing has happened, or maybe, future scenario where you find some complication or a revision scenario. And at the same time, it should allow easy revision. Probably not all the times you will be able to fulfill all this. You have to go for a compromise. So types of fixation again can be considered as aperture fixation and suspensory fixation. A lot has already been talked about and mentioned time and again during the discussion. So aperture fixation What usually we use is interference screws, which we have seen even during our live surgeries today. Suspensory fixation, most of the times we use endo buttons. The advantage of aperture fixation, it minimizes the graft tunnel motion, so it gives more rigid fixation, less femoral canal widening, and creeping is also less. Factors which influence the interference screw fixation, it is decided by length, size, and geometry of the screw, divergence of the screw, torque of the screw insertion, the bone mineral density will also matter, and finally the screw material. So all these things which should be taken into consideration, starting from exact selection of the device and at same time execution while inserting the interference screw. So length screw, probably longer the screw, better the fixation. Size, screw diameter should be 1 mm more than the tunnel diameter for soft tissue grafts, and it should be same for bone plug grafts. So geometry, soft threads for soft tissue fixation, otherwise it's bound to cut through the tissues, and use of reverse thread screw for left side. I don't know how much practically that is being used, but that's what is recommended. Insertion torque, more the resistance while inserting, better the fixation. So that's why we also must have heard the squeaking sound while surgery was being done and interference screw was being. So that is a sign like the diameter and insertion torque is quite good. So tunnel dilatation, probably this is something which maybe I would like to get comments from our panelists and even the faculties. How much of us are really practicing, I don't know, but then probably we should be going in for a 2 mm, by under-rimming 2 mm and then impacting the bone. Probably that is to preserve and to have a better bone stock and the same time better hold of the interference screw. Now this is quite important, something which needs to be emphasized again and again, because what happens is you might have done a very good job with the tunnel placement, but while inserting the screw, you toggle a lot and you will end up diverging it more than what exactly it was supposed to follow. So more than 20 degrees of divergence will compromise the stability. So that is the importance of following the tunnel. Now, BMD is something again which is not in our hand, but then we should try to go for hybrid fixation wherever we come across a bone which is not that strong. Now, bioabsorbable screws, of course, they are the most hot favorite nowadays, but then we need to understand that they do seem to be having advantages in terms of there's no need for a removal. They don't interfere with their MRI compatible. They are easier in revision scenarios, but then they also do break. So we should understand that we have to be quite careful, and the specialized screwdrivers provided should only be used. And too much of divergence can also lead to breakage while inserting. Tissue reaction in some patients can be an issue. Fixation lost after partial degradation is again reported, and that can lead to your failure of fixation. So obviously, I would say that this probably depending on the material used for these screws, their strength rapidly decreases, and they can also sometimes lead to, because of local tissue reactions, widening of the tunnel. Now, metallic screws that ways seem to be having advantages, like they have got high initial fixation strength, but then they may not be that compatible with MRI because they distort the images, and especially in revision scenarios, that can become difficult. But then probably that is being conventionally time tested, especially with the titanium screws, because that's quite cheap and cost effective. Suspensory fixation, again, as I said, endo button is the most commonly used, but then tightrope is again gaining popularity because of obvious reasons that last moment you can make some changes with the stability of the graft. So endo button, we all are quite familiar, like how it's done, but we need to understand that the two parts of the tunnel, femoral side we are talking about, the one is meant for the graft, the whole other part is meant for the endo button to pass and just to get flipped. So Maths of endo button, it's quite simple, and we have seen even during surgeries, nothing much to discuss in that. Tightrope, as I said, that is probably over a period of time going to be the most commonly used method of suspensory fixation. Bone plug fixation, femur again, these are all the options. On tibia side, we got same different options. Soft tissue fixation on femur side, as I said, suspensory ones, these are used most probably, but then even on tibia side soft tissue, you can have different combinations and permutations. Tibial versus femoral fixation, as I said earlier, tibial fixation is less secure, so there's no harm going in for hybrid fixation, probably in most of your cases. And you need to take into consideration the bone strength as well. So just to conclude, in the early post-op period, fixation is the weakest link. So in spite of the best of the surgeries, if you have not been very careful, considerate enough to go for the best fixation, then you may land up having a failure. So tibial fixation is a greater risk of failure. So better to have hybrid fixation wherever you feel important. Clinical results of various methods, although literature it's not very conclusive and they are comparable. So maybe that is the reason where probably we go more by our own conviction and our experiences rather than going by these theoretical talks. Aperture fixation seems to be theoretically better. Interference screws are gold standard as far as tibial side is concerned. Tunnel dilation improves fixation. So probably we should not just be drilling. We should under drill and then same time impact the bone. Again, I would like to get comments from faculties regarding what's their take on that. Hybrid fixation definitely is always safer and better, especially on tibial side. So thank you for your patient here.
Thank you. Very nice presentation.
Nirmal, you have mentioned BMD estimation. Do you do it routinely in the for the cases,
No,
or
we don't
just
do it, sir. But then, like it's always like we go by our own feeling. We feel bone is not that good enough. So, anyways, it's always better to go for hybrid fixation. I mean, if you find, especially on tibial side, bone not that strong.
Another
But
question.
maybe it's not a bad idea. I mean, if you have got elective cases and you've got sufficient time and resources, you can go for B. Practically, it's not.
Nowadays, are you doing the reverse Lachman while fixing the tibial component?
Pardon, sir?
While fixing the tibial screw, are you doing the reverse Lachman and you do the reverse Lachman or you do it in neutral position? What do you do? Posterior drag. Yeah.
Yeah, basically we do,
Is there any scientific evidence that if you don't do, then there will be some problem?
maybe I'm not the right person to answer that, but then.
Sundar sir.
I don't think any direct evidence or something like that to do the posterior dryer. But usually it is not required because your all other structures are normal. It's not going to go forward or backward too much. So
Unless and until it is a very chronic tear and
you have a
subluxated
injuries, and if you
yeah.
miss the ramp, if there is excessive anterior translation, then in that cases it's important. Otherwise,
Thank you.
glacial doesn't matter.
Thank you.
So it's more to do with like how we have seen people doing and probably.
Yes.
That's what we have been doing. Sort of convention.
So now that there is a video presentation by Dr. Sachin Tapaswi from Pune, he is IAS president. Rohit.
So today's topic is why should we save the meniscus? And if you look at the meniscus, you will see that there are two lovely menisci, medial meniscus.
ठीक है 40 ही है 40 ठीक है 30 तक करो आप देख लो चला जाएगा तो कितना কত না না ডায়ামিটার 9 তো চলে যাবে তো খুলে যাবে না তো हाँ 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 चलो 30 तक करो 30 30 और एक मिनट क्लियर कर देते हैं
functions. The medial meniscus carries about 50% of the
দাঁড়াও, হাতে দেখা হাতে
lateral
ঘোরাও, হাতে ঘোরাও।
meniscus carries about 70%
চলে
of
গেছে
the
অনেক
lateral
20।
compartment.
হ্যাঁ,
And if you look
30
at
तक
the
चलो।
ACL individual, which is a fairly common injury that we see in our clinical practice,
30 करो, ये 30 चला गया। हाँ, हाथ में जाओ, थोड़ा घुमा दो। हाँ 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 हाँ, अब निकालो।
on the same
ड्रिल
hand,
रोड।
almost about
हाँ?
40% of all ACL fractures will have a lateral meniscus tear.
हाँ।
The main biomechanical functions of the meniscus are those of load transmission, which is the main role. The menisci allow to transmit load from the femur to the tibia, and they
টিবিয়া কি করে রাখবো?
to circumferential foot stresses.
মিডিয়াল সাইড থেকে
The
দেখে।
roots of the meniscus are play an important role. They help dissipate the force in the subcondylar bone area, and hence the meniscus root is now recognized to be an extremely important reason for getting back the stability of the knee joint. When you perform
ये से देखना पड़ता है हर वक्त। आफ्टर डूइंग दिस you always have to see। हाँ, देखो ये तुम्हारा देखो differential tunnel। हाँ, these things you have to always see। There is bone in the posterior cortex। हाँ, bones all around and you have a tunnel there। ठीक है, चलो।
This is more important on the lateral
ক্রিয়া
side.
করেই নি।
Because on the
এটা
lateral
টেনে দেবে সুচারগুলো। কোনটাতে করে দিয়ে ইয়ে তো ইয়ে টানেল তো মার্ক করে নিয়েছো সব। হ্যাঁ, চলো ওটা টানাটানি তুমি করবে।
location with respect to the zones of the menisci.
40 টানেল 40, তাই তো? গ্রাফট কত রাখছো? 15।
But on a broader aspect, you can
18।
classify them into traumatic tears, which are essentially seen in young athletic individuals, which are usually associated with an ACL or some cruciate tear, and they're usually of a peripheral longitudinal type and are amenable to repair. On the contrary, you have degenerative tears, which are seen usually in patients above the age of 40-45. They will occur with a trivial injury, and you would find that there are pre-existing degenerative changes in the cartilage, and the meniscus may not also be of normal quality. These may not have the same healing capacity as that of a traumatic tear, and these are usually of complex tear patterns, and repair may or may not be possible. It was way back almost 100 years ago that the meniscus was found to be capable of healing if the tear had access to a synovial blood supply. And Warren and Ornoxy, about 40 years ago, did show us that the peripheral capillary plexus, which originates from the synovium and the capsule, richly innervates and supplies vascularity to the periphery of the meniscus. So based on the same, you can classify tears of the meniscus as zone 0, 1, 2, and 3, based on whether it is at the level of the capillary plexus or with decreasing vascularity towards the central area. You could also classify them based on the configuration, as we discussed, whether it is a radial tear or a flap or a horizontal cleavage tear or a longitudinal vertical tear, which is what we need to look into in proper details. On the basis of chronicity, a chronic tear is less likely to heal, and which is why we must look at this aspect very critically, because a tear which has been out for a very long time may not heal properly at all. And of course, we need to look at the age of the patient. Older the patient, less the chances to heal, and a non-compliant patient is someone that you should stay away from. An unstable knee needs to be corrected before you perform any form of meniscus surgery, and this becomes critical because if you leave a knee that is unstable, the meniscus repair is bound to fail. If you look at surgical techniques, the meniscus can be repaired with an outside in, inside out, or an all inside technique based on the zone or the area of the meniscus. And we now have better devices of all of these three techniques, which allow us to repair more and more of meniscus zones with increasing ease. If you look at the repair principles, we understand that we should perform divergent superior and inferior vertical mattress sutures, something which will be highlighted by my next speakers. Why is it important and critical to repair? It is important to repair because if your meniscus repair tides over the first 24 months, after the repair,
then there is a good chance that it will survive for more than 10 years, which is very important. And this happens because 20% of the meniscus repairs will fail, and probably they could be as a result of a wrong indication or a poor technique or a meniscus which did not have good biology. Another important critical aspect is that if you remove the meniscus at the first go, then you will perform a meniscectomy, which is 85% more than what would be if your repair failed at a later date. Also, this study showed that you will have a 50% higher chance of landing up with a chondral lesion if you perform a primary meniscectomy. The association between anatomical healing and clinical results has also been demonstrated that with improved meniscal healing, there is improved clinical outcomes. Also, it's very critical to understand that if you perform a meniscus repair, you are more likely to not get osteoarthritis and you are more likely to return to the pre-injury levels. So which are the factors to consider? I think consider tears which are in zone 0 and zone 1 and some selective tears in zone 2. Definitely repair all the lateral meniscus tears as much as possible. They stand a lower risk of failure than the medial tears. Repair the smaller tears for sure. If you have a longer tear, then it may lead to a poorer prognosis because the healing rates may be lower. But please understand that if you perform a large meniscectomy, you are definitely going to get a poor result, which is why you should try and repair as much as possible. It's also important to understand that partial meniscectomy will lead to lower reoperation rates than meniscus repair. And this is more so on the lateral than on the medial side. But what is important and critical to understand is that we need to do a good combined repair if we want to ensure that we want to have good stability and good outcomes. The Lishom scores and the amount of chondral degeneration is definitely going to be more when you perform a meniscus repair, and that holds true for osteoarthritis as well. So to conclude, to save meniscus tissue is of prime importance. It prevents osteoarthritis and restores normal biomechanics. You need to be aware of the various different methods of meniscus repair, including those for hidden lesions, which are the ramp and the root tears. Thank you very much for your kind attention, and I hope to meet all of you soon in person.
Thank you, sir. Are you all online? Cut, yes, cut. Okay. So now the next speaker is Dr. S.R. Sundarajan. He'll be speaking on perfect tunnel placement. Dr. Sachin Tapaswi, sir, are you online? Oh, he recorded, he sent the record. Okay, okay.
निकाल देते हैं बाद में वैक्यूमाइसिन दे दो सब कुछ
Looks like most of them went for lunch or went home.
हाथ हाथ ऐसे करो ना हाथ पीछे रखो हाथ पीछे ही रखो हाँ हाँ बस हाथ को सामने मत लाओ ठीक है
Sorry.
ছবি তুলে নেন, হলে বলবে যে বলেগা কি
আমার ফোনটা আমার ফোনটা কোথায় তোমাকে দিলাম
What has happened? Actually, Dr. Sundarajan has to go from.
So should we go live? Dr. Pavan, I am Dr. Somodi from the theater.
After that, we can have a
I am
break
ready
for the
with
lunch.
my
We are stuck between lunch and the session.
yes. So I am standing between the lunch and live surgery.
Session, no. But he has the paper
Okay, paper. Okay.
in between.
Sundarajan, sir.
Dr. Somya. Dr. Somadeep.
Yeah, yes. Can you see and hear me, sir? 10 minutes, sir. We have done all the things. Can you see?
Somadeep, you are fine?
Yes, I have joined. Can you see, sir?
Can you say something regarding the patient profile?
Yeah, this is a 30-year-old patient. He is a footballer by profession. He has a injury while playing football 2 months ago. Classical anterior drawer pivot sheet positive. He has so we have done all the things. We have harvested his ipsilateral semi-T graft. And
Okay.
it's a good graft. We get a four-folded the graft and get a length about 70 mm and a diameter is 9 on both sides. We use
Okay.
the four-fold semi-T graft and we have made the tunnel. So
Yes.
So we
So
have
it's
made
a
the
simple
tunnel.
ACLTR, isn't it?
Only ACLTR on meniscus
Okay.
and PCL. Can you see the pristine PCL there? Both the two
Okay.
bundles and both the meniscus are intact. So this is
Right.
the tunnel we have made.
So you have
So
made
it's a
the tunnel,
complete
okay.
ACLTR. It's a you can see the tunnel there.
Right,
It's
very nice.
low,
Yes, we
yeah,
visualize.
it's low there and oblique. It's important for the
Okay.
junior. See the orientation. I always use the accessory medial portal.
Okay.
So that helps to guide my drill because my probe is going to the accessory medial portal. Now, can you see the accessory medial portal? So it's
Okay.
directly perpendicular. So
Right.
otherwise you don't get the trajectory from your medial portal. So use
Okay.
the accessory portal or you can use a flexible drill guide if you have the luxury to use a flexible drill guide. So
Okay.
this is the tunnel. So I'll go from the medial side. Tunnel length is 40 millimeter. And we
Focus on
have-
the tunnels, please. Focus on the tunnels.
yeah, I will focus on the tunnel from my medial portal.
Okay.
So this is my tunnel.
Yes, yes.
Yeah.
Visualize. Very nice.
Yeah. So can you see that there is bone all around and just I want to clear the debris. Pump, please pump.
Some tissues inside.
Yeah.
Yes.
Can you see the intact lateral cortex there? So there is
Okay.
differential tunnel. This is very important for the juniors. Always go from the medial side. See that your lateral cortex is intact. But if it is broken, then you have
Right.
to don't use the suspensory fixation. Use the other mode of fixation.
Okay.
So, and tibial tunnel is very standard. I have passed the thread from the femur to tibia, and now I will railroad the graft.
Dr. Soumya, we have
Yes,
to
sir.
just have a break because Dr. Sundarajan is to leave for
Okay,
committee.
okay. So Sundarajan sir,
So
please
after he
complete your
finishes this
lecture.
paper, we will
Then I will
restart.
come
Okay.
back. Okay, okay, okay.
Okay,
No
okay.
problem.
Please,
Soumya,
please,
5
please.
minutes.
Okay, okay, please.
We will be back in 5 minutes.
Right.
Okay,
right.
no problem, sir. You go.
Okay, so we will come back.
Sister Vancomycin.
Okay, thank you. So I think all of you are aware about this. This is about the perfect tunnel placement in the ACL reconstruction. So if you see the average length of the ACL attachment, the tibial side is around 9 to 25, almost 17 mm. And if you see the width is around 8 to 9 mm. So always we make the width, but we cannot make the length. This is not possible. Both on the femoral side and the tibial side, it is almost same. It's such a broad width we can manage, but the length is very, very difficult to manage that. So when you come to the femoral side, the same issue.
almost it's like, if you see the length is around 16 mm, that means they are giving such a broad, lengthy attachment, but see the width around 89 mm so that we can replicate the ACL with the grafts. The two important landmarks which we have to know is one is the lateral intercondylar notch, otherwise bifurcate ridge, otherwise called a resonance ridge also. So that will help you in a chronic situation to make a perfect tunnel. Why it is very important? We know that when you do a revision surgery, the most common reason for ACL failure is your non-anatomical tunnel placement. So if you're an youngster, it's very important that you have to make sure that you make it a correct tunnel so that you don't miss it. So these are the two revision cases of videos. You see the tunnels, where was it made? You see that is the front, and that is where original tunnel was made in the first surgery, where it is supposed to be in the entire, it has to be in the posterior part of your notch. You see your tunnel is so anterior. And you can see that another video, you see that that is where supposed to be your tunnel. You see the tunnel here. So how this ACL will survive? Naturally, it is going to fail. So the most important mistake you should not make when you do an ACL reconstruction, don't make an anterior tunnel. So that is a very, very crucial. Initially, when we thought of doing an anatomical ACL reconstruction, we thought of putting a midpoint between your anterolateral and the posteromedial bundle. But that will bring you your graft will be more anterior and low. So better to go slightly more posterior and slightly higher so that the graft will not fail at least. So when you do the tunneling again, making the more medial placement of your entry point, creating a very circular or normal tunnel, which is exiting your middle of the thigh. But if you are making a very close to the patellar tendon entry, sometimes it will almost make in a vertical tunnel, which was used like before what we use a transtibial technique. So better to go for a fore-medial portal like this, or you can make a three-portal technique where you can make another higher anteromedial portal. So you can visualize through the anteromedial portal and work through the fore-medial portal. That is also a technique described. Some surgeons do that. But I do through the anterolateral portal and also the fore-medial portal so that I don't make another portal. And we know that during drilling, you make it at least 110 degrees to get a longer tunnel. That is very important. And you can see in this case, the most important make a tunnel, your entry is very critical. So make sure that you use a needle before you make your portal on the medial side. So you make a needle, you see the knife, which is just perpendicular to your ACL placement. It has to go to the posterior end of the notch and it has to be lower. So that will give you that portal placement is very crucial. Suppose if the portal placement is not okay, you can make another portal, doesn't matter. Don't worry about making another portal. And it is important to clear all the soft tissues in front of you. Take off fat pad, take off the soft tissues in front of the notch like this, so that your entire notch has to be visualized when you see through from the anterolateral portal. If you don't remove the soft tissues properly, then you can make a mistake. You can make a resonance ridge is the posterior end and you can make an anterior tunnel. So it's important that you visualize. So otherwise, you're going to use even a wand to go end of the tunnel, and make sure that you clear that area so that you can visualize that part is very important. Don't have any remnants when you are in a starting part of the career. Don't worry about the remnants preservation. So make sure that you make and clear that entire notch and make an entry point. So you make an entry point through this kind of awl. So you can see in the first cases is always easy. You can see the footprint. Today morning also we saw in the live surgeries. That is the footprint. That is the anterolateral. This is the posteromedial. So here we are not making a portal tunnel. You have to make a tunnel in the more of anterolateral, less of posteromedial. So that's how you don't your tunnel doesn't come very anteriorly. So you can see there are two, it is as I showed you in the morning, you can see that this is a nice case where you can see the entire footprint you are able to see in acute cases. So you don't come too anteriorly to make a tunnel. You make a tunnel, that is the upper border of your footprint. So you see the notch going up to here. You don't make a vertical graft. So that is the upper border of the footprint. So you make an entry point just over the anteromedial portal, more of anteromedial tunnel bundle, so that you create this kind of perfect tunnel. So that is the key when you make a tunnel here. When the chronic cases, which I talked about, one is the bifurcate ridge, another is the intercondylar ridge. So this is the intercondylar ridge, and it's a bifurcated ridge. So this, you can see that is the upper border. So your tunnel has to only come here, not over there. You see the mark here. So that is easy. That is not very tough. The other method is that you can use a ruler to make it 40% or 50% from the posterior end. That will give you again anatomical tunnel. Don't come too anteriorly. As you see here, you can go blindly also by seeing the residence ridge over there. You can knock it over through small hole and create a entry point like this. This you can see. I will also show you the same entry point which I created by blind. Also you can confirm if you are using a ruler. You can use the ruler and confirm it's a 40. And also if you see, if you are worried about using, or you can use a notcher also to make a, like what we showed in the morning surgery, you can use a 6 or 7 mm offset guides are available. That will give you a good fulcrum to create a tunnel like this. So you should not come anteriorly like this. This is the posterior. You can see the 2 mm cortex is intact. That makes the tunnel perfect. And also during surgery, I showed that if you are making a perfect entry point, it has to be in the middle of the thigh. Not too low, not too high. If you are too low, that means you are too anterior. If you are very high, it is in the vertical. Even if it goes slightly higher, it doesn't matter. Your graft will not fail. Because we know that I was doing transtibial approach for almost 8 years, 10 years from 2004 to 10. We never had a graft failure. Even though it doesn't have a rotational control, it will not fail. But if you put a guide wire here, that means your tunnel is anterior and very low. The chance of failure is very high. So better to avoid that lower entry point. If you go a little higher, it doesn't matter. When you come to the tibial side, I think already we spoke many times. You see the anterior horn of the lateral meniscus. When you keep a jig, don't come too laterally. You should keep it slightly medially because your orientation should go from here to here, not here to here. So you have to make the entry point slightly lateral in the lateral part of the footprint. So that will give you good entry point so that you can do a serial reaming. I think morning we have discussed this. I don't want to discuss again. You do the 4.5 first, insert the guide wire so that you can adjust your entry point. You can make you can make more medial or more lateral, anterior or posterior so that you have a good orientation of the ACL. This is the normal orientation of the fibers, which you will get it through that. To conclude, always look for the remnants of the tibial side, even the femoral side. It will help you to make an entry point. More of anterior medial bundle which you are making so that your chance of failure is less. And don't make it too low and anterior. And the medial portal technique, for medial portal technique, there is a transportal technique. It's the technique which we use all of us now. In chronic cases, these ridges will help you to make an entry point. In tibial side, slightly make more medial entry point so that your orientation will be better. And the serial reaming will help you to prevent the blowout of the tunnel as well as damage to the anterior horn of the lateral meniscus. Thank you very much.
Thank you. Thank you so much. Yeah.
So we were making. So usually when we did the transtibial technique, we used to put a graft in more posterior. You know why? Because your orientation was like this. You cannot make a more anterior, that give a lot of graft impingement. You come anteriorly when you do a transtibial technique. Now we are doing independent tunnels to the transportal technique. So it doesn't matter. So you don't need to be a too posterior. You can make in the middle of the footprint. That is what is really important. You don't come too anterior or too low, too posterior. So always you go in the center of the footprint and slightly on the medial side so that you don't damage the anterior horn of the lateral meniscus. And as well as you don't go too posterior, too anterior. Because sometimes people think that it's anterior. What happens when you do that? Sometimes anterior blowout also can happen. So don't come too anteriorly. And it corresponds, your 2/3 of the ACL corresponds to the anterior horn of the lateral meniscus. So you orient that, your entry point should be there. And another important point which you note that what kind of jig you use, whether you use a pointer, point aimer, or a elbow aimer, or the footprint aimer. So the footprint is so easy because just to keep in the center of the footprint and drill. So that helps you to make a perfect tunnel in the tibial side. Absolutely. And most of the tunnel fail not from the tibial side because of the femoral side, because of the anterior tunnel, which I see when you do revisions, most of the time it's a tunnel placement, anterior tunnel placement.
Thank you. Thank you so much.
Thank you.
And I think you are leaving for the.
Yeah, you'll have a lunch.
Wish you, wish you a very safe journey, and thank you, that you have come and attended this. Thank you so much from the Jharkhand. Yeah.
Sorry? Third. I came for a foot and ankle.
Yeah.
Then you were central zone meeting and third. Thank you. Thanks.
Should we go live? Pavan sir? So this is our tunnel. So we'll pass the graft. So we'll railroad the graft from the tibia to femur. We are using a Smith and Nephew adjustable loop. So tunnel diameter is 45. So we have marked that, and we'll put the graft around 20 mark. So this is the graft going. Now I will go from the medial side, see the graft is. I'll see the medial side. So this is my graft going. Yes, that's the button. Going, pull. Pull.
Oh, then your paper will not be there. Paper?
This is the marking. So it is just on the mouth. See, pull. I am pulling it. It's done. So we can that correspond to our marking there. So now the loop is the end button is fixed to the lateral cortex. Now I just come to the anterolateral portal and so now my graft will go into the tunnel around 18-20. The mark is there. So now the graft is coming.
What is the diameter of the graft?
It is 9 mm both in the tibia and the femur.
Okay.
Yes. Now it is going. Can you see the mark? That is around 20 mm.
Yes.
So my 20 mm graft will be in the femur.
Okay.
Pull. It's done. Okay. We are not using a screw. Now the graft is gone in the femur. Can you see the very good graft and the orientation of the fiber? Yeah.
Consistency is quite good.
So this is an oblique graft, and can you see that it's on the posterior aspect and posterior inferior. And now we'll fix the graft in the tibia with a loop, with a disc. So the next step we'll do, hold it. That is the cycling. It's a very important thing. We'll see the impingement. I am just extending. Can you see the graft is not impinging on the femoral notch? And now I will do the cycling to take away all the creeps from the graft. So it's very important to do cameraman please focus outside, pull the graft and do a flexion extension of the knee.
Camera on the picture. Yeah?
Can you see my hand? Cameraman focus. So this is very important. Do it for 10 to 15 times. That will take away all the creeps from your graft. And then we'll see it again. And finally.
Stability is okay.
So it's an adjustable loop. Sometimes there will be some creeping and everything. So this tensioning is very important before going to the tibia fixation. Now we see that graft is very perfectly placed. 4-stranded semi-T is good enough. So now we'll come to the tibia fixation.
Okay. So you have fixed the femur. Now you'll fix the tibia.
Yeah. So now we'll go for the tibia fixation. Light, camera, light, please, top light.
Which position you will fix?
At 30-degree flexion.
Okay.
Hold it. And neutral rotation.
Okay,
Light.
neutral rotation. So you're
I will hold, you put the note. So I will just put the, can you focus, see the button? So disc is just, I am pressing the disc over the tibia to press it, and someone will hold the knee, put up
this is your 30-degree position, isn't it?
30-degree position.
Okay.
Just knee, flex the knee. Flex the knee to 30-degree. Huh? Chalo. So you can see that there are 4 threads there. It's a cross thread. So I am just pressing the disc.
Your back is coming. Your back is coming.
Okay, I will show that, just doing this, and then I'll show the fixation.
Got a break.
It is economical and time saving,
Okay.
and that's sometimes what happens, your screw may cause screw may impair with the thread. Your graft can.
What is your screw size?
There is. I'm not using any screw. I am using a disc there. Can you see the disc? It's nicely. Cameraman, please focus.
So not visible actually.
Yeah, this is the disc.
Okay.
This is
We
the
are
disc
using
I am
the
giving. I am
disc.
giving an 8 stand of thread. I have put these threads tied over the tibia, over the disc. So it's a cortical fixation. Now I will see it.
Okay.
If any laxity there are always a
So
scope.
this is the buttoning system.
Cost-effective method of
Yeah, cost effective.
very
Yes,
cost-effective.
Yeah.
You can do for patients who are
So that is the
Poor
graph. I
patients.
will
Poor
give me a
patients.
probe. So I will see the tension. If any stage there is lax, you can always retension with your tunnel. No, just leave it. That's you can see that it's a very good, well tensed graph there. So I don't have to do much more tension.
very good technique. Very good.
Yeah, you see the orientation, and that's done. Okay, so
Yeah.
we'll go for lunch. Yeah, you'll see the disc. I'll show with the scope also.
Scope wala.
Aperture is, it will fix over the.
Yes.
You can see. This is
Yes.
cameraman. Please focus. This there is no movement. Disc is still is fixed to the tunnel. So it's there is
Stuck
no
to the
movement.
tunnel, isn't it?
Yes. So that's a very good fixation. It's a cortical fixation, very strong fixation. You can mobilize the patient from the next day.
Okay.
Okay.
Very nice.
Thank you.
Very good method. Thank you.
ঠিক আছে চলো এগুলো খুলে দে আর মারিস না তখন সেলাই উঁচু হয়ে
So this was the second last case. Now we will move to the last case, which will be done by Dr. Gurudev and Dr. Ujjwal Sinha. And meanwhile,
one paper is left. I think that can be concluded. Isn't it, Rohit?
Dr. Gurudev will be operating. Abhinav is here. Dr. Abhinav.
Thank you. Thank you.
Thank you.
One more paper is left, or you will be. You can have a break. Okay. 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 लंच लेके आता हूँ लाइव नहीं आएगा Ruth will continue.
Then yeah, same session we will continue as this because many speakers are busy.
Yes.
Dr. Rajiv Raman is busy. Gurudev is
So
busy.
Rajiv is not coming.
No, he will come in 10 minutes.
Okay.
Meanwhile, we can have one presentation. Okay, if nobody is free, I'll start my presentation. So Dr. Abhinav will do one presentation on what are the complications of ACL.
सिस्टर मेरे को 2 थ्रेड रेडी करके रखना, ठीक है। ग्राफ्ट हार्वेस्टर, यस, ग्राफ्ट हार्वेस्टर, रिट्रैक्टर रेडी रखो। बहुत ज्यादा चीज की जरूरत नहीं है मेरे को, सो मैंने इतना नहीं चाहिए। चलो स्टार्ट, शुड आई स्टार्ट? चलो एक मिनट ऑन करेगा हम, आप इधर चलो। एंटीबायोटिक गिवन राइट साइड, कंफर्म किया है। चलो चढ़ाओ, यस। व्हाइट बैलेंस दिखा है, ओके ओके। स्पीड देना थोड़ा, इसको हटाओ, रखो सिस्टर। टूल देना एक बैठने को,
टूल दे दीजिए बैठने के लिए।
फोटो कीजिए इतना। आई सिस्टर यहाँ इधर आ जाओ, यस। फोटो फोटो नोट वीडियो फोटो, यस ओके।
So,
yes,
thank you for the opportunity,
okay.
Ias and the organizing committee and Rohit Lal sir.
Tool, please.
Today I'd be talking about complications in ACL reconstruction. So the patients usually present with persistent pain, instability,
एक आदमी यहाँ खड़ा रहो,
swelling,
यहाँ
tension,
रखो,
and
सब कर लेंगे।
stiffness.
टूल आगे करो, आगे इधर।
Most of these reasons occur, most of the complications occur due to some reason or
इधर,
the other.
इधर,
So
ठीक है,
starting
बैठे।
with errors in diagnosis and judgment. Timing of surgery is very important, as we all know. The range of motion should be at least 0 to 90. The knee should not be hot as such, and if you do it too soon, may lead to post-operative stiffness. Whereas if we do it too late, it may eventually damage the meniscus and the articular cartilage due to persistent instability. And incorrect diagnosis and missed additional diagnosis like MCL tear, meniscus tear, etc., should be taken care of. Complications can also occur during graft harvest, like the dreaded complication of dropping the graft while in the OT. So wherever possible, we should change the graft. We should take the other graft if possible. Otherwise, disinfection with chlorhexidine 2 to 4% solution or a triple antibiotic broth can be done. Patella fracture can occur while taking patellar tendon graft or quadriceps tendon grafts. We should avoid taking deep V cuts and graft defects, and we should graft the defect with trimmed bone plug wherever possible. Proximal transection of graft, like the amputation of graft, can occur in hamstring tendon harvest. So we should release the CBT facial bands very properly before proceeding with the harvest. Saphenous nerve injury can occur while taking the hamstring graft, especially the sartorial and the infrapatellar branch. And hyperesthesia or numbness of the medial aspect of the knee can occur because of that. MCL injury can also occur during hamstring harvest. And hamstring weakness can occur if we remove too much muscle tissue with the graft. Complications can also occur due to graft sizing, like in BTB, the bone patellar tendon graft. The tunnel length can mismatch due to the length of the graft that we attain. So if the graft is too long or too short, it may compromise the fixation and warrant additional fixation or alternative fixation, and maybe even the graft options can be changed. Whereas if there's a width mismatch in BTB grafts, if it's too big, we should trim the graft. And if it's too small, we can use alternative fixation methods like staple, suture post, endobuttons, etc. Oversized graft may lead to impingement. So wherever possible, we should measure the footprint with the scale, as we've seen Sundarajan sir doing it in some cases. It would prevent overstuffing. And the most important errors that we make are during tunnel placement and graft fixation. So tibial tunnel, if it is placed too anterior, may lead to impingement and loss of extension, and there would be higher tensile load on the graft during extension and may lead to failure. Whereas if it is placed too posterior, the graft would be vertical and there would be poor rotational stability, as was the case with transtibial grafts earlier. And PCL impingement can also occur, which would lead to early failure. Femoral tunnel placement, if it is too anterior, we saw the last presentation by Sundarajan sir, would lead to impingement, loss of knee flexion, and early failure. And if it is placed too posterior, the tunnel may blow out and may compromise graft fixation if we're using the interference screws for fixation. And if the femoral tunnel is placed too vertical, may lead to poor rotational stability. And if the graft is placed in excessive knee flexion, then there would be loss of extension and patellofemoral pain. Also, we sometimes have to do notch plasties, especially in V-shaped notches. We usually widen it for a better visualization. If we don't do adequate notch plasty, we'll end up with impingement and graft laceration. Whereas if we do excessive notch plasty, it could lead to pain pain in the knee, secondary to articular cartilage damage and patellofemoral dysfunction. There would be, if there's a graft tunnel diameter mismatch, may lead to graft laceration or loose graft in the tunnel. And in cases of double bundle reconstruction, there may be tunnel convergence, complicating the surgery. Some complications are specific to fixation devices like soft tissue interposition and suspensory fixation with endo buttons. So it is more common with the adjustable loop, and graft laceration with titanium interference screws are common. Graft screw divergence can occur. We should try to keep it as low as possible. If the divergence of screw is more than 15 to 30 degrees with the tunnel trajectory, may lead to failure of fixation. Posterior migration of screw may occur, which may lead to potentially dreaded vascular injuries. And intra-articular migration of the screws can also occur, leading to cartilage injury and risk of screw breakage in the joint. If the tibial side fixation is loose, like in osteoporotic bones, we should use alternative methods like cortical fixation devices such as suture post or suture disc. And post-operative complications, very commonly, not so commonly though, we see infections, which may present with pain, swelling, stiffness, and necessitate the removal of graft. Aggressive treatment with lavage and debridement and IV antibiotics must be tried, and if it all fails, then we should remove the graft. Stiffness and arthropibrosis and also cyclops formation may lead to lack of range of motion, either flexion or extension. Aggressive post-operative rehabilitation should be done, and manipulation under anesthesia and arthroscopic arthrolysis may be warranted. Persistent instability may occur due to inadequate tension in the graft or inaccurate tunnel positioning, sometimes due to graft rupture or maybe even stretching. Geniculate artery pseudoaneurysms have been noticed at donor tendon site due to excessive synovectomy. Deep vein thrombosis, hemarthrosis, effusion, and synovitis can also occur. Femoral and tibial tunnel cyst and tunnel osteolysis. Significant osteolysis of more than 14 mm widening may lead to failure of your ACL reconstruction. Other complications include retractile capsulitis and iliotibial band syndrome and osteoarthritis. As we all know, it was overrated earlier. Earlier was reported as 50% after ACL injury and 70% with concomitant meniscal injury. But Keys and colleagues have recently reported it to be 0 to 13% after ACL injuries and 21 to 48% when associated with meniscus tears. Thank you so much.
40% है ना, उधर से हट जाओ, उधर से लो, देखो कितना सेंटीमीटर है। चलो पढ़ो फटाफट, हाँ पढ़ो फटाफट, इंटैक्ट है ना। आगे काम करें, 5 मिनट हो जाएगा। ए उज्जवल सर, दो नो नाइफ दो, जल्दी हो, ग्राफ ले चुका हूँ। इसको हटा देन, चलो नाइफ देन। कोई भी नहीं, उसको निकाल दो, इसको रहने दें।
So my topic is on grafts.
ग्राफ बनाने आता है अच्छे से।
So we are having the last surgery in the operating room. Dr. Gurudev and Dr. Ujjwal Sinha, they will be doing the surgery. So they are preparing the patient, and we will now have live surgery interaction. So those who want to interact can please come forward and ask questions, because this surgery will be more of detailed work. And if you have any query, don't be afraid of asking anything, because this is
Top light off, please.
we all want to benefit from.
हेडलाइट ऑफ करो, हेडलाइट ऑफ करो, हेडलाइट ऑफ करो।
Top light off, please.
थोड़ा लेवल उठा देता है उसमें सब काम। चलो हम रेमनेंट प्रिजर्विंग करेंगे।
वहां से कुछ है क्या?
फुट स्विच हैंड वाला नहीं है, फुट स्विच, फुट स्विच,
Put it.
यहाँ
Black.
दिस वन।
Visit 3,000. Plus.
उधर से थोड़ा सा लेगा तो वीडियो के साथ आएगा, फोटो उधर से लेगा तो वीडियो के साथ आएगा।
वहीं से बोल।
बिग टाइप लोग। हाँ स्क्रू, वो स्क्रू इस डिस्क देखा जाएगा, स्क्रू लो अभी। प्रो ये सब हटा दो, वहाँ पे रखा है चीज। बचाया जा सकता है इसको, बचाया जा सकता है ये नथिंग। पकड़ो इसको, रूट टीयर लग रहा है, पकड़ो इसको, पकड़ा। छोड़ छोड़ दो leave it yes पकड़ो hold पकड़ने से ठीक से रूट टीयर का समझ आ गया पकड़िए इसको रूट टीयर का समान है जी
रूट वाला सेट खोल दीजिएगा रूट वाला
कुछ नहीं यहीं पे लगा देंगे
फुल में
कंप्लीट
हो रहा है
क्या फोर में
हाँ तो डायमीटर
8 है ना हो जाएगा हाँ यस करना चाहिए यहाँ पे आउटसाइड थोड़ा सा हाँ बस पंच लेना पंच दो बस लो ये वाला देगा बैक बाइटर देना सुनना बैक बाइटर
So my topic was on graft.
Backbiter. नहीं backbiter. हम उधर से लेते पकड़ो इसको पकड़ो. देना अब देना. दो अब दो.
So I had a chance to go to Adelaide for a fellowship. So ideal graft, of course, it should be similar to ACL, easily harvested, least graft site morbidity and secured predictably, gets well incorporated with bone. So there are many autografts, synthetic grafts. So what I wanted to know, tell the surgeons who are starting, it is always important to know at least 2 graft harvest techniques. Either you know hamstring and peroneus longus. These are the basic techniques which you all should know, because if you are not able to harvest the semitendinosus, or if it is very small, you can always take the peroneus longus tendon. There is no harm in it. And also for multi-ligament, you have to use 2 grafts. So you can do semitendinosus gracilis as well as peroneus longus. So the basic graft is hamstring tendon graft. So this is my technique. Always I measure 6 centimeter from the medial joint line, and this never fails. So if you make a mark 6 centimeter from the medial joint towards the tibia, midway between the posteromedial border and the tibial tuberosity, you will definitely find your semi-T there. You have to identify the sartorius fascia. So sartorius fascia is the main culprit why we are not able to harvest the hamstring tendon, because it is sticking to the bone. It is a flared out structure sticking to the bone, and you cannot palpate the semi-T and gracilis without cutting and without going through the sartorius fascia. So you have to identify the sartorius fascia. So when you cut the skin, then fat comes, and then when you separate the fat, you will find a loose fascia. When you cut that loose fascia, then you will find a fascia which is sticking to the bone and which is concealing the hamstring tendons. So you have to identify that sartorius fascia. There is no harm in giving, especially when you are beginning to do it, there is no harm in making a long incision. You see how big incisions we are giving for MCL repair and things like that. So all these, don't be in a hurry to do it in a small incision. You can have a good dissection, and you can initially for my first few cases, I would dissect the entire fascia, entire nicely. I would go. There is no harm in doing it because you are not opening the joint. You are on the soft tissue side of the joint. So there should not be any, because hamstring tendon, why we are taking it? Because there's no anterior knee pain. There is no graft site morbidity. There may be some weakness, but it is not documented. So I just wanted to run through all these slides. So this is the diagrammatic. ये वीडियो है चला इसके बाद आइए. So there is no harm in giving a liberal incision. ये वीडियो रन करिए. So always use a sterile S-mark. And then this is the marking. See, I mark a point at 6 centimeter from the medial joint line. So this is my mark. Make a medial joint line mark and then 6 centimeter. Yeah. And this is skin and then fat. So this is a loose fascia. You cut through this loose fascia. Then you encounter a fixed fascia. So what I'm touching with the tooth forceps is, this is the fixed fascia, and most probably this is the sartorius. So I am splitting the sartorius now. So the sartorius is being split nicely. And now you can easily palpate the hamstring tendon. Now you can easily palpate the hamstring tendon. So skin, fat, one loose fascia, then a fixed fascia, which is the sartorius fascia. You split it through, and then you get the hamstring tendon. Problem happens when we don't split the sartorius fascia nicely. And then you can feel the tendon nicely. So this is the tendon, glistening tendon. And because there are two tendons, hamstring tendon as well as semitendinosus as well as gracilis. So the semi-T will be below gracilis, and it is a long tendinous structure. If you have any doubt, if you think that you have put, and if you have taken both the grafts together, you can go a little proximal, because if you go proximal, both the grafts split. So there is no harm in splitting and making another incision, or even making 2 centimeter more of incision to see both the grafts separately. And pass the thread with a loop. So we have passed the thread and loop, and now you have to go till the end of the bone so that you get the proper length. We don't want to get it short, so we erase it from the junction of the bone and tendon. And now you see the tendon stripper. There, one thing is missing in this video is there are two bands. One band is going posteriorly into the calf. So I don't know, that is not shown in the video. So you have to cut those two bands, and then only will you get the excursion of about 1.5 centimeter. If you are not getting the excursion of the tendons, then that means the bands are still there. So don't be in a hurry to put the tendon stripper. You release the bands and get the excursion of at least 1 to 2 centimeter. It will come out as a rubbery strand. And be gentle so that you don't cut through the, and once you are confident that it is gone inside, there is no problem in taking out these grafts. So all these grafts, the reason I took this photograph was we take it, we make a incision which is oblique incision so that there is no scar. So it is along the lines of Langerhans. This is one of my first patients. So this is the most commonly used graft. All of us are well versed. So you have to learn it. My advice would be not to be in, you can make a liberal incision while you're doing your first few cases and see all the structures. BTB graft, I don't think anybody is doing in Ranchi. It is a difficult thing to do, and it has complications of anterior knee pain and graft site morbidity. Now, another good thing which we are doing is quadriceps tendon graft. It is a very promising graft. This can be used for primary as well as the secondary or revision cases. It can be managed with good rehab. There is no quadriceps weakness because we are taking, quadriceps is a big muscle. So we are taking only a part of the quadriceps. So presently we are doing, I have bought an instrument called Quad Pro. So Quad Pro is an Arthroscopy instrument. So this is Quad Pro. I'm using this Quad Pro. This takes a full thickness graft and it takes a 10, you get it in different sizes. My Quad Pro is 10 centimeter. So you just make an incision over the patella or a horizontal incision, take a full thickness graft right through the bone, suture it, and then pass it through this Quad Pro. So this Quad Pro actually takes out a 10 centimeter graft, but it will be a small graft. So you don't need to pass an endo. It cannot be used as an endo button. So this is a new instrument by Arthroscopy. And I have taken out split the graft. Now this graft is coming out through a tunnel outside. And there is a scale. You see that a scale. And what I am taking out is about 11 centimeters of graft and 10 mm thickness. And you just pass this another trocar which cuts the graft. So this is the graft which you get, which is a very strong graft. The only thing is for fixation, you need a special endo button, and Arthroscopy has that that endo button has sutures. So you can suture this graft on that endo button and pass it through your femoral tunnel. So this is the quadriceps tendon. And these are all pictures. This is how it is done. So you take all the sutures, take a full thickness, and you can use your Quad Pro of Arthrex. There is another partial thickness graft, which we have already spoken about. ये video. Video. So this is peroneus longus graft. Now it is very well accepted. In case you are not getting a good harvest of hamstring tendon and in multi-ligament, you can easily take this. This is a very good graft to do ACL, PCL reconstruction. So there are two tendons which I am trying to show. One is peroneus longus and the other is peroneus brevis. So we have to take the long tendinous structure, which is the peroneus longus. So this is the peroneus longus. How you identify it? Because peroneus brevis will have more muscle. Muscle fibers will be more in peroneus brevis and it will be a thin graft. So there were literatures which said that peroneus longus should not be used because it causes problem in ankle. This is a video which I have put that I have used peroneus longus in this patient and there is no problem in any ankle. This is another patient I used peroneus longus. There is no problem in ankle movement or ankle power. So all these tests we have done and there is no problem in ankle joint even if you use peroneus longus tendons. And it's an easy graft to harvest. You cannot use it in sports persons. The only thing is, but you can use in women or people who are not into sports. You can easily use peroneus longus graft. So all these are patients who have done successful ACL surgery. So peroneus longus is a promising graft, still needs to be evaluated for its role in primary ACL, but we have not had donor site morbidity, but still has insufficient evidence because as a primary graft, it is still not used. But in some cases, if you can use it, if you are not able to get hamstring or if there's a multi-ligament injury, you can easily use. So all these are papers in support of peroneus longus. So this is one of my patients. So at least learn two graft, make your own choice, whichever you are comfortable with. Synthetic grafts are not available, but your graft technique should be reproducible and should not have any donor morbidity. Thank you. Live कर दीजिए यार.
इधर भी आएगा 20 से कैसे आएगा
आएगा 20 से तो यहाँ डिलीवर कर दीजिए.
पकड़ा है पकड़ा है ठीक है देखते हैं कितना रहेगा पकड़ा है ऊपर से वही चाह रहे हैं ना, मैं सोच रहा था ऊपर से, लेकिन दिक्कत करेगा था। नहीं नहीं, वो एडजस्टेबल लूप है, इसमें मामला फंसने का डर, हाँ है ना, उधर जाएगा, इसीलिए ये भी है, ये कुछ नहीं करेगा, इसके ऊपर चिपका रहेगा, चिपका रहेगा, ये चिपका रहेगा, इसको हम कुछ नहीं करेंगे। नहीं अभी ग्राफ रहने दो, तो थोड़ा पानी दे दो, क्लीन करो, दे दो थोड़ा सा पानी। ये से निकालोगे, कुछ है ही क्लियर है ना। लॉक करो 80%। वहां दूर से, हाँ अच्छा करना है, लेडी, हाँ हाँ है, हाँ लाइव कर दें, हाँ तो बोला है लेडी करना है, ओके आएगा, उधर रखो, ओके ना, ओके मॉप दो, एक टूल बैठने के लिए दे दो, मॉप रेडी रखना, कॉटरी लगाओ, रेडी है कॉटरी, हेलो फोन करके बताओ, go ahead.
Dr. Gurudev,
Yes boss, hello,
keep talking.
Am I audible? So this is a case of how many years, patient age?
So it had rotatory instability.
So this young man, he had injury of the ACL, and he complains of pain and instability at the time of doing his work on
He is
MRI.
an army man. You have to do it very nicely.
So on MRI, there is only mention there is a tear of the complete tear of the ACL. So we have harvested only the semi T and prepare the graft 4-fold, diameter 8.5 mm and length 7.2 centimeter. And he had some rotatory instability also. Okay.
Yes.
He had some instability, rotatory instability also. So my plan is to augment this ACLR with lateral extra-articular tenodesis. Should I go ahead?
Yes, very good. Good surgery. Please go ahead.
So before camera here, before proceeding this lateral extra-articular tenodesis, we have to mention all the bony landmark. So this is the tubular head, and this is the guardi tubercle, and this is the medial epicondyle. Marker pen. So, and this is the area of iliotibial band. So my incision is just proximal to the guardi tubercle, posterior to the medial epicondyle, in the line of IT band. Nice. Yes. Lateral epicondyle. Sorry, it's the medial. Lateral epicondyle. Sorry. So I take the straight incision proximal to the guardi tubercle. Tooth retractor. Remove the subcutaneous fat tissue to identify both anterior and posterior border of the iliotibial band.
So how will you fix your LET?
come on later stage. My plan is to fix it with the bio screw.
Okay.
But there are so many options. You can fix with a staple also, anchor also, and you can tie on the other side on the suture disc also.
Okay, thank
My
you.
plan is here to just fix it with the bio screw. Seizure, please. Usse, seizure, please. Knife. Then arthroscopy. So this is my posterior border of the IT band, and this is the anterior one, arthroscopy. So identify whole of the IT band, then measurement scale, please. Scale, please. Marker pen. Marker pen. Marker pen. So I took around 1 centimeter, yeah, or middle third of the IT band, approximately 80 millimeter of the graft from the girded tubercle.
So you're taking 8 centimeter from the Gerdy's tubercle.
Yes, yes. So, and
so this is a tensor fascia lata, which is being stripped off.
So
8 centimeter from the Gerdy's tubercle. 1 centimeter in thickness.
I am releasing it on the anterior aspect. Then on the posterior side of the IT band, in the line of girded tubercle. Yes. So 2%. Now I am detaching this one from the proximal side, keeping the distally intact. Now dissect this band from the vastus lateralis, not destroying the capsulo-osseous layer on the lateral side. इसकी खराब हो गई. So if you want, please, number 2. लो दो इतना कॉस्ट एक है दिया, दूसरा भी देता तो हो जाता. So I am going to put a stitch up to 3 centimeter. You can use the simple vicryl also, or number 2 ethibond also, not an issue. Or sometimes there is one graft stitch available. We are using that thread also. It is easy. So the only the ACL helps to reduce the anteroposterior instability, not the rotatory instability. It is the LET, which is just augmented procedure, add-on procedure on the lateral side to prevent the rotational, to give the rotational stability, and prevents the rupture of the graft, or you can say the increase the survival rate of the reconstructed ACL.
So this is an augmentation process.
Yes, it is just a augmentation procedure.
It is not a replacement for ACL.
Not the replacement for ACL. Seizure.
So you are just augmenting and making it more rotatory stable.
And simply, we can think that the ACL is the central structure. How can it prevent the rotatory instability? Okay, so the indication is mostly in the revision cases and young individual who involved in the contact sports and the hyperlaxity cases. Now,
do you do it in obese patient? Do you augment your ACL in obese patient?
We have some experience to high BMI patient. Now I am going to locate the fibular collateral ligament. So by doing the figure 4 position, we can palpate the FCL. पकड़ो इसको थोड़ा नाइफ लेना नाइफ 15 नंबर देना नीचे करो थोड़ा हाँ देना नाइफ देना so you see the anterior border of the fibular collateral ligament. We are not going to injure the popliteus. We remain extracapsular, and this is the posterior one, artiforceps.
The fascial lata, which was over the lateral collateral ligament, now it is being
thread. So this is the fibular collateral ligament. You can illustrate here by doing the figure 4 position. It can be easily palpable. Now you can pass the loop thread underneath this FCL, or sometimes you can use the artery forceps also to increase the space. So the this graft is easily passed under the FCL. Now I am passing this graft from distal to proximal. Okay, artery forceps. Now we have to dissect on the lateral aspect of the lateral femoral condyle. Usually, it is
what care do you take to?
Usually, it is attached at the level of distal Kaplan fiber. Or
where do you take to so that you
just lateral
coalition?
Proximal and lateral to the lateral head of the gastrocnemius, and there is a vessel. The very good landmark is there is vena communatis, which is easily visible here. यहाँ से लीजिए, ऊपर से। हाँ,
So what is the landmark you're using for the femoral insertion point?
my landmark is it is just proximal and lateral to the lateral head of the gastrocnemius, or during the surgery it is very easy to find out that vena communis, which is there on the lateral flare of the distal femoral condyle. Rotate करो ऊपर की तरफ, लाइट दिखाओ इधर से,
So what is the care we have to take so that we don't destroy our ACL tunnel?
We can check once I pass the guide wire. At the same time, check there is chance of tunnel collision while doing the ACL along with the LET. नीचे से, इधर से नीचे से rotate करो। See this is the, यहाँ पे focus करो। There is a leach of vessel visible here. Guide wire then. Guide wire. So this is my point of passing the guide wire. छोटा करो, छोटा। Sometimes there is a lateral genicular artery also. That's why it is better to use the cautery to clean that area.
Is there any specific direction?
Can you show the direction of
और भाग रहा है, वो नहीं है, कुछ है।
Cameraman, please zoom out a little.
लगा के दो तो, लगा के दो, भाग रहा है वो, ये ड्रिल गाइड चाहिए, दो जल्दी। नहीं नहीं, वो भाग जाएगा, वो फ्लेयर ऐसे होता है ना, दैट्स व्हाई इसलिए पे दो 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 डालो। So I am using this 4 mm of drill bit as a drill guide to pass the guide wire on the exact location where we have to attach this graft. अच्छा अच्छा अच्छा, सॉरी, इसको ऊपर रेडी, इसको निकालो ना। अच्छा, डालो डालो डालो, उसी ऊपर इसको कर देना। हाँ हाँ, ओके, चेक यस। चलो इसको खोलो। So we have passed the bit pin. Now I am drilling over the bit pin with 4 mm of the drill bit so that the thread is coming out on the medial aspect easily. Medially. Down. हम दिखाते हैं, इसको पकड़ो, इसको पकड़ो। पानी देना थोड़ा, वाटर वाटर प्लीज, वाटर प्लीज। हाँ, नहीं गया, नहीं गया। सो पानी का प्रेशर दो थोड़ा, दो, पानी बंद करो, अब बंद करो, थोड़ा ड्रिल करो वहीं से थोड़ा सा। ओके ओके, I think the guide wire is away from this tunnel. It is not. थोड़ा सा और साफ करो, और प्रेशर दो थोड़ा, हाँ 2-4 बार करो उसको, दिखा? Okay, it is visible.
Yes, yes.
Yes, there is no guide wire. Already I have passed this guide wire and drill over that guide wire with 4.5 mm of the drill bit. So there is no tunnel collision with the ACL along with this LET femoral tunnel. Okay. चलो 6 mm कर दे दो इसको, हटाओ. हो गया? पूरा हुआ नहीं? पूरा नहीं हुआ, हटाओ. चलो इसको पकड़ो.
Can we have the outside camera?
Outside.
Zoom कर दीजिए.
जल्दी निकालो. हाँ, निकालो, इसको निकालो. अच्छा, हम निकालेंगे. Forget. 6 mm. जल्दी 6 और 6.5. नहीं पकड़े रही. I am drilling over that guide wire with 6.5 mm of the. कितना है? हटाओ. Now thread. इसको हटाइए. छोड़िए इसको. नहीं इसमें नहीं जाएगा. इसमें नहीं जाएगा, नहीं. इस थ्रेड दो. अच्छा इसमें था. लगाओ 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 जल्दी लगाओ.
What is
Yes.
what is that outside you are holding on the medial side?
Medially, this is the already I have prepared the femoral, tibial, and femoral tunnel for the ACL, and we have passed that thread, and it is holding with the arthroscopy on the medial aspect of the leg. कौन सा? दो ग्राफ दो. कौन सा? क्या करना? कौन सा? हाँ ACL. Yes. So before fixing this LET, we have to complete the ACL. दो. So we have already prepared the femoral and the tibial tunnel. This is our femoral tunnel. It is.
So what was the diameter of the tunnel for LET?
6.5. 6.5 to 6 around.
And you'll be using a 7 screw, will it?
Yeah, my plan is to use. अरे इतना पानी कहाँ है तेरा? दो ग्राफ दो. दोनों फंसाओ ना. ग्राफ देखो. This is the graph we have prepared, है ना? दिख रहा है? चलो पास करो. I am passing the graph over this loop thread. हाँ धीरे धीरे लो इधर से लो. जाओ जाओ. देखते हुए ले जाना धीरे धीरे. चलो screw 9-10 का दे देना. So always in my practice I am using this method to see the button properly sitting on the lateral aspect of the thigh. Okay, okay. So now the button is flipped. So chalo pass karo. Yes, dance, but here I think this is the ultra button. Just a perception. चलो चलो खींचो. धीरे 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 धीरे.
Dr. Rajiv, please come over to the stage.
ठीक है. देखो वो देना. तो वो देना. ग्रास पर देना. क्या है? तो ग्रास पर तो.
हो गया. किसका बोला? सर का टॉक.
खींचो ना, हो जाएगा.
एक काम करिए आप बोलना, आप निर्मल को दे दीजिए.
चला एक मिनट, जस्ट मिनट. जाएगा. थोड़ा खींचो, बाहर है. हाँ ओके. ठीक है.
I call upon Rajiv sir Dr. Rajiv Raman, who's the pillar of arthroscopy in India. So,
yeah, screw
IOA, yes, now IOA secretary, he will be. So I call upon Professor Dr. Sudhir Kumar to please come over to the stage, and we have a small certificate of.
So we have already passed the graft through the femoral tunnel, and this is a case where there is some amount of fiber of the ACL is.
Dr. Rajiv Raman will felicitate Professor Dr. Sudhir Kumar. Thank you very much, Sudhir sir, for your kind support and for.
Hello, Rohit boss. Hello.
Very good. Congratulations, sir. Thank you. Dr. Abhinav Mishra, please come over to the stage. Very nice talk. Dr. Rajiv. Dr. Nirmal Kumar, is he here? Dr. Nirmal Kumar, please come over to the stage. He's our secretary, Jharkhand Orthopedic Secretary.
ACL में स्क्रू लगा देते ना,
इसमें
स्क्रू दे देते हैं.
Honored to have him in our event.
लो दो 10 mm का एक ही गड़बड़ है, एक ही था. चलो दो जल्दी दो ट्रॉली.
And I think 3 cheers and big clap for Rohit. He has organized this meeting. Congratulations, Rohit, for a wonderful show. I think 5 live surgery in 6 hours, not a matter of joke, and he has managed it very nicely. Thank you so much, Rohit, for organizing Ias One.
स्क्रू दो ना, हो गया, चला गया. दो स्क्रू दो ना, 10 9 से किया 10 देगा ना, 1 प्लस. थर्टी 30 खराब छोटा स्वेलिंग हो गया.
Hello. So can we have the light, please, in the operating room? We are not able to see.
We are fixing the ACL. Yeah, we are fixing the screw over the tibial tunnel.
Okay.
So I think we have finished the ACL reconstruction. Now I am going on the lateral side to fix the LED graft. चलो वो दे उसको बाहर आना उधर गाइड रिट्रैक्टर 90 retractor.
Anybody's watch?
7. 25.
Galaxy watch? Huh? Anybody who has forgotten to take his watch or her watch can collect from me. Call me.
नहीं जा रहा. जस्ट एक मिनट हमको थोड़ा कुछ देना, थोड़ा रिट्रैक्टर लगा ऊपर, पंच देना, टिश्यू है वहां पे. वेट थोड़ा सा टिश्यू पंच देना.
So have you drilled?
We have already drilled, and at the time of drilling we have seen there is no tunnel collision along with this
Do you check it with on image?
Yes, image. No, not image. I put the scope in the tunnel view in the
Okay.
from the
So
enter.
we are confident that there's no tunnel coalition, and this is a very good, very nice augmentation of ACL. I do it for in obese patient. All the obese patients, we do it LET. All the revisions we do LET. And as Dr. Gurudev mentioned, we can do it with sportsmen who are having contact, who are playing contact sports, high demand sports persons. You can protect your ACL by doing an LET.
Yeah. ठीक. Right for you.
Anybody wants to ask any question about ACL or tunnel or anything?
Good person. छोड़ी दो. हाँ, गया. ठीक. Okay. Yes.
Tendon transfer?
Yes.
We do tendon transfer, I don't know. Sir, please come over to the desk. We can have some insight on tendon transfers. Yeah, that is a very good thing. Tendon transfers for ACL instability. A very good question and very good answer by Professor.
Practically, this is a non-revealed secret. I have learned this technique long back. I think around in 90s, mid-90s, I learned this technique from one of my seniors. Very simple. And if I talk about this technique in front of the arthroscopic assisted surgery, probably I will be fooled by them. I will be fooled by them. But anybody wish to see the patient, we have got two patients right now in contact with me. And one patient is having a follow-up more than 20 years. Everyone knows about him. So, Pradeep जायसवाल जो प्रवीण ब्रदर्स वाले हैं, उनके बेटे को मैंने ऑपरेट किया था करीब 20 से 22 साल पहले. We have done a tendon transfer for this boy. He was playing, by the time he was playing the junior level cricket, the state of Jharkhand. Still he is playing, living a normal life without any instability, no problem, no symptoms. Another nursing staff who is working still with us. We have operated her around in 6 years back. She is having absolutely no problem. But once you are going to examine the patient, you might be able to elicit instability of the. I don't know whether I am right or whether they are better than us. Still, I used to do the very occasional tendon transfer in some of the patients. Partial ACL injury is there. So I don't have to cut the stump proximally and distally. Simply augment the surgery by doing a simple tendon transfer. If you are going to do this surgery with a small incision in front of the joint, it's a small one tendon grasper or tendon tunneler is required. Transfer the semitendinosus, make it intra-articular, and cut it at the site of the elevation over the medial part of the tibia. We have operated more than 400 to 500 patients, starting since the time of 90 to 93 से लेकर के करीब
मेजर करने से फायदा नहीं.
2014-15 तक मैंने किए होंगे 400 से 500 तक पेशेंट को ऑपरेट किया है. अब नहीं करता हूँ. Hardly I do the tendon transfer. Hardly I do the ACL. It's done by the other people. क्योंकि इसको मार्केटिंग हम नहीं कर सकते, बोल भी नहीं सकते, बता भी नहीं सकते. Nobody will believe me. And I don't have the documentation of that particular period. I have got a case-based follow-up on the long-term basis. At least 2 patients are there, 2 people are there. I can't say them the patient. They are in the regular contact with me. And they are leading a normal life. And tendon transfer is very simple, reliable. As you are going to do the tendon transfer in the other part of the body, you have to learn the basic principle how you are going to do the tendon transfer. Tomorrow we have planned one of the patient she has lost the anterior and lateral compartment of the muscle following the surgery. After the surgery, now there is no muscles are there on the anterior and lateral compartment. Patient is having a complete foot drop. So what we have planned for the TBH posterior transfer to the tendon to tendon transfer. And once you are going to do the proper tendon transfer, they are going to have the good dorsiflexion without injuring the anterior or distal part of the forefoot. So this is one of the technique, and still is applicable in the younger patient, the children, where you are suspecting the instability. In one of the patient who is having a congenital instability bilateral knee, he was operated around, I think around we have operated in 98. He was in follow-up for around 10 years with me. Till 2008, 2010 तक वो follow-up में थी. In the post-marriage period, once in a while, for some or other purpose. And post-operative, she was having a good stable knee on both sides.
Okay.
Tendon was intact, ACL was intact, but patient was having instability because of the hyperlaxity of this one. She was going in the recurvatum.
Hello.
Now she is having a stable joint. So this is probably one of the techniques, forgotten technique nobody is using, and I don't think this has been propagated by anybody across the country. But believe me, still it's very reliable surgery, like doing a shoulder surgery. A time-tested procedure is the bone block procedure, but hardly you are going to convince the patient to go for a small mini open surgery. If you are going to calculate the size of the incision, this much of the incision is required. You are only going to transfer the coracoid process in front of the glenoid. And one of the patients who was having a recurrent dislocation, bilateral shoulder, very heavy in the follow-up is more than around 17, 18 years follow-up now. Absolutely no problem, no limitation at the moment. So why to forget the time-tested reliable technique? It all depends on to some extent, depends on the marketing. सारे अच्छे सर्जरी भी हम लोग डिस्कार्ड करते हैं. क्यों करते हैं? No answer is there with me. I don't have a publication, so I cannot narrate my 30-year experience.
Hello.
Experience is important, but it's more important to document the fact, figure and publish it. Then only things are validated. I cannot validate my technique. Just to ask the question, sometimes I used to ask them, okay, ये सुनते हैं, होता था, एक बच्चों में किया जाता था. But nobody knows about the technique. Very simple, reliable, and fairly tested at the time. Very good for the Iceman patient.
Hello. Hello, Rohit sir.
Thank you very much, sir.
Hello.
And now we can go live.
Yes. Hello.
Again and see how well the ACL and LET has been done.
Hello. Hello. Hello, Rohit sir.
Dr. Gurudev.
Yes, sir. So we have finished both ACL and the LET. My scope is inside the knee joint. We can see here already we have fixed the graft, and this is the final picture. I am pressing the graft is so tight. And one thing special in this case is there is some fiber of the ACL is present or attached to the PCL. So I already kept these fiber intact on the tibial stump, and it acts like a necklace of this ACL. You can appreciate here, and it is not impinging. Extension karo. It is not impinging in the roof.
Do you want to debride the ACL from the PCL?
No, we are not going to debride because there is no impingement both on medial and lateral side. And this is the tightness of the graft. Now come on the lateral side. Lateral picture here. This is our mop retractor. This is the outside picture on the lateral side of the knee, and this is the LET structure, IT band, where we have fixed with the bio screw on the lateral aspect of the femur, and it is quite tight, and this is the final picture of the pivoting. Okay.
Good evening, Gurudev sir. Abhinav here.
So I think we have finished both LET and the ACL in this patient, and hope. Yeah.
Hello, Gurudev sir, can you hear me?
Yes.
Sir, good evening, sir. Abhinav.
Yeah.
Sir, my question was, we saw a decent amount of remnant remaining after ACL reconstruction. So is there any role of stitching the remnant to the graft, like, putting a fiber wire or something, so that
No.
it keeps it together?
You mean to say we have to fix this remnant to the ACL?
Is there any role of stitching it? I've seen a few.
Yes.
surgeons-
Yes, there is definitely a role of remnant preservation in the ACL reconstruction. Suppose in that case, if you put the scope in a couple of months, there is very fast vascularization of the graft, and there is very good amount of proprioception. That's why we are keeping this remnant of the ACL intact.
He's asking to stitch the graft.
No,
with
yes,
the-
sometimes we have to stitch if the remnant is falling back and it impedes the roof. In that condition, we have used a couple of stitches to stitch that graft with the remnant, but not in this case, not needed.
Only dropping the ACL,
So-
our reconstructed ACL, it is not falling back, it is not going anywhere. We don't think it's required.
So now we have come on the lateral side and closing the interval of this IT band, not in a continuous manner, just to interrupted suture. Otherwise, there is too much tightness of the lateral side of the knee, and it is highly painful. Yes. Dikrit. Any question, please?
Can the fascia lata be closed?
Yes, it is closed to the interrupted suture, not in the continuous manner.
So you just tag it.
Yes.
Okay, thank you, Dr. Gurudev. Now we are.
Thank you. Thank you, boss.
Huh?
Otherwise, herniation. Herniation.
नहीं, वो नहीं बोल रहा हूँ। ACL वो अभिनव जो पूछ रहा है।
नहीं करते हैं।
करते हैं।
हाँ, 30%.
हाँ यार।
Okay, great. Good work. So I call upon Dr. Sudhir Kumar, sir, please, once again. Please felicitate our star, Dr. Ayan, for his
Last time
contribution to
last
Indian Arthroscopy
pro हो गया
Society. Come, Dr. Ayan.
हाँ, ये कट pro हो गया। अच्छा और मिडिल वर्ड हम ग्राफ साथ ही लेंगे। नहीं लेना चाहिए। एक दो स्टिच
Thank you. हो गया ना? So we want to conclude now because all the surgeries are done. I thank Indian Arthroscopy Society and all of you who have contributed, Smith and Nephew especially, for the implants, for free implants of the patients. I thank all my seniors and my colleagues who have contributed, who have helped in the operating room so that we could finish about 5 plus 4 plus 1 multi-ligament. So you can consider multi-ligament as 2 cases. So we had 6 cases in about 6 hours. So that is commendable. Dr. Ayan, Dr. Abhinav Mishra, Dr. Ujjwal, Dr. Anup Nair, All of them were there ready to help our national faculty who had come all the way from Coimbatore, Kolkata, Mumbai. So we had a very good event yesterday and today. So I'm thankful to all of you. I hope I get more chance to organize something different. And Indian Arthroscopy Society will have more events now because Ias won this organization. They want to organize these events in at regular interval of time. Thank you very much, sir. Dr. Nirmal, please come over to the stage and conclude this session.
Thank you, Rohit sir. Thank you. So it was a wonderful academic congregation, I must say, and well attended. Definitely, to add to the icing to the cake was this numerous live surgeries which were wonderfully performed by arthroscopists of national and international repute. So I would like to extend our sincere thanks to the organizing secretary, Dr. Rohit Lal sir, for organizing and such a great event at Ranchi. And I would wish all the best to IAS. I mean, the way they are going ahead and trying to organize such events, even in cities beyond metros. So that is commendable. And definitely more of such academic events under whatever headings we have in future would be highly appreciable. So thank you all. Hope to see you again. A major kind of participation and big number in rest of our coming events also. And just to remind you all regarding our upcoming JoaCon, probably you all are already aware about JoaCon, which is upcoming March 9th and 10th. We have at Dhanbad. So I expect and invite you all to come and actively participate in JoaCon. So thank you so much.
So we want a group photograph or whoever. Nirmal, Ayan, on. Abhinav. Nayak sir, please come for a group photograph. Nayak sir, come for a group photograph. Sudhir sir, please come. Everybody come. We will have one group photograph. Please come.
सेंटर में ये रहे
ऊपर में है चाय पिलाएगा नहीं इसके बाद यहीं के ऊपर सर ऊपर आ जाइए
Okay. Thank you. Yes. मेरे मोबाइल में लिया था ना? Oh, sorry. चलो हो गया, हो जाएगा?
काम खत्म हो गया